This evergreen hillock is in the suburbs of the emerging metropolis of Kochi in Kerala. A blissful heaven of a close-knit community of happy and agile senior citizens. In a short span, since its genesis in the year 2011, has emerged as premium geriatric friendly seniors, about winning the accolades of many around the world. A highlight of blessed retirement living is that all the properties within the premises are scientifically and professionally designed for a cheerful retirement life.
നാശം.
കുറെ നേരമല്ലോ ചൊറിയാൻ തുടങ്ങിയിട്ട്. ഒന്ന് കുളിച്ചൂടെ?
ഓ, ചൊറിയണ വർത്താനം പറയല്ലേ ചേട്ടാ. ഇന്നലെ SI കോമള സാറിന്റെ വീട്ടില് പണിക്ക് ശേഷം തുടങ്ങിയതാ.
വെറുതെ അല്ല, വല്ല ആപ്പ ഊപ്പ പ്ലൈവുഡോ MDF ആയിരിക്കും. ഇനിയെങ്കിലും ജാക്ക്വുഡ് സൂപ്പർ ഡി ഹാർഡ്വുഡ് MDF ഉള്ളെടുത്ത് നീ പണിയാൻ പോകാവുള്ളൂ. അപ്പൊ പിന്നെ ചൊറിച്ചിലുമില്ല കരച്ചിലുമില്ല. സത്യം ഫോൺ അടിക്കുന്നു.
എന്റെ SI സാറേ, ഇനി ഞാൻ ആ വഴിക്കില്ലേ.
ജാക്ക്വുഡ് സൂപ്പർ ഡി, കരുത്തുറ്റ സൂപ്പർ സ്ട്രോങ് ഹാർഡ്വുഡ് MDF.
രക്ഷപ്പെട്ടോ? മണക്കാട് മണികണ്ഠന് മതം പൊട്ടി.
അയ്യോ,
എവിടെയെങ്കിലും പോയി ഒളിക്കാൻ നോക്ക്.
അതിന് ഇന്ത്യ എന്താ കാര്യം?
ഇതേ കണ്ട തല്ലിപ്പൊളി MDF അല്ല, ജാക്ക്വുഡിന്റെ സൂപ്പർ ഡി ഹാർഡ്വുഡ് MDF. ആനയല്ല, ദിനോസർ ആയാലും ചവിട്ടി ക്ഷീണിക്കത്തേ ഉള്ളൂ.
എന്ന് ഞാനും ഉണ്ടാകത്ത്.
ജാക്ക്വുഡ് സൂപ്പർ ഡി, കരുത്തുറ്റ സൂപ്പർ സ്ട്രോങ് ഹാർഡ്വുഡ് MDF.
എവിടെ പോയി? ഇവിടെ ഉണ്ടായിരുന്നല്ലോ.
നീ എന്തുവാടാ ഈ തപ്പുന്നത്?
ഈ റെയിൻകോട്ടിന്റെ തൊപ്പി ഉണ്ടോ?
തൊപ്പി തപ്പി സമയം കളയണ്ട, ദേ ഇത് കൊണ്ടുക്കോ.
MDF ബോർഡോ? ഇത് ഈർപ്പടിച്ച് നാശമായി പോവല്ലോ.
ഇതേ ജാക്ക് വുഡിന്റെ സൂപ്പർ ഡി ഹാർഡ് വുഡ് HDF ഈർപ്പം അടിച്ചാലൊന്നും ഇത് നാശായില്ല. നീ ധൈര്യമായിട്ട് കൊണ്ടുക്കോ.
എന്നാ ശരി.
ജാക്ക്വുഡ് സൂപ്പർ ഡി, കരുത്തുറ്റ സൂപ്പർ സ്ട്രോങ് ഹാർഡ്വുഡ് HDF.
Lifeguard Digital Health is proud to present Intellicare with life-saving alerts for senior facilities. The system has 3 parts: a state-of-art wearable device for the resident, a tablet for the resident within the senior facility premises. Intellicare sends emergency alerts for fall detection. When a resident falls, the watch will auto-detect the fall and the admin desk will receive the alert, so they can respond immediately. Intellicare has geofence alerts. If a resident leaves the facility premises, the staff will be alerted with the location of the resident and can communicate with the resident. Intellicare can monitor residents' vital signs. When a wearable device is worn by the resident, it monitors their vital signs and will report to the staff, so they can check on resident vitals anytime from the admin tablet. Staff and residents can message each other. Staff can message residents with important information. And residents can give feedback to staff. Finally, staff and residents can communicate with voice and video calls. Staff can call residents on their tablet in their room or on their wearable. In the event of an emergency, residents can call staff directly from the wearable at any time. Life-saving alerts for senior facilities. Intellicare powered by Lifeguard Digital Health Inc.
Autumn years in a person's life are equally to be cherished. Quite often, the hand that rocked the cradle is left clueless about how to live the rest of their lives. The reason may vary: the kin settling abroad, nuclear family preferences, or wanting personal space for them. These reasons contributed in the setting up of Atulya, a premium independent assisted living for the elderly. Based on the concept of harmonious community living, Atulya provides customized assisted living to its members. The homes are ergonomically designed, keeping in mind the needs of the elderly. Right from the carpet to the ceiling, the interior design has been crafted after conducting a thorough research on assisted living trends that are popular worldwide. The floors at Atulya are non-slippery. The state-of-the-art adjustable beds provide optimum comfort. Railings are provided wherever required, as we understand that even minor injuries may cause serious health complications. Emergency call buttons provided near the bedside ensures that precious time is not wasted in case of any medical emergency. Some of the unique features include round-the-clock medical care, providing healthy food options curated by dietitians. In addition,
From a humble beginning with just 2 residents, the facility today has over 130 residents from various walks of life, leading an active, healthy, and vibrant life in a community ambience. Most of them are retired personalities who had a successful stint in key positions in professional career in various parts of the country and abroad. Retirement living facility is not just one to provide shelter, food for the elderly. It should ideally be a facility that provides the best of care for the elderly to live a life of safety, comfort, happiness, and health. Bliss Retirement Living has been conceived and functioning with this very idea. Elderly living involves a host of aspects like institutional care, assisted living, care at home, elderly friendly gadgets and products to make the life of the elderly easier. Hospitals having specialized geriatric care departments and dementia care, etc. This conclave is also meant to provide an update on the latest research and welfare campaigns happening in various parts of the world for the benefit of the delegates and participants. It is heartening that several institutions and agencies involved in elderly care, a few United Nations institutions and agencies involved elderly care, ministers, people's representatives, academicians, experts are participating in this 3-day event. Also like organizations like Senior Living Association of Kerala, SLAC, and members of Association of Senior Living in India, ASLI, are also actively involved in this initiative. It is a matter of great pride that the founder chairman of ASLI and the presently its chairman emeritus, Mr. Mansoor Dalal, is the chairperson of this conclave. We also have in our midst Kerala's Industry Minister, Mr. P. Rajiv, Kerala's Higher Education Minister, Dr. Bindu, who also holds the charge of social justice, MPs, Mr. Benny Baganan and Mr. Haibi Eden, MLAs, Mr. Srinajan, Mrs. Uma Thomas, apart from around 50 experts from far and wide who will be presenting their papers. While extending a hearty welcome to all of them, I would also like to welcome members of the management of Bliss, staff, and the residents who are working day and night to make this conference a great success. Let me also point out that a conference of this kind, addressing all issues relating to elderly care, was a long cherished dream of Bliss, and I am so glad that our dream has come true today. Once again, a hearty welcome to one and all. Thank you very much. ശ്രീ ബെന്നി ബെഹനാൻ MP ഇവിടെ എത്തിയിട്ടുണ്ട്. അദ്ദേഹത്തെ സ്നേഹപൂർവ്വം ഈ സദസ്സിലേക്കും ഈ കോൺക്ലേവിലേക്കും സ്വാഗതം ചെയ്യുന്നു. എ ഹാർട്ടി വെൽക്കം ശ്രീ ബെന്നി.
Thank you, Babu sir. So like Babu sir mentioned, we have 3 days decked with delegates from all over the world, with speakers from all over the world, and also brands who have come and traveled to see all of you, to introduce themselves to all of you from all parts of the world. Now I would like to start by introducing someone to you who is very close to the conclave. The International Institute on Aging, United Nations, Malta, has been very kind, and we have been very honored to be associated with them for the 3-day conclave. Unfortunately, the representatives were not able to be here with us physically, but they have been very warm and kind to send in a message. We have Ms. Rosette Farrugia Bonella, who is the Deputy Director, who has sent in a message for all of you. Can I please have the video?
The International Institute on Aging, United Nations, Malta, is pleased to be collaborating with Blessed Retirement Living in organizing the National Conclave on Healthy Aging in Kochi, India. We are living in a period the demographers call the age of aging, with 1 in 9 persons in the world aged 60 years or over, projected to increase to 1 in 5 by 2050. Population aging is a phenomenon that we can no longer ignore. India, despite its young population, the size and percentage of older population have been increasing in recent years, and this trend is likely to continue in the coming decades. The United Nations projects that Indians over the age of 60 years will double by the year 2050, constituting almost 19.6% of the total population. Besides, according to the World Health Statistics of the 2021 report, it found out that in India, the overall life expectancy was at 70.8 years, but healthy life expectancy was 60.3 years, a trend common to other countries. Population aging is inevitable and irreversible demographic reality, which is associated with improvements in health, medical care, as well as decline in fertility and mortality. It is therefore important that all stakeholders, that is the government, civil society, and communities all over the world, perceive the increasing longevity as one of humanity's greatest achievements. Indeed, population aging is a cause for celebration. The opportunities that this presents are as endless as the contributions that our socially and economically active, secure, and healthy aging population can bring to society. However, opportunities come with challenges. Population aging presents social, economic, and cultural challenges to individuals, families, society, and global community. It is, however, how we choose to address the challenges and maximize the opportunities of a growing older population that will determine the future of mankind. In order to realize their right to enjoy the highest attainable standard of physical and mental health, older persons must have access to age-friendly and affordable health care information and services that meet their needs. There is also no doubt that an age-friendly physical environment that promotes the development and use of innovative technologies that encourage active aging is especially important as people grow old and experience diminished mobility and visual and hearing impairments. When we speak about age-friendly environment, we are not speaking only about the physical environment, but environment that includes our attitudes. Ageism, unfortunately, is still very much on the rise. COVID-19 pandemic has had exposed the seriousness of the situation. Ageism has never been so evident. Older people during this period are the ones who have been the greatest victims worldwide. Efforts to protect older persons, however, should not overlook the many variations within this category, their incredible resilience and positivity, and the multiple roles they have in society, including that of caregivers, volunteers, and community leaders. We must see the full diversity of people within the older persons category. It is time whereby ageism should be eradicated. It is time where policies on aging should be mainstreamed and planned through a life course perspective. The Madrid International Plan of Action on Aging and the political declaration adopted at the Second World Assembly on Aging in April 2002 marked a turning point in how the world addresses the key challenge of building a society for all ages. The Madrid Plan is a resource for policymakers, suggesting ways for government, non-governmental organizations, and other actors to reorient the ways in which their societies perceive, interact with, and care for their older persons. Moreover, it represents the first time that governments agreed to link questions to aging to other frameworks for social and economic development and human rights. Lately, WHO launched a decade of healthy aging. This is an opportunity to bring together governments, civil society, international agencies, professionals, academia, the media, and the private sector for 10 years of a concerted, catalytic, and collaborative action to improve the lives of older people, their families, and the communities in which they live. Lastly, while it is important to implement initiatives to address the concerns and challenges of an aging population, it is also important to go one step further to find ways to unlock the creativity and talents of older persons and to leverage on technology to enable population aging to age well and maximize their individuality, health, and longevity. All should adopt a positive attitude towards aging. Aging is not about decline. It should be looked at as a continuous growth and new opportunities. Allow me to close my short message with an appeal for active participation during this conclave and the follow-up initiatives which will take place. I am certain that this program will act as a motivator to enhance knowledge and to set the right environment for discussion and networking. It is important to make sure that the necessary action and implementation will be taken to better the lives of older persons, according to the realities of your respective countries and regions. Thanks for your attention.
നമുക്ക് നല്ലൊരു കയ്യടി കൊടുക്കാം. വീഡിയോ ആയിരുന്നെങ്കിലും സമയമെടുത്ത് നമ്മുടെ കൂടെ ഇവിടെ ഉണ്ടാവാൻ പറ്റാഞ്ഞിട്ടും ഒരു വീഡിയോ മെസ്സേജ് അയച്ചതിന് പ്ലീസ് ഗിവ് എ ഗുഡ് റൗണ്ട് ഓഫ് അപ്ലോസ്. And also I'm just giving a quick disclaimer. I will keep switching from English to Malayalam because though this is an international conclave, we are in Kerala, we have people here who understand Malayalam best. So I'll keep switching to both languages and I hope that's okay for everybody here. So now moving on, I have, like Babu sir mentioned, we have the Honorable MP with us. He was supposed to be our guest tomorrow for the function tomorrow, but due to his busy schedule, he'll not be able to be there tomorrow, but he has been kind enough to come by today and meet all of us and address all of us today. So എല്ലാവരുടെയും പേരിൽ ഈ തിരക്കിൻ്റെ ഇടയിലും സമയമുണ്ടാക്കി ഞങ്ങളുടെ ഇടയിലേക്ക് വന്നതിലും ഞങ്ങളോട് സംസാരിക്കാനായിട്ട് സമയമുണ്ടാക്കിയതിനും ഒത്തിരി നന്ദി. Ladies and gentlemen, please put your hands together for Mr. Benny Behnan, the MP, please.
Distinguished guest and my dear friend Mr. Babu, there had a confusion because which language I had to speak. But the Honorable this anchor said it is better to speak in Malayalam. I am here to apologize before you because my program is on tomorrow. But tomorrow I had some political assignment. I had to go to Bangalore, Karnataka in the evening. So I can't attend the meeting tomorrow, even though I want to be here because this healthy international conclave on healthy aging is organized by the Bliss. I had been several times in the Bliss, that is in my constituency. So I know the functions of the Bliss, the attitude and other things to the Bliss. So I am very much happy to be here. ബഹുമാനിലെ നമുക്ക് ഏറ്റവും കൂടുതൽ പരിചരണം കൊടുക്കേണ്ട, ശ്രദ്ധിക്കേണ്ട സമൂഹത്തിലെ ഒരു വിഭാഗമാണ് പ്രായം ചെന്നവർ. ആദരിക്കപ്പെടേണ്ടവരും ബഹുമാനിക്കപ്പെടേണ്ടവരുമാണ്. അവരെ എത്രമാത്രം നമുക്ക് ജീവിതത്തിൽ അവർക്ക് സന്തോഷം പകർന്നു കൊടുക്കാമെന്നതാണ് ആധുനിക സമൂഹം ശ്രദ്ധിക്കേണ്ടത്. ഇന്നത്തെ ആധുനിക കാലഘട്ടത്തിൽ കുടുംബ ബന്ധങ്ങളിലും സാമൂഹ്യ ബന്ധങ്ങളിലുമൊക്കെ ഉണ്ടായിട്ടുള്ള വ്യത്യസ്ത തലങ്ങളായ മാറ്റങ്ങൾ, പഴയതുപോലെയുള്ള പരിചരണങ്ങളും ബഹുമാനവും പലപ്പോഴും മുതിർന്ന തലമുറയ്ക്ക് ലഭിക്കാതെ പോകുന്ന ഒരു സാഹചര്യമുണ്ട് എന്ന് ഖേദത്തോടു കൂടി ഞാൻ സൂചിപ്പിക്കുകയാണ്. അതിനാരെയും കുറ്റപ്പെടുത്തിയിട്ട് കാര്യങ്ങൾ ജീവിത സാഹചര്യങ്ങൾ ഉണ്ടായിരിക്കുന്ന മാറ്റങ്ങളാണ്. നമ്മുടെ സമൂഹം പലപ്പോഴും കുടുംബ ബന്ധത്തിൽ അധിഷ്ഠിതമായ സാമൂഹ്യ ജീവിതക്രമം ഉയർത്തിപ്പിടിച്ചവരാണ്. പക്ഷേ ആ കുടുംബ ബന്ധത്തിൻ്റെ പവിത്രതയും അതിൻ്റെ വൈകാരികതയും പഴയതുപോലെ പലപ്പോഴും ഉണ്ടായിട്ടില്ല എന്ന ഒരു പശ്ചാത്തലമുള്ളതുകൊണ്ട് മുതിർന്ന തലമുറയിൽപ്പെട്ട ആളുകൾക്ക് പല കാരണങ്ങൾ കൊണ്ടും ആ ഒരു പരിചരണം ലഭിക്കാതെ പോകുന്നു എന്ന യാഥാർത്ഥ്യമുണ്ട്. അങ്ങനെ വരുമ്പോൾ അവരെ ശ്രദ്ധിക്കേണ്ടതും സംരക്ഷിക്കേണ്ട ഉത്തരവാദിത്തം സ്വാഭാവികമായും സമൂഹത്തിനുണ്ട്. നമ്മുടെ നാട്ടിലിപ്പോൾ ഒത്തിരി ഓൾഡ് ഏജ് ഹോംസ് ഉണ്ട്. പക്ഷേ ബ്ലസ് എന്ന് പറയുന്ന സ്ഥാപനവും നിങ്ങളുടെ ഈ കോൺക്ലേവിൽ ചർച്ച ചെയ്യപ്പെടുന്ന കൺസെപ്റ്റ് ഓൾഡ് ഏജ് ഹോമുമായി ബന്ധപ്പെട്ട തലത്തിലുള്ളതല്ല, കുറച്ചും കൂടി വിശാലമായി റിട്ടയർമെൻറ്റ് ജീവിതം എങ്ങനെ സന്തോഷത്തോടുകൂടി സംതൃപ്തിയോടുകൂടി ജീവിക്കാൻ കഴിയും എന്ന പുതിയ കാഴ്ചപ്പാടിൽ അല്ലെങ്കിൽ വ്യക്തമായ കാഴ്ചപ്പാടിൽ ആണ് നിങ്ങൾ ഇത്തരത്തിലുള്ള ഇൻ്റർനാഷണൽ കോൺക്ലേവ് സംഘടിപ്പിച്ചിരിക്കുന്നത്. നമുക്കറിയാം, ജീവിതത്തിൻ്റെ പ്രായം ചെന്ന ആളുകൾക്ക് ഒട്ടേറെ അനുഭവങ്ങളുണ്ട്. ആ അനുഭവങ്ങൾ നമുക്കെങ്ങനെ പ്രയോജനപ്പെടുത്താം, ആ അനുഭവം നമുക്ക് സമൂഹത്തിന് എങ്ങനെ പ്രയോജനപ്പെടുത്താം, അത്തരം കാര്യങ്ങൾ ഇത്തരം കോൺക്ലേവിൽ സ്വാഭാവികമായും ചർച്ച ചെയ്യപ്പെടും. ഒരു വർഷം മുമ്പ് എൻ്റെ സ്നേഹിതൻ ശ്രീ ബാബുവിനോട് ഇന്ത്യയുടെ പാർലമെൻറ്റിൽ പുതിയൊരു നിയമനിർമ്മാണം ഈ പ്രായം ചെന്നവർക്കും റിട്ടയർമെൻറ്റ് ജീവിതത്തിലേക്ക് കടക്കുന്നവരുടെയും സാമൂഹ്യ സുരക്ഷയ്ക്കും ജീവിത സുരക്ഷയ്ക്കും വേണ്ടിയിട്ടുള്ള ഒരു ബില്ല് കൊണ്ടുവന്നപ്പോൾ ഞാൻ ആദ്യം അതിനുള്ള നിർദ്ദേശങ്ങൾ ചോദിച്ചത് ശ്രീ ബാബുവിനോടാണ്. പക്ഷെ നിർഭാഗ്യം എന്ന് പറയട്ടെ, ആ ബില്ലിൻ്റെ സജീവ പരിഗണന പാർലമെൻറ്റിൽ വന്നിട്ടില്ല. ഞാൻ ഇന്നും എൻ്റെ സ്നേഹിതൻ ശ്രീ ബാബുവിനോടും സുഹൃത്തുക്കളോടും പറഞ്ഞു, ഈ കോൺക്ലേവിൽ നിന്നും ഉരുത്തിരിഞ്ഞു വരുന്ന നിങ്ങളുടെ വിലപ്പെട്ട നിർദ്ദേശങ്ങൾ എനിക്ക് തരണം. ഒരു പാർലമെൻറ്റ് മെമ്പർ എന്ന നിലയിൽ അടുത്ത പാർലമെൻറ്റ് സമ്മേളനം നടക്കുമ്പോൾ ഔദ്യോഗികമായി ബില്ല് വന്നില്ലെങ്കിലും ഒരു പ്രൈവറ്റ് ബില്ലിലൂടെയെങ്കിലും ആ നിർദ്ദേശങ്ങൾ ബഹുമാനപ്പെട്ട കേന്ദ്ര ഗവൺമെൻറ്റിൻ്റെ മുന്നിൽ കൊണ്ടുവരാൻ ഞാൻ ശ്രമിക്കും. അത്തരം കാര്യങ്ങളിൽ നമുക്കെന്ത് ചെയ്യാൻ കഴിയുമെന്നുള്ള കൂട്ടായ ചർച്ചയുണ്ട്. അതോടൊപ്പം തന്നെ പറയുന്നു, ഈ കോൺക്ലേവിൻ്റെ തീരുമാനവുമായി ബന്ധപ്പെട്ട് നിങ്ങളെടുക്കുന്ന തീരുമാനങ്ങൾ കേന്ദ്ര ഗവൺമെൻറ്റിൻ്റെ ശ്രദ്ധയിൽപ്പെടുത്തണമെങ്കിൽ ഐ ഇൻവൈറ്റ് my friend Babu Joseph and others to come to Delhi. We can meet the concerned officers and the concerned minister there and we can discuss it. നമുക്ക് അങ്ങനെ എന്തെങ്കിലും ഒരു പ്രയോജനം കിട്ടുമെങ്കിൽ അതിനു വേണ്ടി ശ്രമിക്കാം എന്ന് കൂടി പറയുകയാണ്. നമ്മളുമൊക്കെ ബാബു 70 വയസ്സ് കഴിഞ്ഞു കേട്ടോ. ബാബുവിനെ കണ്ടാൽ തോന്നുമില്ലെങ്കിലും എനിക്ക് 70 വയസ്സായിപ്പോൾ. അതുകൊണ്ട് നമ്മളുമൊക്കെ റിട്ടയർമെൻറ്റ് ജീവിതത്തിലേക്ക് കടക്കുന്നവരാണ്. അപ്പോൾ നമ്മളുമൊക്കെ സമൂഹത്തിൽ നമുക്കെന്താ വേണ്ടത്? ഒരു സാമൂഹ്യ ജീവിയായ നമുക്ക് മറ്റെന്തിനേക്കാൾ കൂടുതൽ വേണ്ടത് നമ്മൾ ഒറ്റപ്പെടുന്നില്ല എന്നൊരു ഫീലിംഗ് ആണ്. സമൂഹത്തിൽ നമ്മൾ ഒറ്റപ്പെട്ടു പോകുമ്പോഴാണ് നമ്മൾ അസ്വസ്ഥരാകുന്നത്, നമ്മൾ ഫ്രസ്ട്രേറ്റഡ് ആകുന്നത്. പലപ്പോഴും ഇന്ന് കണ്ടുവരുന്നതാണ്. അതുകൊണ്ട് പ്രായം ചെന്നവർ സമൂഹത്തിൽ ഒറ്റപ്പെട്ടവരല്ല, അവർ സമൂഹത്തിൻ്റെ അവിഭാജ്യ ഘടകമാണ്. അവരോടൊപ്പം സമൂഹം നിൽക്കുന്നു. അവരുടെ കുടുംബാംഗങ്ങൾ മാത്രമല്ല, ദ സൊസൈറ്റി മൊത്തം അവരുടെ കൂടെ നിൽക്കുന്നു എന്നൊരു ഫീലിംഗ് അവർക്കുണ്ടായാൽ ചെറുപ്പക്കാരേക്കാൾ കൂടുതൽ ഒട്ടേറെ ബുദ്ധിപരമായും മറ്റ് രീതിയിലും സംഭാവന നൽകാൻ കഴിയുന്നവരാണ് നിങ്ങൾ എന്ന പൂർണ്ണ വിശ്വാസമുണ്ട്. അത് നടപ്പാക്കാൻ നിങ്ങൾക്ക് സാധിക്കട്ടെ. ഇവിടെ വന്നിരിക്കുന്ന മുഴുവൻ ഗസ്റ്റുകൾക്ക്, നോട്ട് ഓൺലി ഫ്രം കേരള, ഔട്ട്സൈഡ് കേരള ആൻഡ് ഇൻ്റർനാഷണൽ ലെവൽ ഇവിടെ വന്നിരിക്കുന്ന എല്ലാവരെയും അഭിവാദ്യം ചെയ്യുന്നു, ആശംസകൾ നേരുന്നു. നാളെ വരാതിരിക്കുന്നതിന് ഒരിക്കൽ കൂടി ഞാൻ നിങ്ങളുടെ ക്ഷമാപണം നടത്തുന്നു. ഇങ്ങനൊരു അവസരമുണ്ടാക്കി തന്ന സംഘാടകരോട് നന്ദി രേഖപ്പെടുത്തിക്കൊണ്ട് ആശംസകൾ നേർന്നുകൊണ്ട് എൻ്റെ അറിവിൽ ഇത്തരത്തിലുള്ളൊരു കോൺക്ലേവ് ആദ്യമായിട്ടാണ് സംഘടിപ്പിക്കുന്നത്. ആദ്യമായി ഇത്തരം ഒരു കോൺക്ലേവ് സംഘടിപ്പിച്ച ബ്ലസ്സിനെ കൂടി അഭിനന്ദിച്ചുകൊണ്ട് എൻ്റെ ചെറിയ വാക്കുകൾ നിർത്തുന്നു. നിങ്ങൾക്കെല്ലാവർക്കും നമസ്കാരം. ജയ് ഹിന്ദ്.
ശ്രീ ബെന്യാമിൻ സാറിന് ഇന്നത്തെ കോൺക്ലേവിൻ്റെ പേരിൽ ഒരു മൊമെൻറ്റോ കൊടുക്കാനായിട്ട് ഞാൻ ബാബു സാറിനെ വേദിയിലേക്ക് സ്വാഗതം ചെയ്യാണ്. Thank you once again, Mr. Benivanan, sir, for your time and for being present here with us. So, like we mentioned before, we'll be meeting a lot of interesting people today, tomorrow, and day after as part of the conclave. And I would like to start with introducing one of those interesting brands that, to be very honest, not even I was aware of. But when you get to know them, you understand what a necessity each single brand here today is. I would like to call on stage Mr. Jeff from Lifeguard product for the demonstration of their lovely brand. So can I please have you on stage? He is the expert. He will know exactly what to tell you and how to introduce his brand to you. So the stage is all yours.
Good morning, everybody. First of all, I'd like to thank everybody here for having us. We came from Canada. This is our second time visiting Kerala. We have had the ultimate best time here both times. We've been so grateful for the way that everybody's treated us. We have a very special thank you to Bliss Homes, who has sponsored us 2 times. And we would like to also thank them for allowing us to be part of a 1-year trial where we're going to be showcasing our products at Bliss. And we are going to be having a person from our team on site there for the full time. So Lifeguard will be integrating itself and our company here. We believe that this market for our company is one that we absolutely have to be part of. We think that our products can help the people and citizens of India, and we're going to show a little bit about that today and some of the products that we've introduced and we've built to help specifically in seniors care. I'd first like to introduce our team and our Lifeguard team who obviously came with me and who will be helping through the demonstration today, who will be answering a lot of your questions. First of all, I'm not the expert, they am. I just get to talk. So any of the expert questions will come from my team there. First, I'd like to introduce Fern Hardy. Funny, she has the same last name. She happens to be my wife and my partner. So that's Fern. I would also like to introduce Chandana. Stand up, Chandana. So Chandana is probably, the reason that we actually ended up here. She has her mother who is a resident of Bliss, who we love. There she is. She's our big star, and all the other people there we've come to know and love. And the second time, I guess yesterday, a few days ago we showed up, and when we walked through the door, it really was like coming home. The people were so great to us, and we're so grateful. So what is Lifeguard Digital Health? So Lifeguard, I founded Lifeguard and incorporated Lifeguard in 2017. And we have a few different platforms, but our main platform that we're going to be talking about today was really developed during COVID. And when everybody in every country around the world, senior citizens were hit extremely hard during COVID. Not just physically and getting COVID, but also dealing with mental and physical stress, being locked in their rooms, not locked in their rooms, but being confined to rooms, not being able to talk to friends and family, not having a way of communicating, and staying safe. What Lifeguard does in a summary is we specialize and have developed technology, simple and easy to use, that will bring emergency services, friends and family, to people that are in distress. That's what we do. We bring help if you're in distress. It really doesn't matter what happens. All of our products work in different markets, but we're going to talk about how that's actually affected in the seniors care community and how Lifeguard with its products specifically target seniors and bringing help to them and making their life easier and safer. Just to make sure we're all on the same page, Intellicare, which is of course our seniors care product, it was designed specifically for seniors care community and was built off of another product that we use in other different communities. So what we're going to be able to show you today and tomorrow and the next day, how does Lifeguard Intellicare manage alerts when alerts are provided when someone's in distress? And that's really what we do best. We manage alerts, we bring help to people when people are in trouble. So that's what we're going to show today. We're going to go through a bit of a demo. And what I'd like to do first is we've created a video that will illustrate all of the different pieces that come with our product, the different features that it has in the products. And we've divided up the features in two ways. The features and benefits for clients and the features and benefits for staff, residents, and nurses. So they're the same system, but they work different. And once you see the video, you'll understand what I mean. So Shivari, oh, here we go. Are we going to start from the beginning? There we go.
For senior facilities, the system has 3 parts: a state-of-art wearable device for the resident, a tablet for the resident apartment, and a monitoring tablet for the staff. Staff will receive emergency alerts from residents and communicate with them wherever they are within the senior facility premises. Intellicare sends emergency alerts for fall detection. When a resident falls, the watch will auto-detect the fall and the admin desk will receive the alert, so they can respond immediately. Intellicare has geofence alerts. If a resident leaves the facility premises, the staff will be alerted with the location of the resident and can communicate with the resident. Intellicare can monitor residents' vital signs. When a wearable device is worn by the resident, it monitors their vital signs and will report to the staff, so they can check on resident vitals anytime from the admin tablet. Staff and residents can message each other. Staff can message residents with important information. And residents can give feedback to staff. Finally, staff and residents can communicate with voice and video calls. Staff can call residents on their tablet in their room or on their wearable. In the event of an emergency, residents can call staff directly from the wearable at any time. Life-saving alerts for senior facilities. Intellicare powered by Lifeguard Digital Health Inc.
Okay, thank you for that. Appreciate it. So this gives you a really high-level description of how our product works. What we're going to do now is we're going to actually go into and talk about each feature and give you some more detail on how they actually work and can work for yourself. The product itself, it can work at any level of care. So it can be customized and can be catered to individuals and to staff. And it doesn't necessarily have to be exactly how you see it. But what we're going to do is, as I said, we're going to go through each feature and we're going to show. And if you guys want to, after this presentation, want to come to the booth, we'd be more than happy to talk you through some of it. So as it showed on the video, each client receives a tablet and a wearable. And that is the system that comes automatically complete. We design our products from scratch up. We have them manufactured, so they're specific to this solution and this particular product. That goes equal for the staff resident tablet. So all of them work together and they all communicate together, and there's no substitutions. It all works as an ongoing system that works all together. The first piece I want to talk about is the resident tablet. So resident tablets will do a few different things. The resident tablet will allow you to communicate, whether it's through audio or video, to the front desk. And I want to tell you where this really came really important, and it's not just a feature that is used on a day-to-day basis. When COVID came out, and I talked a little bit about how people were affected mentally and their mental health and also physically. So when that came about and we started to develop our platform, we wanted to make sure that even if you were confined to a room, then you were able to communicate, whether it be with staff, with other people in the building, with your friends or family. So now, rather than being confined to your room and not being able to see any of your loved ones, now you can obviously not see them physically, but mentally and through the voice and audio, you can actually talk to them through the tablet. Messages from staff to clients. So a couple of examples are if your son or daughter had called and you'd missed the call, and they called to Bliss, for instance, they would send a message to you and say, okay, your son or daughter called at 6 o'clock, they would like you to call back. The other thing which showed up here, it can give you a recommendation of an announcement of what's going to happen for dinner tonight. So my new favorite is Kerala curry chicken. I had it yesterday, and so that might be an example of something that the dinner is going to be tonight at one of the care facilities. The really important thing to understand as you're walking through this presentation and come and see us at the booth, there are a lot of devices on the market. There are a lot of different companies that are bigger than ours, that are more well-known than ours, but I want to be extremely specific. We are the only company in the world that manages alerts the way we do. The alerts that go to the front desk can also utilize our patented technology, which that alert can then be directed specifically and directly to emergency services. So let me give you a bit of an example. If you had a crisis in your bedroom or outside, and the watch detected that, sent a message to the front desk, they communicated with you, you didn't answer. So through the geofence and through different ways of being able to locate you, there could also be an ambulance that's on the way to help you. So the way we manage alerts, we are the only company in the world that does it this way and works specifically in seniors care communities. Not Apple, not Google, not a lot of the names that you've heard. Remember Lifeguard. Lifeguard is the only one that works this way. The second part I want to talk about is the resident watch. And we've had, like I said, we've done lots of presentations. And one of the questions we always get is, well, I have an Apple Watch or I have an Android watch. Why can't I use that? And I'm going to be completely honest with you and tell you that when we started Lifeguard, we tried using different types of watches. We tried to adapt them. We tried to redevelop them, and we just couldn't get the results from off-the-shelf products as we could when we developed our own. So our products that you receive are completely customized. They contain only the features that are most important to seniors, and that is how our product has been built. Some of the things that the wearables will do that are unique as a solution, first of all, it will monitor your vital signs. So whether it be heart rate or blood pressure, if it becomes to a dangerous level, there's an automatic alert that gets sent again, not just out on the cloud, it goes directly to the front desk. Once it goes to the front desk or to admin or to a nurse's station, they then have the ability to decide how are we going to respond to this particular client. The next feature I wanted to talk about is geofence. Now, when we were blessed last time, and we were visiting a lot of the people that live there, we were introduced to a man there that I'm not going to mention any names, but I'll tell you the situation was there why geofence was a perfect fit for this person. So this particular gentleman at Bliss had some dementia, and because of that, his freedom to walk around and to leave the premises they could do that, but they had to be mirrored with a staff person. So how geofence works is we can actually create a digital fence, any size that you want, so it allows any person to move around freely, and if you for some reason go outside of the geofence, it then sends that alert again back to the front desk. At that point, they can communicate back to you. How are you? Do you need help? Would you like us to come and get you? The watch will also give the GPS location so that we have accurate instructions of how to find you. So again, Lifeguard, all the alerts, we're able to deal with it, get to you anytime you're in crisis. Once again, we have the audio visual. So the audio visual on the watch, same as the tablet, we can move back and forth in terms of sending messages, talking back and forth. You're completely in connection with the front admin, a nurses panel, or we can actually set it up so that you can talk to your children, friends and family. So again, customizable. I think what I'm going to do is we're going to open up for any questions. We're going to allow people in a few minutes to come and see the stand and come and ask some more questions. We've got everything set up there. We have the tablets set up. We have the watches set up. Please feel free to come by. Please feel free to ask all your questions. Ask any of the ones that you like, what you don't like. If you think our product could do certain things and make it better, please tell us, and that's why we're here today. But the other reason we're here today, obviously, to share this technology, and through this trial that we're at Bliss, and again, thank you so much for them for having us, we're going to show and prove to everybody how this technology can actually save lives. Lifeguard itself, if you go to our webpage, we've saved 65 lives through our different platforms. Extremely proud of that. And we're going to continue not only to save lives, but to make lives, again, safer and easier. So thank you so much for having us. We'd love to see you at our booth. And if there's any questions, I'd be more than happy to answer them, or come and see us at the booth. Any questions? Okay, claps are good. Thank you so much, everybody. Obviously, Lifeguard right here. Again, my name's Jeff Hardy. Happy to take any of your questions. All good? Okay, we'll save them all up for the booth. Thank you, everybody.
Thank you, Jeff. Thank you, Lifeguard Digital, for everything that you do, for saving lives, for making lives easier, and we really hope you keep doing what you're doing. ഒന്നും കൂടി പറയാണ്, ആ പ്രോഡക്റ്റിനെയും അവരുടെ ബ്രാൻഡിനെയും കുറച്ചും കൂടി നന്നായി അടുത്തറിയണമെന്നുള്ളവർ, they will be there. Please do go and talk to them. Please do try to understand how they function. നിങ്ങൾക്ക് കുറച്ചും കൂടെ പ്രാക്ടിക്കലിലേക്ക് വരുമ്പം questions ഉണ്ടാവാം, concerns ഉണ്ടാവാം. I think the experts are there to address it. So please do reach out to them. Thank you so much once again. And next, I would like to call up somebody or a brand again that is really, really interesting. And നമ്മളെല്ലാവരും കുറേ കേട്ടിട്ടുള്ള ഒരു കാര്യമായിരിക്കാം, but I did not really know unless and until I had a deep conversation with him a couple of minutes ago, how versatile this segment really is. So I would like to invite Mr. Mache, did I get that right? Mr. Mache from Seni Products to please address the gathering.
Oh, it's okay, it's fine. Dear honorable distinguished guests, ladies and gentlemen, good morning. My name is Maciej Długos. Today I will have an honor to represent Tezatomo India, Tezatomo Group in India to this Festival of Knowledge. But in the very beginning, first let me start this presentation with expression of gratitude, because I'm grateful for all the presence of so many people today here, so many people who are concerned about healthy aging. When I met Bliss family a few months ago, I knew that this team is special and they go for very sophisticated, beautiful projects. And I've seen Bliss retirement living, and I was not having dreams, even dreams that such a beautiful conference, Conclave, will happen. So, Bliss family, thank you for an opportunity to be with you today. But before going further into the presentation, few information about Tezatomo Group. Tezatomo Group was created, the company, mother company was created more than 70 years ago in Poland, in Europe. And from a small dream and from a wish and a dream, the company has grown, and currently we are supplying our products to over 80 markets all around the world. And the products which we supply are with the users from the very first days of life. We believe that the support of the users can be done to the whole life. So the products which we supply are, you can see in the slide that we supply products for babies, baby diapers, even for the smaller premature babies with the weight of 600 grams, we supply such sophisticated products. So we supply products for women, sanitary napkins, sanitary pads, panty liners. When the beautiful stage of life, the stage when the baby is born happens, we supply ladies with maternity pads, with breast pads. And of course, when the time passes and there is a need for solutions to take care, to support problems of bladder weakness, we are also there, and we have products dedicated for women, for men, which are definitely not diapers, right? The diapers come next. We have products as well for bedridden patients, diapers and pull-ups, but during this presentation I would like to try to convince you that the diapers are last resort, and there are other options to deal with bladder weakness, with incontinence issue, with more economy and more discreet way. The project and the proposal which I would like to introduce to you is a Continence Care program. It's a program which is centered on the person, and the approach to care a person with premium products. Sometimes when we speak about premium products, in the picture there comes the area of costs, but I would like to show you that there are some significant advantages of using premium product. They can reduce the cost, take costs under control. And the costs are not only the picture. We should also speak about comfort, about confidence, and then satisfaction of the users. So there are four pillars of the Continence Care program. One was mentioned. The one was the comfort and confidence of the users. But when the user is confident and happy, the family is happy. And if family is happy and the caregivers around are happy, we can have better health outcomes. The products which we provide have a unique features of breathability. They allow air to pass. There is a free, the air passes freely, so the humidity level in the intimate area is reduced. It influences greatly the skin condition. So we can say that our products are skin friendly. And the last pillar which you see in the slide is significant cost savings. When you use the premium product, you use, simply speaking, less. And then at the end of the day, the number of products which are premium, they are pocket friendly. So if we speak about the Continence Care program, we speak about benefits for residents, benefits for the users. First of all, if there is a challenge of bladder weakness, definitely it creates some kind of an invisible leash to home. We would like the users of our products to enjoy life and have the ability to perform daily tasks without any compromises. We would like the users of the products to have a good sleep, because if the sleep is not interrupted and you can have a safe sleep whole day, the next day will be a good day. And if we speak about quality products, premium products, it all reflects in the skin condition. There are a lot of conversations about bad sore prevention or irritations and inflammations that happen when you use a product of a low quality. This all can be minimized if you use SENI. There are many benefits, right? But let's highlight the most important one. Going further, if we speak about caregivers, If you use a product which is easy to be put on and easy to be taken out, there is a less work involved from the caregiver side and the less the risk of injuries for them. If the concern about the skin is less, the work of a caregiver is easier. And if you need to replace the product during a day in lesser number of times, the time consumption for one patient, for one caregiver, at the end of the day is less. And you can spend this time on the more quality tasks with your residents. And this is quite important. And when we speak about benefits for the community, you can group them into two groups. One group is obviously connected with the happiness, confidence of the resident and confidence of the family, because happy residents, they reflect their opinions to the families. So this, of course, builds the prestige of the community. But second group of the benefits connected with the costs, right? I've spoken about the costs a few times today. But the main goal of creating a community is based on happiness of residents, and it's based on happiness of families and happiness of caregivers. So the main goal is just creating a home. When we speak about premium products and the price concerns comes into the picture, I would like you to think about a day, because it all matters what is the cost, what is the price at the end of the day. We would like our partners to give a chance to the product and check what all expenditures are done within the 24 hours period for a patient, within a 7 days hour period for a patient, and most probably within a year period for a patient. And we believe that based on our experience with old age homes across the world, the number of diapers you will use a day, the number of underpads you will use a day, the number of gloves you will use a day, the number of time you will spend a day with the patient will be less. And you can use this time and those resources in a different way. And this is the main goal of a continence care program, to combine benefits from different approaches. But when we speak about continence or incontinence, bladder weakness, I would like to highlight one very important point, that bladder weakness has a name. There is a patient behind bladder weakness. So every patient may have different level of problem. And we should support and compensate the problem with the different products. SENI has a wide range of the products. I will try to show you this within the next few minutes. We speak a lot about bladder weakness because it's in our blood. We provide products which support bladder weakness issue, but sometimes it is good to speak about healthy situation. Every of us drinks approximately 30 milligrams of water for every kilogram of our weight. So it will give you around 2.5 liters of water that we drink a day on average. 70% of this, simply speaking, will be urinated, and we will visit the toilet around 6 times during the day. So when we speak about incontinence issues, we speak about levels of incontinence, because between one visit to the restroom and second visit to the restroom, there is some time. And in this time, we can control bladder or not. And depending on the level of this control, we can speak about light incontinence, we can speak about moderate incontinence, you can speak about heavy, severe incontinence issue. So when in this period between one visit and a second visit to the restroom, this 4-hour period, on average, we speak about loss of urine droplets of around half of the glass. It's estimated that this issue will be called light incontinence issue. If it will be one glass, moderate. If this will be many glasses, or there is totally no control over the bladder, it will be severe and heavy incontinence level. Why it's so important to speak about it? Because the range of the products which are available is vast. And especially for light and moderate incontinence, we do not suggest diapers and we do not suggest pull-ups. There are products which compensate light and moderate incontinence effectively, and they are skin friendly, they are breathable, they are light, they are discreet, and they are pocket friendly. They are economic ones. So today I tried to show you that Tezatamo Group supports their users from the very early stage of life till the elderly time. I wanted to show you that using a premium product, if you will consider 24 hours approach, 24 hours summary of all expenditures, and you will see the price at the end of the day, the premium product can be, in fact, economy one. I wanted to tell you that the phrase that the bladder weakness has a name. There is a patient behind any bladder weakness issue. And you can supply the patient, support the patient with the dedicated product, which will be economy one if you will align it correctly with the level of the weakness, bladder leakage. And I wanted to convince you that the diaper is a last resort, especially for a bedridden patient. It's a last resort, but there are options which are more discreet. We will be there with you for the next 3 days with a sunny booth there with a group of professionals from our company. If there are any questions that may arise that you have, please kindly visit us there. We are there for you. Once again, thank you all and thank God bless for the opportunity to be with you today. Thank you.
Thank you, Mr. Mache. Premium and pocket-friendly sure does sound like something we all like. So again, once again, I request all of you, when you have the time, to please go and speak to them and get to know their brand a little bit more. ഇനി അടുത്ത ഒരു സെഷനിലേക്ക് കടക്കുന്നതിന് മുന്നേ, ഇൻട്രാക്റ്റീവ് സെഷനിലേക്ക് കടക്കുന്നതിന് മുന്നേ, എല്ലാ പ്രായക്കാർക്കും ഇഷ്ടമുള്ള ഒരു ചെറിയ പരിപാടിയിലേക്കാണ് നമ്മൾ കടക്കുന്നത്. നമുക്ക് എല്ലാവർക്കും ഒന്ന് ചായ കുടിച്ചിട്ട് വരാം. There is tea ready outside. Please go ahead, grab a cup of tea, get to know each other, and we'll all be back here within half an hour. ഒരു അരമണിക്കൂറിൽ നമുക്ക് അടുത്ത സെഷനിലേക്ക് കടക്കാം. Please enjoy your break.
Autumn years in a person's life are equally to be cherished. Quite often, the hand that rocked the cradle is left clueless about how to live the rest of their lives. The reason may vary: the kin settling abroad, nuclear family preferences, or wanting personal space for them. These reasons contributed in the setting up of Atulya, a premium independent assisted living for the elderly. Based on the concept of harmonious community living, Atulya provides customized assisted living to its members. The homes are ergonomically designed, keeping in mind the needs of the elderly. Right from the carpet to the ceiling, the interior design has been crafted after conducting a thorough research on assisted living trends that are popular worldwide. The floors at Atulya are non-slippery. The state-of-the-art adjustable beds provide optimum comfort. Railings are provided wherever required, as we understand that even minor injuries may cause serious health complications. Emergency call buttons provided near the bedside ensures that precious time is not wasted in case of any medical emergency. Some of the unique features include round-the-clock medical care, providing healthy food options curated by dietitians. In addition, we at Atulya also provide rental ownership, where a person gets to choose his or her duration of stay. Atulya provides internet and video conferencing facilities to connect with their loved ones. Atulya is centrally located and one has easy access to the best hospitals and healthcare services which are at close proximity. We at Atulya ensure a cheerful and dignified living for the elderly by redefining the living standards and enhancing the quality of life.
Lifeguard Digital Health is proud to present Intellicare with life-saving alerts for senior facilities. The system has 3 parts: a state-of-art wearable device for the resident, a tablet for the resident apartment, and a monitoring tablet for the staff. Staff will receive emergency alerts from residents and communicate with them wherever they are within the senior facility premises. Intellicare sends emergency alerts for fall detection. When a resident falls, the watch will auto-detect the fall and the admin desk will receive the alert, so they can respond immediately. Intellicare has geofence alerts. If a resident leaves the facility premises, the staff will be alerted with the location of the resident and can communicate with the resident. Intellicare can monitor residents' vital signs. When a wearable device is worn by the resident, it monitors their vital signs and will report to the staff, so they can check on resident vitals anytime from the admin tablet. Staff and residents can message each other. Staff can message residents with important information. And residents can give feedback to staff. Finally, staff and residents can communicate with voice and video calls. Staff can call residents on their tablet in their room or on their wearable. In the event of an emergency, residents can call staff directly from the wearable at any time. Life-saving alerts for senior facilities. Intellicare powered by Lifeguard Digital Health Inc.
autumn years in a person's life are equally to be cherished. Quite often, the hand that rocked the cradle is left clueless about how to live the rest of their lives. The reason may vary: the kin settling abroad, nuclear family preferences, or wanting personal space for them. These reasons contributed in the setting up of Atulya, a premium independent assisted living for the elderly. Based on the concept of harmonious community living, Atulya provides customized assisted living to its members. The homes are ergonomically designed, keeping in mind the needs of the elderly. Right from the carpet to the ceiling, the interior design has been crafted after conducting a thorough research on assisted living trends that are popular worldwide. The floors at Atulya are non-slippery. The state-of-the-art adjustable beds provide optimum comfort. Railings are provided wherever required, as we understand that even minor injuries may cause serious health complications. Emergency call buttons provided near the bedside ensures that precious time is not wasted in case of any medical emergency. Some of the unique features include round-the-clock medical care, providing healthy food options curated by dietitians. In addition, we at Atulya also provide rental ownership, where a person gets to choose his or her duration of stay. Atulya provides internet and video conferencing facilities to connect with their loved ones. Atulya is centrally located and one has easy access to the best hospitals and healthcare services which are at close proximity. We at Atulya ensure a cheerful and dignified living for the elderly by redefining the living standards and enhancing the quality of life.
Lifeguard Digital Health is proud to present Intellicare with life-saving alerts for senior facilities. This system has 3 parts: a state-of-art wearable device for the resident, a tablet for the resident apartment, and a monitoring tablet for the staff. Staff will receive emergency alerts from residents and communicate with them wherever they are within the senior facility premises. Intellicare sends emergency alerts for fall detection. When a resident falls, the watch will auto-detect the fall and the admin desk will receive the alert, so they can respond immediately. Intellicare has geofence alerts. If a resident leaves the facility premises, the staff will be alerted with the location of the resident and can communicate with the resident. Intellicare can monitor residents' vital signs. When a wearable device is worn by the resident, it monitors their vital signs and will report to the staff, so they can check on resident vitals anytime from the admin tablet. Staff and residents can message each other. Staff can message residents with important information. And residents can give feedback to staff. Finally, staff and residents can communicate with voice and video calls. Staff can call residents on their tablet in their room or on their wearable. In the event of an emergency, residents can call staff directly from the wearable at any time. Life-saving alerts for senior facilities. Intellicare powered by Lifeguard Digital Health Inc.
രോഗത്തിനുള്ള പ്രതിവിധി തേടുന്നതിനേക്കാൾ നല്ലത് രോഗത്തെ പ്രതിരോധിക്കലാണ്. ചെറിയ അസുഖങ്ങൾക്ക് പോലും ഇന്ന് നാം ആശ്രയിക്കുന്ന മരുന്നുകളുടെ പാർശ്വഫലം എത്ര വലുതാണെന്ന് പലരും ഓർക്കാറില്ല. ഇവിടെയാണ് ബയോമാഗ്നറ്റിക് തെറാപ്പി ശ്രദ്ധേയമാകുന്നത്. ബയോമാഗ്നറ്റിക് പ്രോഡക്റ്റുകൾ ഉപയോഗിച്ചുകൊണ്ട് വരാനിരിക്കുന്ന ജീവിതശൈലി രോഗങ്ങളെ പ്രതിരോധിക്കുവാനും നിലവിലുള്ള രോഗങ്ങൾക്ക് പരിഹാരം കണ്ടെത്താനും സാധിക്കുന്നു. ഇൻഫ്ലുവൻസിയ ബയോമാഗ്നറ്റിക് മാട്രസ് പാഡ്, പില്ലോ പാഡ്, റിസ്റ്റ് ബാൻഡ്, വാട്ടർ ബോട്ടിൽ പാഡ്, റിലാക്സിംഗ് പാഡ്, ഇത്തരം ബയോമാഗ്നറ്റിക് പ്രോഡക്റ്റുകൾ എങ്ങനെ നമ്മുടെ ശരീരത്തിൽ പ്രവർത്തിക്കുന്നു എന്ന് നോക്കാം. മനുഷ്യ ശരീരത്തിലെ 99% രോഗങ്ങൾക്കും പ്രധാന കാരണം ശരിയായ രീതിയിലുള്ള ബ്ലഡ് സർക്കുലേഷൻ അഥവാ രക്തചംക്രമണം നടക്കാത്തതാണ്. ശരീരത്തിലെ സെല്ലുകൾക്ക് ആവശ്യമായ ന്യൂട്രിയൻസും ഓക്സിജനും എത്തിച്ചു നൽകുന്ന ജീവനുള്ള ടിഷ്യൂ ആണ് രക്തം. രക്തത്തിലെ ഹീമോഗ്ലോബിനിലെ പ്രധാന ഘടകമാണ് അയൺ. നാനോ ടെക്നോളജി ഉപയോഗിച്ച് മെഡിക്കൽ ഗ്രേഡ് മാഗ്നറ്റുകൾ സയൻറ്റിഫിക്കലി സെറ്റ് ചെയ്തിരിക്കുന്ന ഇൻഫ്ലുവൻസിയ ബയോമാഗ്നറ്റിക് മാട്രസ് പാഡ് ഉപയോഗിക്കുമ്പോൾ ഇതിലുള്ള മാഗ്നറ്റുകൾ ശരീരത്തിലെ ബ്ലഡിലെ അയണുമായി ആകർഷിക്കുകയും സജാതീയ വിജാതീയ ധ്രുവങ്ങളിൽ ഒരു പുഷ് ആൻഡ് പുൾ പ്രവർത്തനം നടക്കുകയും ഇന്നാക്റ്റീവായ ബ്ലഡ് സെല്ലുകളെ ഡീക്ലസ്റ്റർ ചെയ്ത് ചലനശേഷിയുണ്ടാക്കി ആക്റ്റീവാക്കി മാറ്റുന്നു. ഈ സെല്ലുകൾ ഹാർട്ട് ബ്ലഡ് പമ്പ് ചെയ്യുന്നതോടെ ഓരോ മൈക്രോ കാപ്പിലറുകളിലൂടെയും സഞ്ചരിച്ച് വേണ്ടത്ര രക്തചംക്രമണം സാധ്യമാക്കുന്നു. ശരിയായ ബ്ലഡ് സർക്കുലേഷൻ നടക്കുന്നതോടെ ശരീരത്തിലെ കോശങ്ങൾക്ക് ആവശ്യമായ പോഷകങ്ങൾ, ഓക്സിജൻ, ഹോർമോണുകൾ, വൈറ്റമിനുകൾ, ആന്റിബോഡികൾ, ഇലക്ട്രോലൈറ്റുകൾ എന്നിവ കൃത്യമായി ലഭിക്കുകയും സെല്ലുകളെ പ്രവർത്തനക്ഷമമാക്കിക്കൊണ്ട് ശരീരത്തിന്റെ പ്രതിരോധശേഷി വർദ്ധിപ്പിക്കുകയും ശരീരത്തിനുള്ളിലെ ഡിസോർഡറുകളെ സ്വയം കറക്റ്റ് ചെയ്യാനുള്ള സെൽഫ് ഹീലിംഗ് പ്രോപ്പർട്ടീസ് വർദ്ധിപ്പിക്കുകയും ചെയ്യുന്നു. ബയോമാഗ്നറ്റിക് വാട്ടർ ബോട്ടിൽ പാഡ് കവർ ചെയ്ത ബോട്ടിലുള്ള വെള്ളം മാഗ്നറ്റൈസർ വാട്ടറായി മാറുന്നു. ഇത് വെള്ളത്തിന്റെ സാധാരണ ഘടനയെ ലഘൂകരിക്കുന്നു അഥവാ മൈക്രോ ക്ലസ്റ്ററിംഗ് നടത്തുന്നു. ഇത് സെല്ലുകളുടെ ആഗിരണശേഷി വർദ്ധിപ്പിക്കുകയും ഓക്സിജൻ ശരിയായ രീതിയിൽ സെല്ലുകൾക്ക് ലഭിക്കാനും സെല്ലുകളുടെ ശ്വസനം അഥവാ സെൽ റെസ്പിറേഷന് സഹായിക്കുകയും ചെയ്യുന്നു. മനുഷ്യ ശരീരത്തിൻ്റെ 70% ജലമായതുകൊണ്ട് തന്നെ മാഗ്നറ്റൈസ്ഡ് വാട്ടർ ഉപയോഗിക്കുന്നതിലൂടെ ശരിയായ ദഹനവും അസിഡിറ്റി, അൾസർ പോലുള്ള അവസ്ഥയെ ഇല്ലാതാക്കാനും സഹായിക്കുന്നു. ഇൻഫ്ലുവൻസിയ ബയോമാഗ്നറ്റിക് പ്രോഡക്റ്റുകൾ ഹാർട്ട് അറ്റാക്ക്, സ്ട്രോക്ക്, ഡിമെൻഷ്യ, അൾഷിമേഴ്സ്, ന്യൂറോ പ്രോബ്ലംസ്, ത്വക്ക് രോഗങ്ങൾ, മുടികൊഴിച്ചിൽ തുടങ്ങി 100-ലധികം രോഗങ്ങളെ പ്രതിരോധിക്കാനും നിലവിലുള്ള രോഗങ്ങളുടെ തീവ്രത കുറയ്ക്കാനും സഹായിക്കുന്നു. 100% റിസൾട്ടുള്ള ജസ്പേഡ് ഇന്റർനാഷണൽ ഇൻഫ്ലുവൻസിയ പ്രീമിയം ബയോമാഗ്നറ്റിക് പ്രോഡക്റ്റുകൾ ഉപയോഗിച്ചുകൊണ്ട് ആരോഗ്യമുള്ള ഒരു ജീവിതം ഉറപ്പാക്കൂ. വിഷ് യു എ ഹെൽത്തി ആൻഡ് ഹാപ്പി ലൈഫ്. രോഗത്തിനുള്ള പ്രതിവിധി തേടുന്നതിനേക്കാൾ നല്ലത് രോഗത്തെ പ്രതിരോധിക്കുക.
We'll be winding up the tea break in another 5 minutes. So I request all of you to please come and take your seats for the next session. നമ്മൾ ടീ ബ്രേക്ക് ഒരു 5 മിനിറ്റിൽ വൈൻഡ് അപ്പ് ചെയ്യാണ്. അപ്പോൾ എല്ലാവരും ഉള്ളിലോട്ട് പതുക്കെ കയറി സീറ്റുകളിലേക്ക് ഇരിക്കേണ്ടതാണ്.
Lifeguard Digital Health is proud to present Intellicare with life-saving alerts for senior facilities. The system has 3 parts: a state-of-art wearable device for the resident, a tablet for the resident apartment, and a monitoring tablet for the staff. Staff will receive emergency alerts from residents and communicate with them wherever they are within the senior facility premises. Intellicare sends emergency alerts for fall detection. When a resident falls, the watch will auto-detect the fall and the admin desk will receive the alert, so they can respond immediately. Intellicare has geofence alerts. If a resident leaves the facility premises, the staff will be alerted with the location of the resident and can communicate with the resident. Intellicare can monitor residents' vital signs. When a wearable device is worn by the resident, it monitors their vital signs and will report to the staff so they can check on resident vitals anytime from the admin tablet. Staff and residents can message each other. Staff can message residents with important information. And residents can give feedback to staff. Finally, staff and residents can communicate with voice and video calls. Staff can call residents on their tablet in their room or on their wearable.
We would like to start with the next session in the next 2 minutes. So I request all of you to please come back to your seats. അടുത്ത സെഷൻ ഒരു 2 മിനിറ്റിൽ റീസ്റ്റാർട്ട് ചെയ്യാനാണ് നമ്മൾ ഉദ്ദേശിക്കുന്നത്. അപ്പോൾ എല്ലാവരും ദയവായി സീറ്റുകളിലേക്ക് ഇരിക്കുക.
Intellicare powered by Lifeguard Digital Health Inc.
All right. So we are going to start the next session. പുറത്ത് ചായ കുടിക്കുന്നവരെല്ലാം ചായ കുടിച്ചതിന് ശേഷം ഉള്ളിലേക്ക് കയറി വരുമെന്ന് പ്രതീക്ഷിക്കുന്നു. സോ നമ്മൾ ആ നെക്സ്റ്റ് സെഷനിലേക്ക് കയറുന്നതിന് മുന്നേ വി ഹാവ് എ ക്വിക്ക് ലൈവ് ഡെമോൺസ്ട്രേഷൻ ഓഫ് ലൈഫ് ഗാർഡ് ഡിജിറ്റൽ. നേരത്തെ വളരെ ഭംഗിയായിട്ട് എക്സ്പ്ലെയിൻ ചെയ്ത ആ പ്രോഡക്റ്റിൻ്റെ ഒരു ലൈവ് ഡെമോൺസ്ട്രേഷൻ നമ്മളിപ്പോൾ കാണാൻ പോകുന്നത്.
Got it? Oh, they got it. Yeah, yeah. Yeah. Do you want me to stand? Or sit? I'll stand. Okay, well, welcome back, everybody. I hope everybody had a nice break. And as promised, what I'd like to do now is Shivari is going to go through some of the features. Please take a look at the screen. You're going to see how they work up front there. And what I'd like to do, and thank you so much for the camera, it really makes a big difference. I'd like to first of all point out what you're looking at there is on the left side, you're looking at a resident tablet, room 101. On the right-hand side, you're looking at a resident tablet 201. And in the center, you'll see that that's the center nucleus of the admin desk or a nurse's station. So again, any alerts that you're going to see will then be sent to the middle tablet, and we're going to go through a few really important features and show you guys how this works. The first thing we're going to go through, just in the same order as we did on my presentation, we're going to talk a little bit about the resident tablet. So the resident tablet, again, is a two-way communication. It's used to send messages from the admin or from the client back to administration or to a nurse's station. And I'm going to ask Shivari just to show you how that works. So this currently is a client trying to What we're going to show now is I think Shivari has actually put a message together and you're going to illustrate how we can message through text onto the tablets for the front desk. So she's just typing out a message. And what you should have seen, and she'll illustrate there, it showed up on room 201. So the lights are a little bit, maybe just, you're going to have to change the angle a little bit. There we go. So the message, if you see, just showed up in the middle of the screen there. That's difficult to see, but hopefully you can. So any messages, again, that you want to send to and from, it'll show up on the tablet just like that. And it'll stay there until you clear it. So for instance, if you're out of your room and you've gone on a walk or you're wherever you've gone shopping, the message will reside on the tablet until you get it. It will actually prompt you as well, so it'll give you a bit of a flash or whatever to make you know that there is a message on the tablet. Okay? Now what we're going to do is we're going to go to what actually has the most features, which is the resident watch. So the resident watch, as we talked about before, does many things. The first thing, whoa, sorry about that. The first thing I would like to show you is how it monitors your vital signs. So as you can see the graph, this is used for many things. So we can actually use this device at a nurse's station over time to gauge your history and to see whether or not your vitals are going to dangerous levels, non-dangerous levels, what's the history of your vital signs. So it actually allows the staff to keep track of what your history is where you've gone up, where you've gone down. But what it really does in terms of emergency, if there's an instance where you're in crisis and any of your vitals have gone to a point that it's extremely dangerous level, it's then going to send the alert to the front desk. Oh. Yeah. Okay. The next thing I want to show you is, and I think this is one of the most important ones because features, which is geofence. I say that because as we all get older, I'm 54 now. You know, I'm even at 54, I'm starting to feel different things, and certain things in my life are starting to change, and I have to consider my health more, and I have to consider mental health and physical health. One of the things that the geofence really does, and if you listen to my example, again, this gentleman was, it really, it kind of brought tears in my eyes because he was limited to what he could do. And he himself, he was an engineer, very smart gentleman, prideful, and I can only imagine that was a very difficult situation where if he wanted to leave and walk around, he had to be mirrored by a staff. So imagine being able to get your freedom back and be able to do whatever you want to do whenever you want to do it. So this particular feature, are we going to be able to show the geofence, hon? I shouldn't call you that. There it is. So what it does is, again, we can, every single client is different. So dependent on the severity of whether you have some dementia, whether you have, it doesn't really matter. But the geofence, which is a digital fence, obviously it's not wood, and it can expand or contract extremely easily depending on the client. So nothing actually is, there's no, it's all inconspicuous. So it's all behind the scenes, this tracking, and I don't want to use tracking. It only ever functions if you get past that geofence. So it's a predetermined, agreed upon fence so that everybody's comfortable with how it works. If somebody, gentleman, lady, female, goes across that boundary, the front desk will get an alert, and they have many options. The first one they can do is to call the watch, are you okay? If there's no answer, the GPS location will then be provided to the front desk. Then they have two options as well. They can respond if the client is close by. If they're not close by, they can then send that alert directly to emergency services. And through GPS and longitude and latitude, they can find out specifically where you are and respond as fast as emergency services can. So through geofence, let's just remind ourselves of some of the really important things here. You get your freedom and life back. Okay, so you can operate independently. You don't need other people to help you. So this particular feature, we find that the feedback is probably one of the most popular, and it also can be utilized if your health or your need for increased care, which is natural. This will work at any level of care. So you can be monitored, or you can be provided your freedom again at any level of care. What do you want to show next? What do you want to show next? You got another one you want to show next? Yeah. Oh, yeah. So one of the most common occurrences, and probably the most dangerous and deadly, is fall. So seniors, it doesn't really matter your age, but as we get older, especially within the seniors community, falls are the most common, the most dangerous, and also the one that will do the most damage, if you will. So a lot of, and I mentioned it on my presentation, a lot of companies will say that they have a fall detection on their watch. What we've done through our team is we've actually reinvented what we call fall detection. So we actually operate now at 98% accuracy, and that's legitimate, and it's also published. So we have done that. The important part is that with fall detection on a lot of watches, there's a lot of false alerts. So a lot of alerts will go off, and somebody either hasn't really fallen, they might have moved too fast, but it's not really an alert. So The other question we always ask is, where does that alert really go? If you have an Apple Watch or if you have a Samsung Watch and they have fall detection and it actually believes that you've had a fall, where does the call go? Who's going to come and get you and who's going to help you? That doesn't have an answer. There are a lot of beliefs that it goes to a call center or goes somewhere else. That's not necessarily accurate. So what happens with Lifeguard? If there's a fall detection, again, it has multiple levels of managements of alerts. That alert will go to the front desk. Again, the front desk can use the in-room tablet to look into the room to see what kind of state that you're in, what injuries that you've got, before they even enter the room. The reason that's important, possibly if you're seriously injured, they automatically, as they're going to the room, they can call emergency services, have them on the way while you're responding, or staff or nurses are responding to the client. So through our trials and through our continued trials of Bliss, we're going to show how this particular feature, extremely important, very effective, and also really accurate. So we're really proud of this, that we've been able, as a small company, to expand on the accuracy of being able to pick out falls that are genuine and are dangerous and be able to respond to them as fast as possible. I think what we're going to show, so if you can see on the watch, well, we got to go the other way. Let's do that one more time. Lots of beeps going off here. Lots of alerts. Things are happening. So Shivari's imitating a fall on the watch. Can it see that? There we go. So it detected a fall. You see how big the letters are. So, and actually, we can have those expand or detract depending on how your eyesight is. So that's how it will come up on the watch. It directly shows up on the panel. And if you can actually go further, she could literally open up the, well, first of all, if you're not in your room, it gives you GPS location. So once again, it can find you. So if you've fallen outside of your facility, if you're outside of the actual grounds and you fall, it doesn't really matter what happens to you. Again, remember, it will, without you being involved, sense that you're in crisis, whether, again, it's through geofence or fall, and it'll send that alert to the front desk. So you don't have to do anything. It monitors you through your vitals, through the fall detection, through wherever you go. And it will, again, send those alerts when you're in distress or in crisis. So fall detection, geofence, being able to communicate 2 different ways, forward and back, whether it's video or audio, those specific 5 functions will make your life easier, simpler, and will save your life. That's proven, and that's for sure. So if there's any questions, I'd be really happy to answer them. We've gone over the most common features that most people want to see. But if there's anything else, please let me know. Or if you've got any questions as well, come to the booth, or I'm available now to answer them. Is that it? I'm getting pulled off the stage here. So thank you very much, everybody. I probably took too much time, and I can talk for a lot, but really appreciate your time. Please come to the booth when you have questions. We'll answer them wherever we can. Thank you so much.
Thank you once again, Jeff. And I think when you talk about something that important, you can take all the time that you want. No worries at all. So thank you so much. So Ini, now we've been talking about healthy aging, and healthy aging in the Varayambo, it's not just technology. It is, technology is a part of it, but it's not just that. It's a holistic approach. So I would like to have on stage Mrs. Chittilappilly, who is the director of Bliss Retirement Living, to talk about how Bliss Retirement Home actually looks at healthy aging holistically. Can I please have you on stage?
Thank you, Neetu. A very warm good afternoon to one and all present here. As we age, Our bodies may not be as strong and agile as they once were. But does that mean we can't enjoy life and stay active? At Bliss, I'm constantly reminded this, that golden age is when you truly start living your life, living for yourself. Or at least that's how it is for most of our residents. By 2017, when we had about 20 residents, we started going big with our celebrations. Meaning, we had week-long preparations with decoration, dance, music, and skit performance. The plan was to do all these running around by us young team members at Bliss. Little did we know, our Geet auntie, Sheila auntie, Venu uncle, Bhatt uncle, George uncle, and all the cutest uncles and aunties who are in their 70s and 80s were so much more excited and skilled when it comes to cultural programs and decoration. The journey just got more and more interesting as the years passed and as our residents' number got bigger. And it's so inspiring and heart-filling to see many of them reliving their youth and for some of them living their long due life. Because majority of them had to spend most of their younger life working or looking after the family. Sorry. Yeah. Thank you. So it's so inspiring and heart-filling to see many of them reliving their youth and for some of them living the long due life. Because majority of them had to spend most of their younger life working or looking after the family and never having the time to do anything they truly enjoyed. Now, I either see them sitting back and exploring the art of slow living or getting super enthusiastic, fulfilling their long-lost or unlived passion like painting, dance, and music. Last night, while setting up the stall, I was having a casual conversation with our staff, Dia, on how the dance plan for tonight looked so great on stage while they practiced yesterday. She mentioned how Ammu auntie and Nirmala auntie are excited to perform tonight and even coming all the way here just to practice. Sometimes watching the 80-year-old auntie acing her dance moves make me doubt myself. Doubt if I'm doing my fullest. I'm sure you all have noticed the beautiful stall right at the entrance with a lot of beautiful artworks. All those works are done by few of our residents, and most of them are their masterpieces. We've got works by Mallika auntie, Gladys auntie, and a lot of, main works are by Mallika auntie and Gladys auntie, who always had art with them, and many other aunties who are newbies and is still learning and improving. But I must say, I'm super proud on where they have reached with their art journey that started at Bliss. It all began with renowned artists like Jairam sir, Kaladharan sir, and Mr. Francis Cordon Kandut, with whom we explored the therapeutic side of painting and clay modeling. From there, we took it up and practiced art daily. And I'm not kidding, it truly changed their lives for good. I see Mariam auntie, who was a renowned doctor who practiced for more than 40 years, no more waking up worrying about her patients, but wondering if the paint stroke she gave previous night has come out fine, and walks around finding new frames to paint next, and eats food thinking if the dining hall she sees is in 1-point or 2-point perspective. I'm sure all of you are well aware of the health benefits of staying physically and socially active. Let me share another story that still inspires me. When I completed college and started spending all my time at Bliss, there was one person who I went to daily. That was our dear Ramachandran uncle. He's a retired doctor and also a huge, talented art enthusiast who constantly supported and encouraged me to follow my passion in art. He was diagnosed with Parkinson's when he came to Bliss, but one could hardly tell. Even at Bliss, he kept adding more acrylic works to his gallery. As his Parkinson's got worse, what I saw in Uncle was not resignation, but renewed enthusiasm and perseverance. Even when he reached the stage where he could hardly hold the painting brush due to his stammering hands. This was the point when we started art therapy at Bliss, and I was so devastated that he couldn't participate like before. But to my surprise, he was ready to go back to the basics. From painting abstract figures, he went all the way back to painting straight lines and filling circles, even with his tremoring hands. Just think about it. How inspiring can this story be? With all this said, let me conclude by emphasizing that activities and art can be incredibly beneficial and therapeutic for all of us, especially for seniors. Thank you.
Thank you, Sheetal. So the next couple of sessions, I'm going to be standing here because it's not going to be a very formal session. It's a rather interactive session, which also means that all of you can actively be part of it in whichever way that it pleases you. So, ini നമ്മൾ ചെയ്യാൻ പോകുന്ന സെഷൻ കുറച്ചും കൂടി ഒരു ഇൻട്രാക്റ്റീവ് സെഷനാണ്. അപ്പോൾ എല്ലാവരും അവിടെ തന്നെ ഇരിക്കണം എന്നൊരു നിർബന്ധവുമില്ല. മുന്നോട്ട് വന്ന് കാണേണ്ടവർക്ക് കാണാം, ഇൻട്രാക്ട് ചെയ്യേണ്ടവർക്ക് ഇൻട്രാക്ട് ചെയ്യാം. So, I would like to call onto stage somebody very special and very close to Bliss Homes. Mallika Aunty, can I please have you here on stage? Mallika Aunty is an artist who pursued her sugar craft artwork from UK. Bliss Homes il vannadinu shesham ആർട്ടിന്റെ ക്ലാസും സെഷൻസും എല്ലാം എല്ലാവർക്കും എടുക്കുന്ന ഒരു കലാകാരിയാണ്. So Aunty, the stage is yours. She will be talking to you about her journey, how art has helped her and what she does. Again, ഞാൻ ഒന്നും കൂടി പറയാണ്, അവിടെ ഇരുന്ന് കാണണമെന്നില്ല. If you want to come forward and see up close what she does, please feel free to do it. Aunty, the stage is all yours.
Okay, thank you. ഞാൻ introduce ചെയ്യില്ല. I think our residents know me. I am a happy resident of Bliss, Mallika Paul. That's my name. And to start with, to say how happy I am, I have to give you a little background or a flashback of my past, about 2-3 years back before I joined, 2 years back before I joined Bliss. We had settled in the Texas for about 18 years, and then we came down to India, then the pandemic broke out, and then we had to stay back here because flights were all cancelled. So that's the time when I went deep into a kind of depression because my husband was very ill, and I couldn't do any of my art because I'm a passionate lover of art. I couldn't do anything. All my materials just lay on the side, and I had to take care of my husband. That was my primary duty. So a stage came when I became very depressed. And then I told my children, I just want to move out. And that's how they found out Bliss. And they said, Mommy, this is the best place for you. So that's how I came to Bliss. So why I said I'm a happy resident of Bliss is because Bliss has brought me back into life. I started all the art materials which I kept aside, I took them out, dusted, and started my journey again. Because I had a very hassle-free life in Bliss. All the staff and all the nursing, all the departments in Bliss. I need not say about our managing directors. They gave me a lot of care and affection, love. I don't know what to say. It's full of, Bliss is always bustling with activities. All kinds of festivals are celebrated here, and we all take part in it. Age is not a number, they say, and that's true. We all take part in all kinds of dance and whatever gym and yoga and storytelling, singing, and art, and all kinds of things which make me very much more energetic and youthful. That is very important thing, to be very youthful even at this age. For that, Bliss has contributed quite a bit. And my children, for them also it would have been difficult if we were in Kerala, in Trichy. Now they feel very, safe, and they feel, okay, our parents are in a safe hands. So they are also happy. So mutually, we are happy because we are taken very good care of. And my children are happy because they have peace of mind to work now because they are under very careful hands. So that's how, when I came here, when I came to Bliss, I noticed that so many people, all are active. Why should they just sit idle? Then I asked Madam Deja, what should I do? Can I teach? Can I do? And I love teaching. So she said, you're welcome. You can do anything what you want. That's the best part of Bliss. You can do, there's no strict hours like this is your prayer time, you have to report here. There's nothing like that. You can just be free and do whatever you want. So Bliss has always blessed me to live a very happy retirement life. Now, coming to my passion, I love painting, I love making flowers, and many other projects I used to do there. I had my own school in Sharjah, and I used to do metal embossing, vegetable carving, cake icing, and a lot of things like that, which mostly all the ladies and men also used to come and learn from me. So now I think I should demonstrate a clay flower. If I keep talking, there's quite a lot to talk about this, but most of the times I've already spoken quite elaborately. And here I'm going to, these are the clay flowers that one of the roses which I'm going to demonstrate now. So those who are interested can come close if you really want to see it, or it's okay, or the ladies, my students. And also I have to talk about my students. They, from the age 65 to up to 83, I have students coming to me. And the 83-year-old student is the most enthusiastic one. She's always like a bouncing ball, jumping all around. I don't know if I should mention her name. She's silent. She's Dr. Mariamma, none other than Dr. Mariamma. She's always active. She'll never sit in one place. 83 means we expect a lady, normally we expect them to sit and relax. But I have not seen her in a room. Whenever I go there, she's not there. She's always around. And all of them are very enthusiastic. They are very happy to come to my class, and I'm more than them, I'm happy to teach them. That is my bunch of students. And the others, we mingle very well with each other. We have lot of fun times. And thank you, Bliss, for giving me this opportunity to be here to speak out my heart. So now can I start?
You may please start, and I think Nalloru kayyade kodukam, please, for speaking so warmly and from her heart. Thank you so much.
Thank you.
And we are all very excited to see what you have in store for us.
Yeah, and just sit. So before I start making the flowers, I'll just give a brief know-how about this clay which I'm going to use now. This is called Thai clay, made in Thailand. The basic ingredients is corn flour, white glue, and then a little bit of glycerin and a little bit of Johnson's baby oil. And these are the things which make, and then we bake it to make it into this consistency. For those who are going to learn this, I have to give you some hints. That is, this clay comes in white color. White, it's pure white. So before starting to make the flower, when we use oil paints or acrylic paints to make the dough whiter. Then that's a must. As you get this clay, you have to add a little bit of acrylic white and then mix it very well. So it becomes really pure white and opaque. If you don't add white, it will become translucent, so the flower will not look natural. That is the reason. So the clay comes very loose. See how it's stretchy, very stretchy. So this, you cannot roll it out because it will stick to your board. So you have to add a little bit of corn flour and make it stiff, very stiff, so that you can roll without touching. Now my lovely assistant, would you please come here and take a chair and sit here? And another thing is, as soon as you take out this clay, you have to see that it is sealed tight and kept in an airtight container. That is very important too. And then wrap it up very well. So then another thing what you need for this is a rolling pin, preferably a non-stick rolling pin. If you don't get this, you can use PVC pipes. That's also very non-sticky. Then I have my board, white board. So I have a non-stick board also. You can substitute this with a nice table mat if you have a smooth one. And then the colors that we use for mixing is acrylic or oil paints. Both are good for it. Right now I mixed acrylic paints. Sorry. Mix it. What I mixed already. Mix it. Sorry, 1 minute, please. All jumbled. pink, pink color. So these are the cutters that we use for making these flowers. We get them in Amazon or anywhere. I think most of the craft shops you get it. So for making the rose, I'm going to use 2 sizes of the circles. And this also, if you don't have them, you can, for this rose, you can use any, all of us must be using medicines, pills and things. You have the lid of those bottles which you can use to make these flowers. So here I have the right tools, I'm using that. So we need, for this rose, you need 2 circles, one bigger and one smaller. And this, here already I've mixed white glue and a little bit of corn flour to make it stiff. And then you take a little bit of this. So I have to always use a little dough at a time so that it doesn't dry fast. And I have my corn flour, glue. So I tied up the corn flour in a small bundle of muslin cloth, and this is a loose bundle of corn flour which I'm going to dust on my work surface, and then I just roll this. I'm just showing you just one petal, the others I've already made. So, can you all see? So from this I'm going to cut out one petal. I'm just showing you one petal now, how to process it. Then later, when whoever wants to learn can come over to me in Bliss. Bliss residence. So this is the one. And this is the shape of the thing that I cut out just now. Then we have to slowly, I'm making the edges a little soft, so it becomes more realistic. You have a tool for that. So you get tools, everything you have tools, but it's not necessary to use all. So I've got this tool, which is like a dumbbell. It's both the sides are rounded, and for different sizes you can use whichever is appropriate for that. So I'm just making the edges, see, making the edges little loose, oh my God. Okay. See, I'm just rolling out the edges. Hope everyone can see it. Just roll it out onto your palm and then just cup it a little bit slowly. Cup this. Then you have to give the shape for the petals. So I'm putting my thumb here so that I don't lose the cup. I'm just going to roll this side of the rose to make it look more natural. So we get the petal like this, which is little, there's a dip in the center, and then I folded both the sides. This is how we prepare the petal, and then I keep it in a palette so that the buds retain the buds there, and it will dry with the same shape what we have kept here. So dip the center of the petal and keep it here for drying. That's the first step. So we have an inner wall and outer wall of the flower. So first you have to do the outer wall so that it dries up. The inner wall is a smaller, so I've done part of my homework. That is, I just, these are the smaller petals. This you don't have to give any shape. The smaller petals has to be done after finishing the outer layer. This is the inner wall, tight roll of the rose. Now, we have to take 2 shades of the dough. One is lighter, one is darker. The inner wall is darker and smaller. Darker and smaller, that's the inner wall. So in that I'm going to just roll it a little bit. You can put glue on the base of each petal. And this is the bud. This is just a ball, and I made the end little bit of. So first we are going to start with the smaller petal, and she's put on all. You have to glue the base of all the petals, and then just stick it. So only the first petal you have to be a little careful. You have to bring this a little higher than the bud, and then you stick it on. So the first one is done. Close the top part very tight so that you don't see it open at the stage. The first one is done, and just opposite to where the place you joined, there you have to put the other petal and stick it very well tight. Close, but you're closing it very tight. Don't go very half. So then I'm taking the third one and putting wherever the joint is there, just seal it with the place so that you see the bud inside. It's a tight bud, and if you want to stop at the bud stage, this is the place where you should stop. And then you can put the calyx, that becomes a tight bud. But I'm going to make a full bloom flower, so we have to keep going with that. So it's very simple, just wherever the petal ends, just overlap and keep going as much as you want the rose to be. The size of the rose depends on how many petals you're adding. The more petals we add, the rose will become larger and larger. This is the second bud stage where it is a little more opening up a little bit, so I just touch like this. Now I've gone to the lighter petals. Lighter. So again, the method is the same, you're just overlapping and going one behind the other. Then you have to keep it for drying. It takes about 7 to 8 hours for drying. Now you should be patient. Don't keep looking at the rose each time. You may open and see, or just keep it for a drying time. And I told you the inner wall should be darker than the outer one. So stick it very well so that, see, it's just opening slowly. I hope you all can see it. Next one. It's opening out, put glue more glue, and keep going. Can you all see? Slowly opening up. Oh, you all are seeing from little dry because I rolled it up at home. And I brought it here so that we don't waste a lot of time. Rolling each petal and processing is a little time taking. Where you feel this, where you feel you need a petal, you can even insert inside if you need to, but preferably just. It's little dry because in the transit I had to keep it open, so it's a little dry. But when you do at home, you can just take it fresh. So it's easier to stick. That's the advantage. So put glue on the calyx. See, it's not stuck now. Keep attaching all the petals likewise. So it will take some time to dry, so it can fall off, so I can't pass it around now. But I have roses which I've done already.
I think there's also one more thing, Auntie, that they can look at.
Where is
I'm right here.
Yeah, okay.
So all of you, did you all get a small goodie bag? Did you all get a small goodie bag? Ellarkku oru cheriya bag kai kittiyarno?
Most of
Kitty. Okay. I have a room full of people and zero noise. Kittiyarno? Okay. Appa aa bag inagattonnu thorakkanengil, do you have a small pouch like this? If you have that pouch, could you just open it up quickly? I'm actually going to make all of you work a little right now because you've all been sitting for a while, no? While Auntie is finishing the rose there. So if you take that jute pouch, that small little pouch, you have a fridge magnet, yes. And that there's a flower on the fridge magnet, which was actually made by the staff, if I'm not wrong, of Bliss Homes with the guidance of Mallika Auntie. So all of you will be taking home a piece of it as well.
So now we are fixing the calyx of the flower. There's a cutter for that as well. So just join all this at the back and let your rose rest for a while for it. So this is a complete rose that's done. Yeah.
We can give her a louder round of applause for that.
Thank you so much. Now we have to really wait for it to be passed around, but you can see the roses. But these are 20 years old. These are not as fresh because, yeah, this you can take.
Those are 20 years old?
Yeah.
Okay.
It's ready for its wash, but I didn't have time, so I just left it.
I also just quickly bringing your attention to the stall there at the back. You guys can also later on during your breaks go and check out works by Mallika Auntie and also her students.
Yeah, all my yes, of course. Mine is very less. Most of them are my students' work.
All right.
So that's all.
Thank you so much.
Thank you
so much, Mallika Auntie.
Watching.
Good round of applause, please, for her.
Thank you. And these are the lilies, with the same clay, tulips. Or you can make any kind of flower using this. Is a very forgiving clay. It doesn't dry so fast. It gives us long time to keep it in shape.
I think you all should definitely go and have a small quick conversation with Auntie, if not to learn about her art, just to understand how she stays so young, warm in her mind, the way you were speaking, so sweet.
And one more thing, my husband always supports me, right? When I was young, when I was 15, I started painting on saris. My mom supported me. Dad was always study, so that was not possible. But my husband, after me, he is the one who asked me to continue. He was always encouraging me, telling me to learn. Since you have that in your hands, just God-given gift, keep doing it. So he's not here at the moment, but think of him. Okay.
Thank you so much, Auntie.
Thank you. Welcome.
Now, next up, we have another artist. But before that, I would like to call upon Dr. Chandana really quickly to hand over a memento to Mallika Auntie.
Thank you so much. Thank you so much. Did you like the session?
I did. I want that rose.
Oh yeah, take it. But it's a little delicate now, it might fall off.
So next...
Take a picture.
Yes, after the picture is taken, of course.
Yeah.
We have to give the next artist a few minutes to set up as well. അടുത്തത് നമുക്കൊരു കലാകാരനാണ് നമ്മുടെ ഇടയിലേക്ക് വരുന്നത്. Dr. C.S. Jairam, who is a painter, a sculptor, a professor, a playwright, an actor, and the list goes on and on and on. And കലയെ ജീവിതത്തിലെ എല്ലാ അംശത്തിലും എല്ലാ രീതിയിലും ഇൻവോൾവ് ചെയ്ത് ഉൾക്കൊണ്ട് ജീവിക്കുന്ന ഒരു വ്യക്തിയാണ്. So I'm going to give him a minute or two to set up. Meanwhile, I'm just going to come out to you guys and meet you a little bit. കാരണം നിങ്ങൾ എല്ലാവരും കുറേ നേരമായിട്ട് മിണ്ടാണ്ടിരിക്കുന്ന ഇങ്ങനെ നോക്കിയിരിക്കണേ ഉള്ളൂ. I want to know if we have artists here among any of you. I'm sure there are. Okay, right up. Can I just have your name and what do you do?
So my name is Dr. Charuda Taroda and I'm traveling from Delhi. And apart from being a doctor and a researcher, I'm an avid painter and I love to do oil on canvas a lot. So that kind of de-stresses me and gets all my ideas onto the canvas for a better calm and a better stress-free life.
Lovely. I think we're hearing from you a little bit more later on, and it also explains your very attentive listening and watching to what Mallika Auntie was doing. Any other artists here? Okay, yes. I'm going to come to you also really quickly. സ്വന്തമായിട്ട് ഒരിക്കലും നമ്മൾ ക്രെഡിറ്റ് എടുക്കൂലല്ലോ, ആരെങ്കിലും പറഞ്ഞാലല്ലേ എടുക്കുള്ളൂ അല്ലേ?
Hi, I'm Adirajit. I like to work with papers. I'm a craft worker. I like to make birthday boxes, flowers, and dream captures. Thank you.
So if I want to gift somebody something for a birthday, I come to you? All right. Okay. So I think Jairam sir is almost set up. Do you need a minute more? All right. Okay. So I already introduced him before. I'm saying it again. I do not know where to start. I do not know where to end. He does everything and anything that is related to art. Ladies and gentlemen, please give him a loud round of applause, Dr. C.S. Jairam.
Thank you, Jairam. Thank you. See, as you can see, I feel so anachronistic to be in this fine, most refined, sophisticated auditorium with all these, up-to-date, state-of-the-art electronic gadgets and all, for being so messy, sloppy, filthy clay. But I'm forced to do this because of the loving invitation that my dear friend and one of my most favorite students, Babu Joseph, and Sheetal, and Jijo and Mrs. Jijo, her parents, and all the staff of Bliss. And another reason why I came was to meet once again my dear children of Bliss. Blissile എൻ്റെ കുട്ടികളാണ് എൻ്റെ മുമ്പിലിരിക്കുന്നത്. As Sheetal said, I remember one of the first pioneering workshops we had with these wonderful young artists of Bliss. And I remember during the course of the clay modeling workshop, there was a stage when they took off tangentially and they started dancing, they started singing, they started cracking jokes, they started throwing clay on each other. It was sheer fun. And I wanted to meet them again. This is a great opportunity. And I will try to share my thoughts on clay as I continue to work. I'm not specifically going to make a finished product, but the very process of handling clay gives me pleasure. Because it's most primordial medium, like stone, goes back to, not centuries, no, most primordial time when our civilizations, cultures began, when man began to, to articulate themselves non-verbally, even before verbal language was designed. People started communicating and they started expressing themselves through clay and stone also. So I have that feeling of being connected primordially to my ancestors the moment I touch clay. And this is the great feeling that I have when I work in clay even today. And I am actually an official mentor of Speakmaker for clay modeling. And Monday, I am starting a workshop in Coimbatore clay modeling for school children for 1 week. And why the relevance of clay today? Because I have been to so many workshops for school children and college children. And much research has been done on clay as a kind of therapeutic practice. Clay therapy comes very seriously under play therapy. We all love play. Homo ludens. We human beings are homo ludens. We love play. And play can be a kind of therapy. Singing can be a therapy. Painting can be a therapy. And among these therapeutic art practices, one of the most important medium is clay. Because clay actually talks to you, and clay can take so much of your anger, of your depression, of all the feelings, of your feeling of melancholy, of your feeling of being lonely, all these things clay can absorb, clay can take. And clay is susceptible to your touch. Clay is a medium, a tactile medium. You communicate with touch. Even during Corona times, when you had to keep social distancing with your own relatives, if you have a lump of clay, it will stick to you. It will stick to you. And tactilely you can feel the touch, and clay will reciprocate. Unlike any other medium, but stone doesn't reciprocate actually. If you do in marble, if you do in granite, I have done in granite, you are cutting away things and taking shape. Whereas in clay alone, clay responds to your touch, and clay somehow communicates to us. And somebody, some psychologist, psychotherapist has said that clay is the Cinderella of all art mediums. Why Cinderella? Because it's very deceptive. It looks so messy, slippery, and it doesn't invite our attention very much. And outward appearance, it's not as beautiful as Mallika's clay, white clay. This is a third world clay. But still, behind that, if you go deep into working with clay, there is a point when clay starts talking to you, reciprocating to you. And clay needs your loving touch. Your touch can be strong, decisive, shaping, plastic, and the clay obediently, very passively, the clay listens to you. And at last, like Cinderella, coming out of her, obscurity, the clay will evolve into an enduring work of art, enduring piece. I think, I forgot her name, one art critic has compared clay to Cinderella of all the work forms. And then scientists, very seriously, studies are now taking place regarding clay therapy, how clay can be very therapeutic, especially to children in autism. In autism, actually, this is one way to treat autism. For autistic children, clay can be very helpful medium. I think in ASD, autism, spectrum disorder, ASD, and then ADHD also, that kind of, attention. Exactly. Hyperactivity disorder. And in these two, especially in these two disorders, what they suggest is clay modeling. How clay can move them to a kind of physical activity, how clay can balance them, and how clay gives them a shape of, spatio-temporal feeling, kind of space, 3D space it can give you. And it can create a kind of hallucinatory shapes also. You can be a kind of creator, and you can create any kind of shape you want by kneading, by putting pressure, as I told you, by attributing your emotions to it. All these things you can do. And another thing about clay is, as a medium, clay is an additive medium. An additive medium you add to make shapes in clay. Whereas stone is a reductive medium, you cut away pieces and make sculpture. Wood is a reductive medium, and clay is an additive medium, and you go on adding, like two pieces. You net two pieces like this. You just press them together, you add, you form a slab like that, like this, you can add again. You can join them again like this. again like this. I remember an experience I had during one of the clay modeling workshops for school children. When we started, the first day, we gave clay to children and they started working. And I was supervising their work. And there was one girl who was sitting very worried. She was just holding the clay I gave her like this. She was sitting there for 1 hour without doing anything at all, absolutely nothing. She will just look here and there, very tentatively. She was not doing anything at all. Then during tea break, I talked to the principal. I said I could detect some girl with some problem. She's not able to do these things properly. And he said, to my surprise, he said that girl had been detected with some autistic problem, and doctors had even advised her to go for clay therapy. She enlisted for clay modeling workshop, among other items, because doctors advised her. In 1 hour, first hour I could detect some problem with her, and she could not coordinate. Her fingers and brain could not be coordinated. And then, we encouraged her in the subsequent days. And on the third day, you wouldn't believe, she could make a beautiful design with clay. And the beaming smile on her face. This is true. This is true. And, I had been taking workshops for specially able children in schools. For example, in Mridula near my house, there is an institute. And lot of children, among 300 children, most number came for clay modeling because they wanted to play with clay. And they are fumbling with clay. You can find that somehow they are trying to coordinate. No other medium can do that. Even if you give them brush and paint, they cannot do that. But clay listens to them. They can shape it any way they want. So they come out with some kind of shape. They are so happy. They are so happy. And eventually we can find a kind of confidence building up in them. And that was seriously the moment when I realized that what I am doing just for fun and as hobby has very serious, resonances, very serious implications, especially for children with autism and even for, adults with some problems. And we are told that this can respond to our sensory motor nerves in the brain, and it can improve the right lobe of the brain, and it can improve our meditative processes, our reasoning processes. It can improve our memory. All these things clay can do. Don't be misled by the primordiality, the simplicity, the easy availability, and the sloppy, misleading look of clay. This is the Cinderella of art. And you can give it any treatment. As I said, this usually happens. I remember in artistry a great quarrel, significant quarrel that went on between Leonardo da Vinci and Michelangelo. Da Vinci was a painter, Michelangelo was a sculptor, and Da Vinci used to say in public that sculptors are all dirty, messy, very lousy people. And Michelangelo heard that, and there was a quarrel. Once they met in public, they had a great quarrel, and Michelangelo said, I may be a sloppy person, and I may be dirty, but I could make a David 18 feet height, marble David in one single piece in 2 years with this one single chisel, iron chisel. Can you make it? Michelangelo challenged Da Vinci, and Da Vinci was without any proper answer. And for me, my personal take in clay modeling is somewhat philosophical. I am reminded of Browning's poem, Rabbi Ben Ezra, where he says, where he compares human life to human beings to passive clay. We are all passive clay. Even biblically, we are all clay. From dust we come and unto dust we return. We are all clay. And Rabbi Ben Ezra, Browning says, we are all clay, passive clay, in the hands of the master potter God. God is a master potter, and on the wheel, pottery wheel, God is spinning us, God is shaping us like this, and the maximum pressure God gives comes out most beautifully. Most beautifully. So think of that. All the hardships we experience in life, all the miseries we experience in life, all the setbacks, all the frustrations, all the thought of death are only the shaping touch, the pressuring, shaping touch of the fingers, the divine fingers of God to make us come out most beautifully. He says, look up, not down to the uses of a cup. God is a potter, and all our miseries are just like this, the pressure the artist gives to the clay. As you can see, I am just fumbling. I am just tentatively trying to make something out of it. Clay refuses to come out. I am negotiating with the clay. I am actually talking to the clay, why you refuse to come out, why you refuse to be stiff. I don't know. I am just trying, but still the clay is waiting for my touch. What will happen, I don't know. And the art of clay modeling, it seems is, the pressure you give with the thumb. The marks of the, sweep should remain there.
I think when you see an artist work on something with such patience, with such passion and with such love, it breaks my heart to even interfere. But because we're running on a schedule, I have to step in. But I'm still curious to know what you make out of this.
As I told you, the clay refuses to, come out as I think. Because it has to be wet and it has to be dry, and somehow I have to negotiate.
But I think that's the beauty of imperfection, isn't it?
Thank you. Thank you for that. Did you hear? You don't have time? Okay.
Please put your hands together.
Do much. I can do much here. I can do much here. I can shape it again and again. It will take time.
I think...
but generally it was just a monologue with a clay lump. Thank you so much.
I was just about to say, it's not just what his hands were doing or the technicalities that he was giving to us. There was a certain kind of poetry in the way he was talking about his art form, and that was absolutely beautiful, and it was an absolute blessing to watch you do your work, sir.
Thank you. Thank you.
Please give him a loud round of applause, ladies and gentlemen. Dr. C.S. Jairam.
Thank you.
And anybody who wants to experience this art form, anybody who wants to actually give this a shot, because this really, really looks like therapy, please, I think you should get in touch with him. He'll be around. If I'm not wrong, you'll be here, no?
And and clay teaches that we all return to clay like this in the end. Thank you so much.
Thank you so much, sir. I would like to call Mr. Mache to please come forward to hand over a memento to Dr. C.S. Jairam.
Okay. You can hand over the memento here because I need time to wash my hands. Thank you, sir. Thank you.
Thank you.
Thank you so much.
Thank you so much.
നല്ലൊരു കൈയടി കൊടുക്കാം എല്ലാവരും.
Thank you so much. I'm deeply touched. Okay.
For introducing clay to children,
Thank you
and to
so
people,
much.
and thanks in the name of the clay for all the emotions you give to the clay.
Thank you so much. Thank you so much. Thank you.
എനിക്ക് തോന്നുന്നു എല്ലാവരും ജയറാം സാറിൻ്റെ ആ സംസാരിക്കുന്ന രീതിയും ആ പോട്രി ഹാൻഡിൽ ചെയ്യുന്നതിൻ്റെ രീതിയും ഒക്കെ കണ്ട് ഭയങ്കര ഒരു ശാന്തതയിലോട്ട് കയറിപ്പോയെന്ന് തോന്നുന്നു. Are you still here with me? I still genuinely can't hear you. Are you still here with me? All right, good. ഭക്ഷണമൊക്കെ ഉണ്ട്, ഭക്ഷണം നമ്മൾ എത്തിക്കും, ഞാൻ അവിടെ വരെ നിങ്ങൾ എത്തിക്കും എന്തായാലും. So while they are cleaning up here, thank you once again, Jairam sir.
Thank you, thank you.
While they are cleaning up here, it fills me with immense joy, and this feels very, very special to call upon stage the next person, because he's a very dear friend, and it's not every day that you get to introduce your friend to a stage. Next we have Rizwan, who is a makeup artist, who has made his way through the industry with his own style of nude makeup art. And he has worked with a lot of prominent faces, prominent names. And we touched on technology, we touched on therapy, mental health, art. It also is a part of taking care of yourself, of looking your best is also a part of taking care of yourself, if I'm not wrong. So I would like to welcome Rizwan on stage to talk to you about how beauty trespasses any age and how you can take care of yourself. Ladies and gentlemen, put your hands together for Rizwan.
Hey all, thank you so much. I'm so happy and proud to be here. Thank you Neetu for the introduction. Yeah, so I'm so happy. ഇവിടെ ഈ ഹെൽത്തി ഏജിങ് എന്നുള്ള പോയിന്റ് ഓഫ് വ്യൂ ഉള്ളവർ മാത്രമേ ഇവിടെ ഇന്ന് ഈ ഹാളിലുള്ളൂ. ആൻഡ് ടോക്കിംഗ് അബൌട്ട് മേക്കപ്പ് ആസ് എ മേക്കപ്പ് ആർട്ടിസ്റ്റ്, മേക്കപ്പ് ഇസ് എന്താ, നമ്മൾ എപ്പോഴും മേക്കപ്പ് ഒരു പോയിന്റ് ഓഫ് ഏജ് കഴിഞ്ഞാൽ നമ്മൾ വിചാരിക്കും എന്തിനാണ് മേക്കപ്പ് ചെയ്യുന്നത്, ഇനി ഭംഗിയായിട്ട് നടന്നിട്ടൊക്കെ എന്തിനാ ഇങ്ങനെയൊക്കെ പോരെ എന്നുള്ള തോട്ട് ഓഫ് മെൻറ്റാലിറ്റി ഉള്ള ഒരുപാട് പേരുണ്ട് ഈ ഏജിലുള്ളവർ. പക്ഷേ ബ്ലസ്സിലുള്ളവരെല്ലാവരും അടിപൊളിയാണെന്ന് എനിക്കറിയാം. സോ മേക്കപ്പ് എന്താണ് മേക്കപ്പ് എന്ന് ഞാൻ ആദ്യം പറയാം. മേക്കപ്പ് ഈസ് നോട്ട് എ ടൂൾ ടു മേക്ക് യു ബ്യൂട്ടിഫുൾ ഓർ ഹാൻസം. നിങ്ങളെ ഭംഗിയാക്കാനോ അല്ല വേറൊരാളെ പോലെ അല്ലെങ്കിൽ ഒരു ഡോളിനെ പോലെ ആക്കാനുള്ള ഒരു ടൂളല്ല മേക്കപ്പ്. ജസ്റ്റ് ടു മേക്ക് ആൻഡ് ജസ്റ്റ് ടു ബൂസ്റ്റ് യുവർ കോൺഫിഡൻസ്, അല്ലെങ്കിൽ കുറച്ചുകൂടി പ്രസൻറ്റബിൾ ആയിട്ടിരിക്കുക, അതൊക്കെയാണ് മേക്കപ്പിനെ കൊണ്ടുള്ള ഉദ്ദേശം. സോ എനിക്ക് തോന്നുന്നു ഒരു പോയിന്റ് ഓഫ് ഏജ് കഴിയുമ്പം ഒരുവിധം അമ്മമാരും അച്ഛന്മാരും ആരും വെൽ ഡ്രസ്ഡ് ആയിട്ട് നടക്കാനോ അല്ലെങ്കിൽ മേക്കപ്പ് ചെയ്യാനോ ആഗ്രഹിക്കാത്ത ആൾക്കാരാണ്. വേറെ ഒന്നും കൊണ്ടല്ല, നമുക്ക് നമ്മളോട് തന്നെ ഒരു സെൽഫ് ലവിൻ്റെ ഒരു ലാക്ക് ഓഫ് സെൽഫ് ലവ് ഒരു പോയിന്റ് ഓഫ് ഏജിൽ വരുന്നു എന്ന് എനിക്ക് തോന്നുന്നു. നോട്ട് ഹിയർ. ആൻഡ് അവിടെയാണ് നമുക്ക് തെറ്റ് പറ്റുന്നത്. and that this is the time to think on it. And I can confidently say you that you guys all are so beautiful. And aging എങ്ങനെ ഹെൽത്തി ഏജിങ് ആക്കാം? ലേഡീസ് ആൻഡ് ജെന്റിൽമാൻ, ഇവിടെ ഒരുപാട് ഈ ഇൻഡസ്ട്രിയിൽ വർക്ക് ചെയ്യുന്നതാണ്. ഞാൻ പാസ്റ്റ് 3 years ആയിട്ട് മേക്കപ്പ് ഇൻഡസ്ട്രിയിലാണ് വർക്ക് ചെയ്യുന്നത്, ഫിലിം ഇൻഡസ്ട്രിയിലാണ് വർക്ക് ചെയ്യുന്നത്. ഐ നോ ദാറ്റ് നിങ്ങളുടെ ഏജിലുള്ള ഒരുപാട് മോഡൽസിൻ്റെ കുറവുണ്ട് നമ്മുടെ നാട്ടിൽ. ആൻഡ് ഇവിടെ ഞാൻ ലാസ്റ്റ് വർക്ക് ചെയ്തിട്ട് നിങ്ങളെ കൂടെ ഷൂട്ട് ചെയ്തിട്ടുണ്ടായിരുന്നു. അപ്പം ഇവിടെ ഒരുപാട് അമ്മമാരെ എനിക്കറിയാം. ഗ്ലാഡിസ് ആൻറ്റി, മരിയാം ആൻറ്റി, ഫിലോമിന ആൻറ്റി, സുനിത ആൻറ്റി, എവ്രി വൺ. ദേ ആർ സോ ടാലൻറ്റഡ് ആൻഡ് ദേ ആർ സോ എനർജറ്റിക്. എനിക്കും എക്സ്പീരിയൻസ് ചെയ്യണമെന്നുണ്ടായിരുന്നു ഇവിടെ അന്ന് ഷൂട്ട് ചെയ്ത സമയത്ത്. എങ്ങനെയാണ് ഈ ഏജിലുള്ള ആൾക്കാർ കൂടെ ഞാൻ ഇതുവരെ വർക്ക് ചെയ്തിട്ടില്ല, എങ്ങനെയായിരിക്കും അവർ റിയാക്ട് ചെയ്യുക മേക്കപ്പിനോട് എന്നൊക്കെ അറിയണമെന്നുണ്ടായിരുന്നു. ആൻഡ് ഐ വെൻറ്റ് ബാക്ക് വിത്ത് എ ബഞ്ച് ഓഫ് ബ്യൂട്ടിഫുൾ മെമ്മറീസ് ആൻഡ് ഐ ഫെൽറ്റ് സോ ഗുഡ് ടു വർക്ക് ഹിയർ. ആൻഡ് ബേസിക്കലി സ്കിൻ കെയറും അല്ലെങ്കിൽ മേക്കപ്പ് ഒന്നും ചെയ്യാൻ താല്പര്യപ്പെടാത്ത അമ്മമാരോട് എനിക്ക് ഹംബിളായിട്ട് പറയാനുള്ളത്, ജസ്റ്റ് ഡു യുവർ സ്കിൻ കെയർ എവറി ഡേ. നിങ്ങളുടെ മനസ്സ് പോലെ തന്നെ സ്കിന്നും ബോഡിയും ഒക്കെ ഹെൽത്തി ആയിട്ട് കീപ്പ് ചെയ്യുക. ആൻഡ് ക്ലെൻസ് യുവർ ഫേസ് എവറി ഡേ. മസാജ് യുവർ ഫേസ് ജെന്റ്ലി. റിങ്കിൾസും ആൻറ്റി ഏജിങ് ഒക്കെ ആയിട്ട് ആൻറ്റി ഏജിങ് sorry. Yeah. And I'm not familiar with this. ഈ പോഡിയവും മൈക്കും ഇങ്ങനത്തെ സിറ്റുവേഷനോടൊന്നും അത്ര ഫെമിലിയർ അല്ല. അതുകൊണ്ടാണ് ഇടയ്ക്ക് കയ്യിൽ പോകുന്നത്. ഐ എം സോറി. ആൻഡ് പ്ലീസ് ഡു, ഇവിടെയുള്ള ഞാൻ വർക്ക് ചെയ്തതും അല്ലാത്തതും ആയിട്ടുള്ള എല്ലാ അമ്മമാരോടും എനിക്ക് പറയാനുള്ളതാണ്, പ്ലീസ് ഡു സ്കിൻ കെയർ എവറി ഡേ. എന്നും രാത്രി കുറച്ച് മോയ്സ്ചറൈസർ ആൻഡ് സൺസ്ക്രീൻ, ജസ്റ്റ് ബേസിക് ആയിട്ടുള്ള. ഓൾവേസ് കീപ് യുവർ ബോഡി ഹൈഡ്രേറ്റഡ് ആൻഡ് ഡു വാട്ട് എവർ യു വോണ്ട്. എന്നും നിങ്ങൾക്ക് എപ്പോഴും, എനിക്കറിയാം ഇവിടുത്തെ ഗ്ലാഡിസ് ആൻറ്റിക്ക് ആണെങ്കിലും ദേ ആർ സോ എനർജറ്റിക്. നമ്മളെ കൂടെ ഷൂട്ട് ചെയ്യാനാണെങ്കിലും ഷൂട്ട് ചെയ്ത എക്സ്പീരിയൻസ് ആണെങ്കിലും അവരുടെ കൂടെയുള്ള ലൈഫ് എക്സ്പീരിയൻസ് ഒക്കെ ഷെയർ ചെയ്തിട്ട്, ഞാൻ ഇവിടെ ഫസ്റ്റ് ബ്ലസ്സിൽ വന്ന ഡേ ദേ വർ പ്രാക്ടീസിങ് റാമ്പ് വാക്ക് അറ്റ് ദിസ് ഏജ്. ഞാൻ ബ്ലസ്സിൽ വന്നപ്പോൾ എനിക്ക് തന്നെ തോന്നിപ്പോയി കുറച്ച് പ്രായമായിട്ടൊന്ന് റിട്ടയർമെൻ്റ് ആയിട്ട് വേണം ഇങ്ങനത്തെ ഒരു ലൈഫ് എൻജോയ് ചെയ്യാനെന്ന്. ബിക്കോസ് ഐ എം സോ ഹാപ്പി. ആൻഡ് യാ, ലാസ്റ്റ് 2 weeks മുന്നേ നമ്മൾ ചെയ്തൊരു ഷൂട്ടിൻ്റെ ചെറിയൊരു ക്ലിപ്പ്, യാ ഇറ്റ്സ് ഓൾറെഡി പ്ലേയിങ്. സോ ദാറ്റ് വാസ് എ ഷൂട്ട്. ആൻഡ് യാ, താങ്ക് യു ഫോർ ഹാവിങ് മീ ഹിയർ. So happy to be here. Yeah, thank you so much. Yeah, okay.
Rizwan is somebody who works in the makeup industry. അവിടെ നമുക്ക് ഒത്തിരി ഒന്നും സംസാരിക്കേണ്ട വരാറില്ല. സാധാരണ ഇങ്ങനെ സ്റ്റേജിൽ കയറി പ്രസംഗങ്ങളും പറയേണ്ട ആവശ്യം വരാറില്ല. എങ്കിലും ഇങ്ങനെ ഒരു പരിപാടിക്ക് വിളിച്ചപ്പോൾ ഐ വോണ്ട് ടു അഡ്രസ് എ ഗാദറിംഗ് ലൈക്ക് ദിസ് എന്ന് പറഞ്ഞ് ഉള്ള ധൈര്യം മൊത്തം പിടിച്ചു നിർത്തിയിട്ടാണ് ഇവിടെ ഒരാൾ നിൽക്കുന്നത്. സോ പ്ലീസ് ഗിവ് ഹിം എ ഗുഡ് റൗണ്ട് ഓഫ് അപ്ലോസ്. താങ്ക് യു ഫോർ ബീയിങ് ഹിയർ വിത്ത് us today. And to hand over a small memento to Rizwan, I would like to call on stage Dr. Mariamma, who is a resident of Bliss Home and a wonderful personality in every way possible, who has an immense career behind her. Mariamma auntie, please come on stage. Thank you. മറിയാമ്മാൻ്റെക്ക് തന്നെ നല്ലൊരു കയ്യടി കൊടുക്കണം. അത് ഞാൻ നിങ്ങളെ കൊണ്ട് പറഞ്ഞ കയ്യടി കൊടുപ്പിക്കേണ്ട ആവശ്യമൊന്നുമില്ല. Dr. Mariamma is somebody you should definitely also get to know in the process of the next 2 days. She has a lot of stories to tell you and a lot of experience to share with you. Thank you so much, Mariamma, for giving the award, the memento to him. Thank you, Rizwan. Thank you, Dr. Mariamma. So, എല്ലാവരുടെയും കയ്യടിയുടെ ശക്തിയുടെ ഒക്കെ ഒരു മീറ്റർ വെച്ചിട്ട് ഐ ഫീൽ ലൈക്ക് എവ്രി വൺസ് ഇസ് സ്ലോലി ഫീലിംഗ് എ ലിറ്റിൽ ഹംഗ്രി. ആം ഐ റൈറ്റ്? ഭക്ഷണം വേണമെന്ന് ചോദിക്കുമ്പോഴെങ്കിലും ഒരു ഉത്തരം തരുമോ? വിശക്കുന്നുണ്ടോ? ഉണ്ട്. ഓക്കെ. So we are going to have lunch, and after lunch, which will be a quick lunch because we are all running on a schedule right now, we'll have a very elaborate dinner where everyone can socialize and have time to meet each other. So I request all of you to please quickly go and grab all of your lunches, and I think we should be back here by 2 o'clock. 2 മണി ആവുമ്പോൾ if I can see you back in the hall, it would be lovely. Enjoy your lunch, and I'll see you back in half an hour.
Like I did, or used to say, I would never fall in love again until I found her. I said I would never fall unless it's you I fall into. I was lost within the darkness, but then I found her. I found you. Georgia pulled me in, I asked to love her. Once again you fell, I caught ya. I'll never let you go again like I did, or I used to say. I would never fall in love again until I found her. I said I would never fall unless it's you I fall into. I was lost within the darkness, but then I found her. I found you. I would never fall in love again until I found her. I said I would never fall unless it's you I fall in like I did, or used to say. I would never fall in love again until I found her. I said I would never fall unless it's you I fall into. I was lost within the darkness, but then I found her. I found you. Georgia pulled me in, I asked to love her. Once again you fell, I caught ya. I'll never let you go again like I did, or I used to say. I would never fall in love again until
Lifeguard Digital Health is proud to present Intellicare with life-saving alerts for senior facilities. The system has 3 parts: a state-of-art wearable device for the resident, a tablet for the resident apartment, and a monitoring tablet for the staff. Staff will receive emergency alerts from residents and communicate with them wherever they are within the senior facility premises. Intellicare sends emergency alerts for fall detection. When a resident falls, the watch will auto-detect the fall and the admin desk will receive the alert, so they can respond immediately. Intellicare has geofence alerts. If a resident leaves the facility premises, the staff will be alerted with the location of the resident and can communicate with the resident. Intellicare can monitor residents' vital signs. When a wearable device is worn by the resident, it monitors their vital signs and will report to the staff, so they can check on resident vitals anytime from the admin tablet. Staff and residents can message each other. Staff can message residents with important information. And residents can give feedback to staff. Finally, staff and residents can communicate with voice and video calls. Staff can call residents on their tablet in their room or on their wearable. In the event of an emergency, residents can call staff directly from the wearable at any time. Life-saving alerts for senior facilities. Intellicare powered by Lifeguard Digital Health Inc.
Autumn years in a person's life are equally to be cherished. Quite often, the hand that rocked the cradle is left clueless about how to live the rest of their lives. The reason may vary: the kin settling abroad, nuclear family preferences, or wanting personal space for them. These reasons contributed in the setting up of Atulya, a premium independent assisted living for the elderly. Based on the concept of harmonious community living, Atulya provides customized assisted living to its members. The homes are ergonomically designed, keeping in mind the needs of the elderly. Right from the carpet to the ceiling, the interior design has been crafted after conducting a thorough research on assisted living trends that are popular worldwide. The floors at Atulya are non-slippery. The state-of-the-art adjustable beds provide optimum comfort. Railings are provided wherever required, as we understand that even minor injuries may cause serious health complications. Emergency call buttons provided near the bedside ensures that precious time is not wasted in case of any medical emergency. Some of the unique features include round-the-clock medical care, providing healthy food options curated by dietitians. In addition, we at Atulya also provide rental ownership, where a person gets to choose his or her duration of stay. Atulya provides internet and video conferencing facilities to connect with their loved ones. Atulya is centrally located and one has easy access to the best hospitals and healthcare services which are at close proximity. We at Atulya ensure a cheerful and dignified living for the elderly by redefining the living standards and enhancing the quality of life.
രോഗത്തിനുള്ള പ്രതിവിധി തേടുന്നതിനേക്കാൾ നല്ലത് രോഗത്തെ പ്രതിരോധിക്കലാണ്. ചെറിയ അസുഖങ്ങൾക്ക് പോലും ഇന്ന് നാം ആശ്രയിക്കുന്ന മരുന്നുകളുടെ പാർശ്വഫലം എത്ര വലുതാണെന്ന് പലരും ഓർക്കാറില്ല. ഇവിടെയാണ് ബയോമാഗ്നറ്റിക് തെറാപ്പി ശ്രദ്ധേയമാകുന്നത്. ബയോമാഗ്നറ്റിക് പ്രോഡക്റ്റുകൾ ഉപയോഗിച്ചുകൊണ്ട് വരാനിരിക്കുന്ന ജീവിതശൈലി രോഗങ്ങളെ പ്രതിരോധിക്കുവാനും നിലവിലുള്ള രോഗങ്ങൾക്ക് പരിഹാരം കണ്ടെത്താനും സാധിക്കുന്നു. ഇൻഫ്ലുവൻസിയ ബയോമാഗ്നറ്റിക് മാട്രസ് പാഡ്, പില്ലോ പാഡ്, റിസ്റ്റ് ബാൻഡ്, വാട്ടർ ബോട്ടിൽ പാഡ്, റിലാക്സിംഗ് പാഡ്, ഇത്തരം ബയോമാഗ്നറ്റിക് പ്രോഡക്റ്റുകൾ എങ്ങനെ നമ്മുടെ ശരീരത്തിൽ പ്രവർത്തിക്കുന്നു എന്ന് നോക്കാം. മനുഷ്യ ശരീരത്തിലെ 99% രോഗങ്ങൾക്കും പ്രധാന കാരണം ശരിയായ രീതിയിലുള്ള ബ്ലഡ് സർക്കുലേഷൻ അഥവാ രക്തചംക്രമണം നടക്കാത്തതാണ്. ശരീരത്തിലെ സെല്ലുകൾക്ക് ആവശ്യമായ ന്യൂട്രിയൻസും ഓക്സിജനും എത്തിച്ചു നൽകുന്ന ജീവനുള്ള ടിഷ്യൂ ആണ് രക്തം. രക്തത്തിലെ ഹീമോഗ്ലോബിനിലെ പ്രധാന ഘടകമാണ് അയൺ. നാനോ ടെക്നോളജി ഉപയോഗിച്ച് മെഡിക്കൽ ഗ്രേഡ് മാഗ്നറ്റുകൾ സയൻറ്റിഫിക്കലി സെറ്റ് ചെയ്തിരിക്കുന്ന ഇൻഫ്ലുവൻസിയ ബയോമാഗ്നറ്റിക് മാട്രസ് പാഡ് ഉപയോഗിക്കുമ്പോൾ ഇതിലുള്ള മാഗ്നറ്റുകൾ ശരീരത്തിലെ ബ്ലഡിലെ അയണുമായി ആകർഷിക്കുകയും സജാതീയ വിജാതീയ ധ്രുവങ്ങളിൽ ഒരു പുഷ് ആൻഡ് പുൾ പ്രവർത്തനം നടക്കുകയും ഇന്നാക്റ്റീവായ ബ്ലഡ് സെല്ലുകളെ ഡീക്ലസ്റ്റർ ചെയ്ത് ചലനശേഷിയുണ്ടാക്കി ആക്റ്റീവാക്കി മാറ്റുന്നു. ഈ സെല്ലുകൾ ഹാർട്ട് ബ്ലഡ് പമ്പ് ചെയ്യുന്നതോടെ ഓരോ മൈക്രോ കാപ്പിലറുകളിലൂടെയും സഞ്ചരിച്ച് വേണ്ടത്ര രക്തചംക്രമണം സാധ്യമാക്കുന്നു. ശരിയായ ബ്ലഡ് സർക്കുലേഷൻ നടക്കുന്നതോടെ ശരീരത്തിലെ കോശങ്ങൾക്ക് ആവശ്യമായ പോഷകങ്ങൾ, ഓക്സിജൻ, ഹോർമോണുകൾ, വൈറ്റമിനുകൾ, ആൻറ്റിബോഡികൾ, ഇലക്ട്രോലൈറ്റുകൾ എന്നിവ കൃത്യമായി ലഭിക്കുകയും സെല്ലുകളെ പ്രവർത്തനക്ഷമമാക്കിക്കൊണ്ട് ശരീരത്തിൻ്റെ പ്രതിരോധശേഷി വർദ്ധിപ്പിക്കുകയും ശരീരത്തിനുള്ളിലെ ഡിസോർഡറുകളെ സ്വയം കറക്റ്റ് ചെയ്യാനുള്ള സെൽഫ് ഹീലിംഗ് പ്രോപ്പർട്ടീസ് വർദ്ധിപ്പിക്കുകയും ചെയ്യുന്നു. ബയോമാഗ്നറ്റിക് വാട്ടർ ബോട്ടിൽ പാഡ് കവർ ചെയ്ത ബോട്ടിലുള്ള വെള്ളം മാഗ്നറ്റൈസ്ഡ് വാട്ടറായി മാറുന്നു. ഇത് വെള്ളത്തിൻ്റെ സാധാരണ ഘടനയെ ലഘൂകരിക്കുന്നു അഥവാ മൈക്രോ ക്ലസ്റ്ററിംഗ് നടത്തുന്നു. ഇത് സെല്ലുകളുടെ ആഗിരണശേഷി വർദ്ധിപ്പിക്കുകയും ഓക്സിജൻ ശരിയായ രീതിയിൽ സെല്ലുകൾക്ക് ലഭിക്കാനും സെല്ലുകളുടെ ശ്വസനം അഥവാ സെൽ റെസ്പിറേഷന് സഹായിക്കുകയും ചെയ്യുന്നു. മനുഷ്യ ശരീരത്തിൻ്റെ 70% ജലമായതുകൊണ്ട് തന്നെ മാഗ്നറ്റൈസ്ഡ് വാട്ടർ ഉപയോഗിക്കുന്നതിലൂടെ ശരിയായ ദഹനവും അസിഡിറ്റി, അൾസർ പോലുള്ള അവസ്ഥയെ ഇല്ലാതാക്കാനും സഹായിക്കുന്നു. ഇൻഫ്ലുവൻസിയ ബയോമാഗ്നറ്റിക് പ്രോഡക്റ്റുകൾ ഹാർട്ട് അറ്റാക്ക്, സ്ട്രോക്ക്, ഡിമെൻഷ്യ, അൾഷിമേഴ്സ്, ന്യൂറോ പ്രോബ്ലംസ്, ത്വക്ക് രോഗങ്ങൾ, മുടികൊഴിച്ചിൽ തുടങ്ങി 100-ലധികം രോഗങ്ങളെ പ്രതിരോധിക്കാനും നിലവിലുള്ള രോഗങ്ങളുടെ തീവ്രത കുറയ്ക്കാനും സഹായിക്കുന്നു. 100% റിസൾട്ടുള്ള ജസ്പേഡ് ഇന്റർനാഷണൽ ഇൻഫ്ലുവൻസിയ പ്രീമിയം ബയോമാഗ്നറ്റിക് പ്രോഡക്റ്റുകൾ ഉപയോഗിച്ചുകൊണ്ട് ആരോഗ്യമുള്ള ഒരു ജീവിതം ഉറപ്പാക്കൂ. വിഷ് യു എ ഹെൽത്തി ആൻഡ് ഹാപ്പി ലൈഫ്.
This evergreen hillock is in the suburbs of the emerging metropolis of Kochi in Kerala. A blissful heaven of a close-knit community of happy and agile senior citizens. In a short span, since its genesis in the year 2011, has emerged as premium geriatric friendly seniors, about winning the accolades of many around the world. A highlight of Bliss retirement living is that all the properties within the premises are scientifically and professionally designed for a cheerful retirement life.
കുറെ നേരമല്ലോ ചൊറിയാൻ തുടങ്ങിയിട്ട് ഒന്ന് കുളിച്ചൂടെ?
ഓ ചൊറിയണ വർത്താനം പറയല്ലേ ചേട്ടാ. ഇന്നലെ SI കോമൾ സാറിന്റെ വീട്ടിൽ പണിക്ക് ശേഷം തുടങ്ങിയതാ.
വെറുതെ അല്ല, വല്ല ആപ്പോ ഊപ്പ പ്ലൈവുഡോ MDF ആയിരിക്കും. ഇനിയെങ്കിലും ജാക്ക് വുഡ്, സൂപ്പർ ഡി, ഹാർഡ് വുഡ്, MDF ഉള്ളെടുത്ത് നീ പണിയാൻ പോകാം.
അനുഗ്രഹീതമാമീടത്തിൽ അലിവോടെ ഞങ്ങൾക്കേകണേ സ്നേഹവും നിൻല.
Bliss Retirement Living is a non-conventional home for retirees. This project was born from the conviction that the elders have the right to live their golden years in a safe and dignified environment. Bliss provides suitable services and facilities to achieve this goal. Residents do not have to worry about preparing food, cleaning, or doing household chores. Housekeeping is taken care of. Waiters serve morning coffee, breakfast, and meals, and the residents get a comforting sense of routine, assurance, and relaxation. They can enjoy meals together in the communal dining space, fostering community feeling, bonding, and belonging as they share stories and experiences. 8 years ago, the founders of Bliss embarked on this ambitious and pioneering project and created a stimulating and energizing community for retirees. But bringing this dream to fruition was far from easy. According to Babu Joseph, the chairman of Bliss Retirement Living, the biggest challenge was changing the negative public perception of homes for the elderly. The promoters challenged negative stereotypes by establishing a new paradigm for senior living. They created an elder-friendly, aesthetically pleasing.
Lifeguard Digital Health is proud to present Intellicare with life-saving alerts for senior facilities. The system has 3 parts: a state-of-art wearable device for the resident, a tablet for the resident apartment, and a monitoring tablet for the staff. Staff will receive emergency alerts from residents and communicate with them wherever they are within the senior facility premises. Intellicare sends emergency alerts for fall detection. When a resident falls, the watch will auto-detect the fall and the admin desk will receive the alert.
ഹലോ. ഭക്ഷണം കഴിച്ച് കഴിഞ്ഞെങ്കിൽ പുറത്ത് നിൽക്കുന്ന എല്ലാവരോടും ഞാൻ ഉള്ളിലേക്ക് കയറാനായിട്ട് റിക്വസ്റ്റ് ചെയ്യാണ്. Once you're done with your lunch, I request all of you to please come in and take your seats so we can continue with the session for the afternoon. I request also the volunteers to please inform the people outside that they can take their food inside as well. So please let them know they can continue their lunch inside if they would like to.
രോഗത്തിനുള്ള പ്രതിവിധി തേടുന്നതിനേക്കാൾ നല്ലത് രോഗത്തെ പ്രതിരോധിക്കലാണ്. ചെറിയ അസുഖങ്ങൾക്ക് പോലും ഇന്ന് നാം ആശ്രയിക്കുന്ന മരുന്നുകളുടെ പാർശ്വഫലം എത്ര വലുതാണെന്ന് പലരും ഓർക്കാറില്ല. ഇവിടെയാണ് ബയോമാഗ്നറ്റിക് തെറാപ്പി ശ്രദ്ധേയമാകുന്നത്. ബയോമാഗ്നറ്റിക് പ്രോഡക്റ്റുകൾ ഉപയോഗിച്ചുകൊണ്ട് വരാനിരിക്കുന്ന ജീവിതശൈലി രോഗങ്ങളെ പ്രതിരോധിക്കുവാനും നിലവിലുള്ള രോഗങ്ങൾക്ക് പരിഹാരം കണ്ടെത്താനും സാധിക്കുന്നു. ഇൻഫ്ലുവൻസിയ ബയോമാഗ്നറ്റിക് മാട്രസ് പാഡ്, പില്ലോ പാഡ്, റിസ്റ്റ് ബാൻഡ്, വാട്ടർ ബോട്ടിൽ പാഡ്, റിലാക്സിംഗ് പാഡ്, ഇത്തരം ബയോമാഗ്നറ്റിക് പ്രോഡക്റ്റുകൾ എങ്ങനെ നമ്മുടെ ശരീരത്തിൽ പ്രവർത്തിക്കുന്നു എന്ന് നോക്കാം. മനുഷ്യ ശരീരത്തിലെ 99% രോഗങ്ങൾക്കും പ്രധാന കാരണം ശരിയായ രീതിയിലുള്ള ബ്ലഡ് സർക്കുലേഷൻ അഥവാ രക്തചംക്രമണം നടക്കാത്തതാണ്. ശരീരത്തിലെ സെല്ലുകൾക്ക് ആവശ്യമായ ന്യൂട്രിയൻസും ഓക്സിജനും എത്തിച്ചു നൽകുന്ന ജീവനുള്ള ടിഷ്യൂ ആണ് രക്തം. രക്തത്തിലെ ഹീമോഗ്ലോബിനിലെ പ്രധാന ഘടകമാണ് അയൺ. നാനോ ടെക്നോളജി ഉപയോഗിച്ച് മെഡിക്കൽ ഗ്രേഡ് മാഗ്നറ്റുകൾ സയന്റിഫിക്കലി സെറ്റ് ചെയ്തിരിക്കുന്ന ഇൻഫ്ലുവൻസിയ ബയോമാഗ്നറ്റിക് മാട്രസ് പാഡ് ഉപയോഗിക്കുമ്പോൾ ഇതിലുള്ള മാഗ്നറ്റുകൾ ശരീരത്തിലെ ബ്ലഡിലെ അയണുമായി ആകർഷിക്കുകയും സജാതീയ വിജാതീയ ധ്രുവങ്ങളിൽ ഒരു പുഷ് ആൻഡ് പുൾ പ്രവർത്തനം നടക്കുകയും ഇന്നാക്റ്റീവായ ബ്ലഡ് സെല്ലുകളെ ഡീക്ലസ്റ്റർ ചെയ്ത് ചലനശേഷിയുണ്ടാക്കി ആക്റ്റീവാക്കി മാറ്റുന്നു. ഈ സെല്ലുകൾ ഹാർട്ട് ബ്ലഡ് പമ്പ് ചെയ്യുന്നതോടെ ഓരോ മൈക്രോ കാപ്പിലറുകളിലൂടെയും സഞ്ചരിച്ച് വേണ്ടത്ര രക്തചംക്രമണം സാധ്യമാക്കുന്നു. ശരിയായ ബ്ലഡ് സർക്കുലേഷൻ നടക്കുന്നതോടെ ശരീരത്തിലെ കോശങ്ങൾക്ക് ആവശ്യമായ പോഷകങ്ങൾ, ഓക്സിജൻ, ഹോർമോണുകൾ, വൈറ്റമിനുകൾ, ആന്റിബോഡികൾ, ഇലക്ട്രോലൈറ്റുകൾ എന്നിവ കൃത്യമായി ലഭിക്കുകയും സെല്ലുകളെ പ്രവർത്തനക്ഷമമാക്കിക്കൊണ്ട് ശരീരത്തിന്റെ പ്രതിരോധശേഷി വർദ്ധിപ്പിക്കുകയും ശരീരത്തിനുള്ളിലെ ഡിസോർഡറുകളെ സ്വയം കറക്റ്റ് ചെയ്യാനുള്ള സെൽഫ് ഹീലിംഗ് പ്രോപ്പർട്ടീസ് വർദ്ധിപ്പിക്കുകയും ചെയ്യുന്നു. ബയോമാഗ്നറ്റിക് വാട്ടർ ബോട്ടിൽ പാഡ് കവർ ചെയ്ത ബോട്ടിലുള്ള വെള്ളം മാഗ്നറ്റൈസർ വാട്ടറായി മാറുന്നു. ഇത് വെള്ളത്തിന്റെ സാധാരണ ഘടനയെ ലഘൂകരിക്കുന്നു അഥവാ മൈക്രോ ക്ലസ്റ്ററിംഗ് നടത്തുന്നു. ഇത് സെല്ലുകളുടെ ആഗിരണശേഷി വർദ്ധിപ്പിക്കുകയും ഓക്സിജൻ ശരിയായ രീതിയിൽ സെല്ലുകൾക്ക് ലഭിക്കാനും സെല്ലുകളുടെ ശ്വസനം അഥവാ സെൽ റെസ്പിറേഷന് സഹായിക്കുകയും ചെയ്യുന്നു. മനുഷ്യ ശരീരത്തിന്റെ 70% ജലമായതുകൊണ്ട് തന്നെ മാഗ്നറ്റൈസ്ഡ് വാട്ടർ ഉപയോഗിക്കുന്നതിലൂടെ ശരിയായ ദഹനവും അസിഡിറ്റി, അൾസർ പോലുള്ള അവസ്ഥയെ ഇല്ലാതാക്കാനും സഹായിക്കുന്നു. ഇൻഫ്ലുവൻസിയ ബയോമാഗ്നറ്റിക് പ്രോഡക്റ്റുകൾ ഹാർട്ട് അറ്റാക്ക്, സ്ട്രോക്ക്, ഡിമെൻഷ്യ, അൾഷിമേഴ്സ്, ന്യൂറോ പ്രോബ്ലംസ്, ത്വക്ക് രോഗങ്ങൾ, മുടികൊഴിച്ചിൽ തുടങ്ങി 100-ലധികം രോഗങ്ങളെ പ്രതിരോധിക്കാനും നിലവിലുള്ള രോഗങ്ങളുടെ തീവ്രത കുറയ്ക്കാനും സഹായിക്കുന്നു. 100% റിസൾട്ടുള്ള ജസ്പേഡ് ഇന്റർനാഷണൽ ഇൻഫ്ലുവൻസിയ പ്രീമിയം ബയോമാഗ്നറ്റിക് പ്രോഡക്റ്റുകൾ ഉപയോഗിച്ചുകൊണ്ട് ആരോഗ്യമുള്ള ഒരു ജീവിതം ഉറപ്പാക്കൂ. വിഷ് യു എ ഹെൽത്തി ആൻഡ് ഹാപ്പി ലൈഫ്.
This evergreen hillock is in the suburbs of the emerging metropolis of Kochi in Kerala.
I request once again everybody who has already had their lunch to please come inside the hall. ലഞ്ച് കഴിച്ചു കഴിഞ്ഞ എല്ലാവരോടും ഒന്നും കൂടി ഞാൻ റിക്വസ്റ്റ് ചെയ്യാണ് ഉള്ളിലേക്ക് കസേരകളിലേക്ക് കയറി ഇരിക്കാനായിട്ട്. We have a very packed schedule to catch up on. And I once again request the volunteers to please inform them that we're about to start our session and we require all of them to be inside the hall.
In a short span, since its genesis in the year 2011, has emerged as premium geriatric friendly seniors, about winning the accolades of many around the world. A highlight of Bliss retirement living is that all the properties within the premises are scientifically and professionally designed for a cheerful retirement life.
All right. So I hope എല്ലാവരും കുറച്ച് ഭക്ഷണമൊക്കെ കഴിച്ച് കുറച്ചും കൂടി ആരോഗ്യമൊക്കെ വെച്ചിട്ടാണ് ഇരിക്കുന്നതെന്ന്. പുറത്ത് കുറച്ച് ആൾക്കാരും കൂടി ഉണ്ട്. We'll give them a few more minutes time to come in. So we have 2 more short sessions which are in tandem with the holistic approach of aging, healthy aging. അപ്പോൾ അടുത്ത സെഷന് വേണ്ടി I am happy to call on stage Ms. Shiona, who is the director of Bliss Retirement Living, and Shanti Bhavan, and she'll introduce Shanti Bhavan to us while Kartu Amma will be doing a small demonstration here, friendile. She'll be doing a small demonstration of her weaving. So can I please have a good round of applause for Shiona to introduce Shanti Bhavan to you.
Hello. Hope everyone's back and settled. Yeah, so just before the lunch break, till now, we saw some wonderful activities for a fulfilling retired life. But we can ask ourselves another questions. Is this accessible and affordable to everyone around us? Are the elders around our neighborhood spending their old age life doing things they really enjoy? Pagalveedu concept, daycare for the elders, is not a new concept to Kerala or India, but when it comes to practicality, there are very few examples which are running successfully. Pagalveedu, which translates to day home, is the idea of a facility for the elderly community of a neighborhood to come together during the daytime when their family is out for work or at school. They come here to spend time with their friends or to even make new friends, do activities, play games, share their personal news, celebrate festivals or special days. Basically, just to have someone by your side to spend the day with, talk and have some fun. Sounds like a very basic necessity, right? Shanti Bhavan is a charity-based vertical of Blessed Life Foundation under the umbrella of Bliss Retirement Living. It was introduced around 10 months ago as an attempt to reach out to the elderly of the local communities around Bliss premises to provide them a daytime solace and a different atmosphere contrary to their usual confinement in the house. At Shanti Bhavan, we offer different kinds of activities to engage the elderly in the daytime and to keep them active. The project's primarily goals were to provide older adults an opportunity to get out of the house and receive both mental and social stimulation, as well as the consistent care and love they need at this age. The typical day at Shanti Bhavan starts with a prayer. After a mindful, relaxing meditation, we conduct newspaper reading session and discuss the current affairs all together. After tea and snacks, we enter into different kinds of brain gym activities that caters to the psychosocial development of the guests. This includes music, dance, art, movie screening, gardening, laughter therapy, which helps in improving self-concept, self-esteem, and to reduce stress, anxiety, and depression, which is drastically seen among this age group as a result of loneliness. This majorly helps with enriching their mental and physical well-being, improves the hand-eye coordination, motor skills, organizational skills, and teamwork, which can be very beneficial even at this age. Through these, we are able to decrease isolation to a great extent. Apart from that, we are providing literacy and numeracy classes to increase the ability to read, write, and understand information. We are providing different types of medical interventions such as diabetics checking camps, health awareness classes, and monthly vitals checkings. We are also doing craft activities using different kinds of items. For the past 3 months, our guests have been busy preparing for this conclave. They've handcrafted a wide range of unique, useful products made with a lot of love. Coconut leaves were plucked, washed, dried, and woven in the traditional method. Coconut shell planters, candles, mats woven out of old saris, coconut leaf baskets, and coasters are all the products we have brought here for sale. So staying healthy and feeling your best is important at any age, but especially as we get older. We should all be able to enjoy healthy aging irrespective of our social and economical background, right? We all have to stay physically and socially active to feel connected to our own communities. Shanti Bhavan has been playing a vital role in maintaining the psychosocial well-being of the elderly in our area. The professional approach from the side of management and staffs makes the project a success, which comes with genuine effort, proper planning, monetary support, and adequate space, all on a consistent basis. I would love to stress on the word consistent and regular basis because that is where a lot of institutions fail. During this short period of time, we were able to create a massive impact on the elderly community. A daycare center provides a safe and secure environment for senior citizens to gather and spend quality time together. Just like the vast number of Anganwadis or daycare for the kids we can see around us, daycare centers in the future will create a healthier senior citizen community. It will create more awareness on issues faced by senior citizens and how to tackle them by indulging elderly to spend their time with others, to talk, to give advice, support, creating a very healthy social and personal attitude itself. The establishment of a daycare center is a crucial step towards reducing social isolation and providing a joyful and positive environment in their own family back home. Behind the hall at stall 11, we have Shanti Bhavan. Our guests from Shanti Bhavan, Mrs. Karthu, Ponnamma, and Tangamma are also here. Atulya Suresh, our project coordinator, Shilpa Mani, our assistant project coordinator, and Bibin Benny, our executive, are also around. So please feel free to contact them and talk to them to know more about how Shanti Bhavan works. Yeah, that's it. And thank you so much, Karthu Amma.
Thank you so much, Yona. All this while she was introducing to you Shanti Bhavan, Karthu Amma was very patiently weaving away. We are a little tight on time, but I still want to give her a second and ask her, Amma, എന്താ ചെയ്യുന്നതെന്നൊന്ന് മൈക്കിലൂടെ പറഞ്ഞേക്കാമോ?
ഞാൻ പായ നെയ്യാ.
എന്ത് ചെയ്യാ?
പായ നെയ്യാ, ചെറിയ പായ.
ചെറിയ പായ നെയ്യാണോ? ഇതിനെക്കുറിച്ച് ഒരു അറിയാത്തവർക്കൊന്ന് പറഞ്ഞു കൊടുക്കുമോ?
പറഞ്ഞു കൊടുക്കാൻ ഇപ്പോൾ സമയമുണ്ടോ? പറഞ്ഞു കൊടുക്കാം.
തിരക്ക് പിടിച്ച് പണിയെടുത്തോണ്ടിരിക്കുന്നതിൻ്റെ ഇടയ്ക്ക് ഞാൻ മൈക്കും കൊണ്ടൊക്കെ ചെല്ലണേ.
എന്താ പറയണ്ടേ? ഇത് ശരിയാക്കട്ടെ. ഇത് ചെയ്തത് 2 ഓല എടുക്കാം. ഒരെണ്ണം അങ്ങനെയും വയ്ക്കാം, ഒരെങ്ങനെയും വയ്ക്കാം, ഒരെങ്ങനെയും വയ്ക്കാം. എന്നിട്ട് ഓരോന്ന് എടുത്ത് നെയ്യാം. ഇല്ല 2-3 ഓല എടുത്ത് ഓരോന്ന് നെയ്യാം, കൂട്ടുക. ഒരേ കാര്യമുള്ളൂ. കഴുതോലയുടെ പായാണത്. നമ്മുടെ സ്റ്റോളിലുണ്ട്.
ഇത്രയും കാര്യമായിട്ട് പറയുന്നത് അമ്മയ്ക്ക് ഇതൊന്നും വലിയ സംഭവമേ അല്ല. ഇത് ഭയങ്കര ഈസി ആയിട്ടുള്ള കാര്യമായതുകൊണ്ടാണ്. അപ്പം കാർത്തമ്മയ്ക്ക് നല്ലൊരു കയ്യടി കൊടുക്കാട്ടോ. സ്റ്റോളിൽ ബാക്കിലുണ്ട്.
Please do go and check that out. So next we have an interactive session as well, which is an interactive session, a music session. And for that, I would like to call on stage Miss Nivedita, who is a playback singer and a beautiful, very talented, gifted artist. Ladies and gentlemen, please put your hands together for Miss Nivedita.
Namaste, everybody. After lunch, everybody sleepy, awake, some noise in the room? Thank you, doctor. Can I have the table? Can anybody imagine a world without music? I can't. Because, doctor, you can second me on this. Even our heartbeat, it's a beat. And when that goes off beat, what happens? There's a lot of problems. Our scriptures, all our scriptures, even the Samaveda, all written in a poetic, rhythmic form. So which is very easy. Our mantras, our Gayatri mantra and all, is very easy to tune because it is already written in a very poetic, rhythmic pattern. There's music all around us. I'm coming from a film background. Neetu, very bad. My introduction was very, I'm a playback singer from Mumbai. So I'm a professional singer from Mumbai. I have done work here. I have done, I was co-hosting Sarigama on AsiaNet, and I've done a film in Malayalam. I am a Malayali, but born and brought up in Mumbai. But I do speak Malayalam. Kannur bhashyaanennu mathre ullu. Pashe Malayalam samsarikku njan. So there's, because I'm coming from a film background, songs are very, very important to me. I'm also a singer, of course. But if you see, every emotion we have is all about some song. We have a song when we're happy, we have a song when we're sad, when we have a song when we're in love, when we have a song when we're in heartbreak. So there is a song for every occasion, for every mood. Like when you talk of romance, I always remember one song. Rafi Saab's voice singing, Deewana hua baadal, saavan ki ghata chhaaye, ye dekh ke dil chhuma le pyar ne angadaye. आगे गाएंगे दीवाना हुआ बादल. So that's romance for me. I'm sure everybody has got a song and then there is a memory associated with that song. Can somebody share a memory? Doctor, why not? Any memory, any song. Merci.
So my best memory about with music has comes from my mom, because she's a playback singer, she's a vocalist, and I remember when growing up with her, in my, when I went to college out of station having the bad separation anxiety, whenever I used to recall the best times I had with my mom, it reminded me of the song that she sings very, very regularly while cooking and preparing meals for me, which goes like this, and I've learned a little from her. लग जा गले के फिर हंसी रात हो न हो, शायद फिर इस जन्म में मुलाकात हो न हो, लग जा गले से. So yeah.
Beautiful, doctor. Is there anybody else with a very fond memory connected to music, connected to singing? We all have memories. Very beautifully sung. One of my favorite songs, like generally. So, yes, music is a part of our life. Apart from that, it's like a meditation. Because when we sing a swara, back me up here again, doctor, you've learned a bit. When we sing a swara, like we're singing, sa, there's full concentration on that particular swara. We are not thinking of anything else. We just cut off every other. We're not thinking of food, we're just thinking, okay, that sa has to be properly sung. So that's kind of a meditation. Apart from that, when we are singing that, there's a deep inhalation. We sa, and it's a very controlled exhalation. So this improves our respiratory functions, respiratory disorders, people have that. It helps. So apart from that, meditation, yes, it's a mood elevator. Right now we sang a song and everybody was like, doctor sang a song and we're very happy. It just boosts our mood, it elevates our mood, and it's just a feel good. So it's a stress buster. You just feel good, and at the same time, it's like a, you're included in a group, you're socializing. So in so many ways, music just helps us to come together. Some auntie said, I sing, but I can sing only in group. But then singing in a group also is about getting together, being a part of a group. The isolation, the loneliness, it's all part of healthy living. Because we're talking about emotions, and because I'm a singer, why not I sing a song? This brings back my memory because I was all of 15 when I started my professional journey. I did my very first stage here in Kochi, and the song I sang, I'd like to sing a little bit of that with you. And there is one very good singer in Bliss family. I would like to ask George sir to please come and join me. The song is Chura Liya Hai. I'm sure everybody knows. You can give a better clap. Bliss member, everybody, louder. Clap for him. You don't want to clap for me, it's okay, no problem. Clap for him.
My wife had warned me, never sing in Hindi where the people knows Hindi. So you are aware of
I'm responsible, sir. I will speak to your wife, no problem. Sorry, slight delay in technical.
സാങ്കേതിക തടസ്സം മൂലം പരിപാടിയിൽ തടസ്സം നേരിട്ടതിൽ ഖേദിക്കുന്നു.
Okay, we are singing, but you all can participate by clapping. All of you all. It's a strong audience. Come on. ഭാഷണം കഴിച്ചു വന്നതല്ലേ, സ്ട്രെങ്ത് ഉണ്ടാവില്ലേ?
മൂക്കട്ടെ.
कहीं बदल न जाना
Where are the claps? बाहर बन के आओ कभी तुम्हारी दुनिया में, गुजर न जाए दिन कहीं सी तमन्ना में। बाहर बन के आओ कभी तुम्हारी दुनिया में, गुजर न जाए दिन कहीं सी तमन्ना में। तुम मेरे हो, हाँ तुम मेरे हो, आज तो इतना वादा करते जाना। चुरा लिया है तुमने जो दिल को, अरे वाह,
नजर नहीं आना सनम।
सुपर।
बाकी
बदल के मेरी तुम जिंदगानी, कहीं बदल ना जाना सनम। താങ്ക് യു സോ മച്ച്.
അക്ഷരം അറിയാത്തിണ്ടാ? അക്ഷരം അറിയാത്തോണ്ടാന്ന്.
കുഴപ്പമില്ല, നെക്സ്റ്റ് മലയാളം പാടാം.
മലയാളം പാടാം. കൈയടിക്കുന്ന പോരാ കേട്ടോ.
So apart from, okay, so we'll sing the Malayalam also now. Okay, fine, we'll sing the Malayalam also. Okay, you'll have to excuse me for my Malayalam.
താഴെ തേനല കാറ്റേവാ പളുങ്കു പോക്കും നിലാവിൻ മഞ്ചലിൽ കാറ്റേവാ നിവാ നിവാ.
Sorry about this. Pia 2. La 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 la. That is chromatic. So these are the things which you can develop at any age. According to me, you can sing at any age. And singing is to express, not to impress. Apart from this, in healthy aging, in older adults, I also see a sense of achievement, a sense of accomplishment when you're singing, when you're singing something new, and I've actually worked with a lot of older adults in Bombay, and I have taken them on stage. They've actually performed on stage, and they're very happy. There's a sense of accomplishment. There's a sense of, the increased self-esteem. That is also part of, singing therapy, which I call. Music, it's just beautiful. It helps us in so many ways. Self-esteem, breathing, meditation, mood elevation, stress buster. So honestly, singing therapy is a very strong tool to express, even to vent out. When you sing a sad song and you still you can just vent out and then you feel lighter. So I just conclude that I think everybody should learn to sing. Everybody should sing because it's just beautiful, and for all the reasons I stated. So thank you so much. Thank you so much for inviting me here and making me a part of this conclave. Thank you so much. Thank you.
Thank you so much, Ms. Nivedita. Can I just request you to wait for a minute? I would like to ask George sir to please hand over the memento to Ms. Nivedita. നല്ലൊരു കയ്യടി കൊടുക്കാം for her lovely session on how music can impact you, how music can heal you. And we all hope that you go on ahead in life to heal people with your lovely voice. Thank you so much. So now we're moving on to the panel discussion. And this panel discussion is on the topic home-based care for elders, challenges and reality. And I would like to call on stage to be part of the panel discussion Dr. Bobby Sara, who is a radiation oncologist and founder of Conclave Kochi. Dr. Bobby Sara, ma'am, can I please have you on stage? I would also like to call on stage Mr. Tom George, who is a founder and managing director at Guardian Angel Home Care Kochi. And to moderate our session, or to moderate this panel, I would like to call on stage Dr. Charu Arora, who is the consultant physician and head of palliative care provider and at Ameri Health Home Healthcare, Faridabad. Thank you so much. I would also want to tell you thank you for being so actively involved and on top of your energy. I've been watching you from here. You're very excited about all sessions. Thank you so much. Yes, the mic, sir. Yes.
Thank you, Nivedita, for keeping the audience awake after the food coma. The lunch drowsiness was kind of taken care of by you. Thank you. Thank you so much. Sorry, Tom. I leave you without a mic. Okay. So, thank you so much, dear audience. First of all, thank you so much, Babu. Thank you so much, Bless Retirement Living. Thank you so much, the awesome rockstar team of Bless, especially Rene, who's been coordinating with our entire group and creating this entire plan. I really want you all to give a round of applause to yourself and Bless. Once, please, a round of applause for Bless. You know, this round of applause is not just to kind of do it, but also mean that everybody is involved in the care for elderly. Everybody is here with a purpose. They have a motive to achieve. And they are actually actively participating in it, whether you are at the booth, whether you are a delegate, whether you are one of the event organizers, or you're a speaker, or you're flying from other country or somewhere else. You are actively involved, and that's what matters, because at the end of the day, we all are here for a purpose, and that is healthy aging and senior care. So whether you are a 20-year-old youngster or an 80-year-old super youngster, all it matters is to take care of the person who is getting a little elderly. I really want to compliment on Bless Retirement Living booth number 11. I think the paintings and the artworks are amazing, and I really loved the entire interactive sessions. Now moving to today's panel discussion on home-based care for elderlies, which is majorly a challenge, and to understand the realistic responsibilities for it. Now before that, I would like to actually, before introducing my very, very honorable panel members and then me, I would like to actually throw some light on why home-based care is so important. You know, even as per the Grandview research, the home healthcare market is increasing, and it's increasing exponentially. In 2017, the market was landed around, $8.8 billion industry. And now it's increasing annually at a growth rate of compound in 19.6%. So just look at the number. And why is it increasing? Why is it increasing so exponentially? It's because I know India is one of the youngest countries in the world. We are still a very young country, but at the same time, our elderly population is increasing. Our problems are moving from infectious disorders to lifestyle disorders, metabolic component, cancers, and definitely increasing the longevity, better healthcare technology, better medical practices, and of course, better institutional care. But at the same time, are we realizing that the requirement that there's a lot of brain drain, there's a lot of youngsters who are still flying away into different parts of the world? And how is the health of their parents, of their loved family members who are aging being taken care of? So the role of rehabilitation experts, the role of skilled medical experts to be given at home is increasing. And definitely COVID has changed the entire scenario. Moreover, now I look personally as a doctor, I even think healthcare industry is just like hospitality, where food creates the mood. Similarly, it's a service industry. Everybody likes comfort. Nobody wants to go to a retail outlet of a food to buy in food these days, right? You just Swiggy or Zomato it. Then why can't you Swiggy or Zomato the healthcare at home? Why can't you bring in somebody any kind of a service which you need at home? Why won't I like it? It's luxurious. It's definitely infection-free and so on and so forth, which my glorious panelists will tell us. So now that it's also increasing in a very organized way. At one point of time, home healthcare was looked down upon as a very unorganized way, as in you train somebody without any degree or matriculate, they can actually come to anybody's house and inject any drug without any documentation. More, and especially Tom on the panel, who I think, please correct me if I'm wrong, you were one of the first organizations who was accredited by the QAI, right? So the first organization, which was one of the first organizations which was accredited by quality in India for a home healthcare organization. So now with that kind of an increasing trend, there is a more stronger lookout towards how healthcare at home or home healthcare market is developing. Now, I am looking at my phone because their introduction is really long and I don't want to piss them off because I have to spend 2 more days coming from Delhi. I have to, they have to take care of me, so I don't want to piss them off. So I'm going to introduce first Dr. Bobby Sarah Thomas. She's a radiation oncologist by education and also the founder of CanCare. She did a post-graduation in radiation oncology from Amrita Institute of Medical Sciences and later took an interest in preventive oncology and palliative care, definitely. Now, she witnessed a large number of cancer patients being sent home whenever cure was not possible. And there was definitely a lack of proper resources and services to help such patients and families. That actually inspired Dr. Sarah to set up an organization called as CanCare. Now, it began as a home-based visit wherein a doctor used to go, and now it's a 50-bedded residential care society for the sick elderly. A huge round of applause for CanCare, please. They not only look after the cancer patients, but also chronically ill and terminally ill patients, which provides a very holistic approach. Thank you so much, Dr. Sarah, for being on with us. Now, Tom George, a man who needs no introduction, a founder and managing director for Guardian Angel Home Healthcare, a very professional home healthcare organization, has been in service for Keralites since 2012. Guardian Angel is South India's first QAI accredited home healthcare organization and the only home healthcare organization with quality accreditation in the region of Kerala. He basically holds a bachelor's degree in engineering from MG University, Kerala, and is a gold medalist from Nikmar University, Pune. He has successfully completed the Stanford Seed Transformation Program, a year-long leadership program for Stanford GSB for established founders and CEOs in emerging economies in South Asia and Africa. With more than 20 years of experience, he's sitting with us to share knowledge with all of us. So thank you so much, Tom. Very, very long introduction. A huge round of applause for Tom, please. A little bit about me. My name is Dr. Charudat Arora. I'm basically an MD physician. I completed my education undergrad from Mumbai and then moved to Harvard Medical School, Boston Children's Hospital to do my residency. Moved to Los Angeles to do my fellowship, been to all parts of the world. Being a social entrepreneur, worked for the underprivileged in Malaysia, Africa, different parts. Moved to India, wanted to practice critical care physician and then moved to palliative care. So basically I wear a lot of hats and I'm heading the Department of Home Healthcare with Asian Institute of Medical Sciences, which is a 19 multi-centered, almost 5,000 bedded tertiary care hospital in North India, one of the largest in the country. And we are running home healthcare organization under the banner of AmeriHealth, and we provide affordable, available, and extremely achievable home healthcare. So I'll be moderating this session on home healthcare. Okay, so now to start this session, Dr. Sarah and Tom, we just discussed about the relevance of home healthcare. But at the same time, Tom, I would like to ask you, how do you feel has a concept of home healthcare changed from the conventional times? I would say conventional when you started it in 2010 or a decade before, and today.
Thank you, Dr. Charu. Thank you all for having me. See, when we talk about home healthcare, I think something needs to be segregated even further, explained even further. So to that extent, conventional home nursing, it used to be called home nursing in Kerala. It used to be sometimes referred to private duty nursing elsewhere. All of this was unorganized. And that is probably predominantly what is available even as we speak. Now, professional home healthcare and professional home care needs to be differentiated. Home care would be the supportive care that you provide at the home of an individual, done by a caregiver, not a professional, maybe supervised by professionals. Home healthcare, as against that, would involve both caregivers and a whole host of professionals, including doctors, nurses, counselors, physiotherapists, speech therapists, and all of them. All kinds of services these days are reaching homes. So there are organizations which are involved in home healthcare, so to speak. I mean, our Guardian Angel Home Care is a home healthcare organization, though the name doesn't sound so. But there is the sad part of it is there is no regulation yet for any of these differentiations in India. So it is more like, we are all emulating whatever systems are available elsewhere in the world and trying to do our best to ensure that, okay, we are complying by the statutory requirements out here and going beyond that to ensure quality of care is delivered at home. Now, to differentiate further from how conventional home nursing, and I would restrict myself to home care part of it, professional home care, there are various aspects. The basic best example would be the focus in a home nursing environment was, do I get a person, giving a person, identifying a person for care. Rather, in a professional home care environment, it should be looking for the kind of care requirement. So to that extent, we are in the business of providing care to individuals rather than providing an individual for a patient. So that essentially differentiates the first part. Now, second part is the scope part. Like, what does a home care carer do in case of a conventional situation or in case of a professional environment? Conventional, the individual who comes in negotiates with the family with their limited understanding or even good understanding, they will tell them, okay, these are the things that needs to be done. Focuses more in terms of, in many a time, the interest is more to get a domestic maid come a carer, underplaying the importance of care required for the individual. Whereas, in case of professional care, we go do the scoping first in terms of serious assessment. Detailed assessment of a patient is done. We go through medical history, current medication, daily routine, functional abilities of the patient to understand what they need. All of that is done, documented, and this is clearly defined in care plans, defined in the agreement, service agreement, as to these are the things that we will do, these are our responsibilities, these are your responsibilities, and our responsibilities delivered by a carer are supervised regularly, they are monitored regularly. That is how we make the second differentiation. There are various other aspects to this in terms of, the quality part. quality, how do we ensure quality? There is a process in the whole engagement, whereas the other conventional way, it is just sending a person and then, replacing that person as and when that person goes on leave.
Absolutely.
Now, technology is involved. Essentially, the basic difference, I would say, it has gone from a person-centric, in the sense person meaning the person who is coming for care, centric to a patient-centric, holistic approach, wherein the focus is not merely the physical support, it is emotional and social well-being. So that is how we would think that the professional home care can deliver better solutions for the patient at home.
I agree, completely agree. So Dr. Sarah, would you like to add something? Because if I'm absolutely correct, you started as somebody who began your career after Radong, and when you saw, so much of misery and sufferings, you wanted to kind of take care by providing home-based doctor visits, right?
Yes.
How has it changed?
See, I think for all of us, home is where the heart is. Or, when you say home, we all have our own, I was recently reading an Instagram post. It says, home is where you poop the freest. That is where you are yourself. You cannot be yourself in the office or in the workplace. But home is where your foundation is, where your roots are, where your emotions are. Now the question is, can healthcare, when we think of a school, we think of an education institution. We send our children out of the home to a school. When there is a healthcare need, we take our family members to an institution for that particular care. Why? Because that particular institution is specialized in providing that particular resource. So when it comes to healthcare, the question is, can healthcare be provided at home? That is the first question we have to answer. And if so, what is the quality or the level with which we can provide? Now, I personally got into home-based care because my mom was a cancer patient. When we went to the hospital, it had already reached a stage where her liver was involved. And we started chemotherapy. We did 3 cycles of chemotherapy, and in 30 days, 21 days was spent in the hospital. So I had a conversation with the oncologist who said, if out of 30 days, she is spending 21 days in the hospital, do you want to stop treatment? So I said, yes, I'd rather have her be at home 21 days than be in the hospital for that 21 days. And that is when we stopped treatment. She lived for another, they put her on a oral-based chemotherapy which could be taken at home. And she lived for another 7 to 8 years with maybe in those 7 years, at best, she was in hospital for 20 or 30 days. So the point I'm trying to make is, what is the goal of healthcare at home? When a person realizes that there is an incurable illness, then you are left with a period of time where you are alive. Yet you have healthcare needs. That incurable disease and these associated symptoms, if they can be managed at home in a comfortable way, I think that is an individual decision every family has to make. A choice made by the family member. The same care can be provided in the hospital. But what we are saying is, do you want to come back to that place where, in the old movies you used to see one doctor will come with a box and come home and check the patients. So there was a time when healthcare came home. There is a period now where healthcare is a completely institutionalized thing. But I think we need to have, at least there may be families like mine which would prefer your family member to be at home than in the hospital. If so, I started home care to give such families that option. So answering your question, what is the trends that have changed? It is the family that has to decide. Where do I want my loved one to be taken care of? And what is the end goal? We cannot keep them alive forever. Death is a reality, and can we give dignity in death? Those are questions the family must ask and answer.
I think very dark questions about death and end of life, but I'd like to ask a very random poll amongst the people who are sitting in the audience. How many of you, including the people who are participating as at the booth stalls, how many of you would like to see your doctor at the place where you live? Just raise your hands. And how many of you would like to see the doctor at the hospital? Raise your hands. Do the rest I mean that they don't want to see the doctor? I don't look that bad, guys. Okay, so I still think that people would like to see the doctor at their places of residence. And I think the concept is definitely changing. So, Dr. Sarah, give us some information on what are the major kinds of patients a doctor should see or a doctor can see in the home healthcare, the area.
Regarding the types of patients, we must define the patients who would benefit more from home health care, because see, there is a category of illnesses like you mentioned. People are living longer. The average lifespan used to be in the 40s, 50s, then now it has moved to the national average in India is 63 and 68. But Kerala, we are having 73 and 78. I have a 50-bed residential care center, and 40 of my patients are aged between 80 and 95. So the reality of chronic illnesses, they are all living with chronic illnesses. So this segment of chronic illness means there is an indefinite period of this illness, and there are progressive complications to these illnesses. So the type of patients we generally see would be dementia, which is memory problems. We see stroke patients, especially those who are completely paralyzed. So they develop pneumonias, they develop bed sores, they develop urine infections, they're on tubes, some are on artificial feeding with Ryle's tube, PEG tubes. Those are the kind of patients we generally see. So if you want me to classify, I would say chronic illness primarily. I don't deal with acute illness at home, because definitely, a 60-year-old with a chest pain calls us and says, I'm having chest pain. I would say go to the hospital. You need to be evaluated for a heart attack, and that is a curable condition which I cannot cure at home. You definitely, and you have a window period. In this time, you should reach the hospital. So those are a segment of acute illness which, my personal opinion, should not be managed at home. But those with a diagnosis of chronic illness like a stroke, dementia, Parkinson's, cancer, which is with a palliative intent, these are the kind of patients we generally see at home.
So I personally would like to add that, not only chronic illnesses, but some of the acute disorders, if you have a good medical equipment backup and if you have a good technology in place, you can also manage, like we manage a lot of ventilator patients at home. We manage a lot of sepsis patients at home. We also manage dialysis patients at home there's a lot of time constraint, there's a lot of traveling involved, especially in the COVID times. People have changed their aspect, of going to the hospital, because I personally never see hospital as an area of healthcare. When I moved back, when I saw in India, hospitals are technically buildings of sick care. We are forgetting that what is healthcare. Healthcare means well-being. Now, when I say apple, the first thing which comes to everybody's mind is a red-colored round object with a green leaf, right? But the moment I say hospital, you don't really think about a happy person going inside or something of a well-being or wellness. Such terms don't come to your mind. What you really think is about cost. So the second thing which comes about, death. Third thing which comes about to your mind, illness, sickness. So I don't believe, I personally live in a hospital 18 hours a day, but I don't believe healthcare exists in a hospital. Healthcare exists at home, because that's where the comfort is. That's where your mind is. That's where you're best at. And if the services can be provided at home for your own well-being, then nothing can actually compensate it.
Doctor.
So yeah, go ahead, Tom.
I just want to add to the point that who are the people who can be treated at home.
Yeah.
See, one is people whom we see, one is the elderly and disabled who require support. It is not from the healthcare perspective, but they might require healthcare, they might have healthcare requirements off and on. I mean, maybe somebody is sick, can be managed at home. So if it can be managed at home, we do intervene. That is one way. So to that extent, we have chronic patients with chronic illnesses, patients with acute illnesses, post-surgical cases wherein they come back home and the recovery is very, very serious business, recovery part. I mean, there are, right now as we speak, there are transitional care centers being set up. I mean, so that is very sensitive area. There are patients whom we are supporting at home during that transitional period. That's second, third type of patients, apart from the elderly and differently able, chronic and acute. The last one is the terminal illnesses patients that Dr. Sarah mentioned about. Now, one other set of people that are getting our services is this, occasional catheter changes that are happening and things, short visits. So our nurses are always on the road. When nurses going there, even doctor as we speak is taking rounds to see about 8 patients today. So that is the kind of numbers that one doctor will have to see. It is not easy in this hot climate to see 8 patients a day. Then that is passion for, hats off to the doctors who are going around and doing this. That is the kind of, patient clientele that we have.
Yeah, so great. So Tom, I have, you started off in almost a decade back, and even the perspective, I know home healthcare is very financially lucrative for the people who are actually going, whether it's nursing, whether it's caregivers, it's financially better for them as compared to the hospital payouts. But still, the nursing at home is never considered a very ideal job, a very ideal career. And it also comes because there's a lot of apprehension that comes from their family, because if I'm going to send my daughter to somebody else's house to take care of his mother, will my daughter be safe? They can be emotional issues, they can be psychological issues, somebody can be a psychotic, somebody can throw a sexual remark, it can be anything. It can be a mental abuse or physical abuse. How, as an entrepreneur, do you deal with the safety or the caregivers, especially nursing and the caretakers, who go to somebody else's house, and you also, kind of take care that they're safe?
Sure. At the outset, I should also say that it is not just safety. The same or similar apprehensions are there with the client as well. They also do understand there's an outsider coming to my home. Are my parents going to be safe? There is another part to it. So, from a perspective of how we ensure safety for our carers, the first and foremost is a serious, detailed assessment that we talked about. We document everything that we see. There is a structured documentation wherein home safety aspects are clearly defined. One, who are all the people who are staying there is also something that if there is no real, genuine reason for us to be there, we shouldn't be there, is my policy. Because somebody who genuinely needs us is not going to play around, for sure. That's of this 11 years, no instance of that kind has happened, except one instance wherein an indication came in, we have a mechanism to tackle it. And I'll tell you what that mechanism is. Very simple. We have care coordinators who are interacting with our carers on a daily basis. And those care coordinators are single point of contact for the carers. Directly, they can just call them up at any time. Anytime, if there is a problem, they can call up. Now, having done the assessment and having seriously involved on a day-to-day basis, the carers feel that happy, that they are in safe hands. So they have the organization backing. Only thing is, organization has to be responsive enough if somebody is actually playing mischief. If there is a slightest indication of things going wrong, we will, even I will be there. That is how the organization has given the assurance to the carers. So there are very few instances wherein when we train the carers also, we tell them there are various aspects to this safety part. Now the point is, if you are obligated to the family by taking gifts, payments, extra payments, there is going to be some other issues that will come. Now they may not be able to even complain to the organization when they have been caught doing something that is incorrect. Now, like stealing and all that, if that happens. So obviously they have to ensure that they deal in a professional manner with the individuals. The training that we have for 100%, we ensure that every carer who goes out from guardian angel home care is trained by us. They have a residential training Right now it is 15-day training that we do. We take them in after an interview process and then do this training. So we try and ensure that their attitudes, the caregiver attitudes are there, and they are much more professional in approach, they understand. And during the training, we stress the fact that please don't, seek favors which would actually put you at a disadvantage. This is something that we do. And beyond all of that, their safety in terms of if they meet with an accident, all of that is taken care of by us. That is assurance that we have. We have medical insurances, ESI, PF, everything for them. That is one part. Fidelity insurance and professional indemnity insurance are also taken for every individual who is doing the operational calls. So to that extent, these are safety nets that we have created to ensure that the organization also does not go out of business because of one individual's misbehaving. And on the other side, for the patients also, we give the same kind of assurance. That's why we have professional indemnity insurance there. If we have erred on something, so there are errors due to omission that happens, and if the patient has a problem, we should be responsible. Similarly, if there is a theft that happened, of this 11 years, I've had one instance of theft, and I know how we have handled it. We have given police complaint, did the correct mechanism, was followed completely, and I can tell you that instance happened in the first year of engagement. The client is with me after 9 years, continuous care is going on even now as we speak, and every single penny was returned back to him. So insurances came in handy. So that is how we do.
Because I believe that safety is extremely important. Dr. Sarah, would you like to add any points on safety? Because especially female doctor, female nurses, which is being home to home, and now also a 50-bedded residential place, different types of people with different mentality. It's not very easy, is it?
See, like we said earlier, this is not a career option that people voluntarily get into. So the majority of people who are coming into this workforce are doing so due to some personal, financial or personal, other challenges for which this is a very good financial source of income. So understanding that this is from a backward or a difficult background, there are two sides to this. I think those of us in Kerala, I had a period of time where I was using home nursing services from, there was a center called Seva, and we used to take people from there, and they were not trained or anything like that. But the attitude has definitely turned around in the last 20 years. Now the attitude is when you call, they're like, okay, we want 6 a.m., we want Bonvita, 10 a.m., we want this, we want fish fry. So I recently had a lady who admitted her husband into my center for the simple reason that the home-based carer would not even wash his own plate. And this 80-year-old lady has to cook for this carer, wash his plate, take care of all his personal hygiene as well.
Who is the carer here?
Exactly. And the only reason she said, I am putting him in a residence, I tried to find, I thought, what should I, I didn't want to admit him if this was the reason, but when we went to the house and we did a survey, what we realized was he's got Parkinson's, he's got severe disability, he needs at least 3 people just to take a shower. So one carer at home would not cut it. So that's when we made a decision. The children are all educated, one is suffering from cancer, and they're like, if 3 of us could come, we would, but we are not in a position where we can come. So that's when we made a informed choice to actually shift, this uncle to a residential care facility. So coming back to the point of safety, the caregivers, it's fantastic what Guardian Angel is doing, but this is still a highly unorganized sector. This needs regulations. People who are coming into this sector are not really trained, and many of them don't have the attitude for that. Recently one of my friends who's a doctor, she hired a person, and her father is bedridden, suddenly became bedridden over a week. He's 92,
developed a UTI. After that, found difficulty in moving. So she hired a person, and this person, she asked the caregiver, "Can you please take him to the toilet and just give him a shower?" And he said, "I came to take care only of bedridden patient, so no showering." So that's the reality, as that's the reality of home-based care that we are facing, because there are no regulations. So when it comes to safety, we have to look at the safety of the elderly person, because many are alone with a caregiver not being monitored. The second is the safety of the staff, which I fully agree that they need to be taken care of. They're doing such a noble service. It is not an easy job. And I usually put my staff on shifts, because more than 8 hours, when you listen to this, you go crazy. You lose it, because I think all of us in this field need to take regular breaks, need to take time out. When I was caring for my mom also, she would be like constantly complaining about the food. That was a major complaint. And I would make it, the maid would make it, somebody else would try to make it. We followed all her instructions, but she was still frustrated, and realized the frustration was not the food. The frustration was, being a nurse, she knew that she has a terminal illness and she must face death. And that frustration was actually coming out, and sometimes these elderly people can be very, very, very challenging to deal with their frustration. So safety in terms of emotional health, physical, sexual exploit is all possible, but I think this needs a more concerted effort on, and now with all of these reporting mediums and all that, I think the safety of staff is ensured, but we need to go to the next level where the safety of the elderly is also ensured.
I agree. So when we say about safety, you mentioned about a huge aspect about the training that is given and the quality of care, or the training, the regulations. So how do you maintain that at Guardian Angel?
So when we started Guardian Angel, as such, Government of India has already identified this to be one of the serious challenges that we are going to face. Niti Aayog has come out with a recent survey. They have said 1 lakh carers are required, caregivers are required for the next 3 years, to be skilled in next 3 years. That's a huge number first. And 1 lakh is only for India. Now, most of the people that I train are going abroad now. I don't know what that certificate is holding good for them or not, because I don't have even an accreditation or government certification with me. I'm just giving them a training that we have found to be useful for our carers. It is an internally developed curriculum. Now, that curriculum itself is working well for people to go abroad, which means of this 1 lakh, if you're readying 1 lakh people in next 3 years, quite likely 90,000 would be abroad. That is how it is going to be. So, which means you need almost 1 million to be trained in the next 3 years. Now, what we do in terms of training is that initially we used to, ever since we started training up front, and then only we will deploy them. The training is not just skilling. Skill is only one element of it. Caregiver attitude is something that you probably cannot even inculcate in them at that age. So we have to identify people with the right caregiver attitude, give them training both on, they have to be professionally refined, how do you approach discipline, how do you organize things, how do you, do things on what are the do's and don'ts in the care. All of that needs to be told. At the same time, they need to be skilled as well, and practical oriented. 60% is practical that we have. It will be both interpersonal skills development, also being in practical sessions. We have that in practical sessions. Now, we did about 95 batches in-house, and then we started Guardian Angel Institute of Caregiving, and there we now are running, from 2021, we are running batches of about 15 to 20 each. Every month there is about 3 batches going on right now as we speak. So these people are coming out after the training. They're all background verified, police clearances taken, medically screened to ensure that they don't have any contagious diseases, or they don't come with any contagious diseases, HIV, hepatitis, TB, all of that is cleared, and then only they are deployed on care.
That's very commendable, because I think a good caregiver shouldn't know on the duties, the job responsibility, but also being a very empathetic, compassionate, and comfortable person to be with.
We talk about love, care, and respect.
Yeah,
that is
TLC, tender loving care. Now coming to tender loving care, one thing which has kind of changed, when I was doing my medical education, palliative care was something which was extremely premature. People didn't talk about it, very dark area, always considered to be associated with death, the demon of death. But now when I see in the last 8 to 10 years, the entire scenario and landscape of palliative care has changed. And that's what kind of got me interested to be a certified palliative care provider. So I want to ask you, Dr. Sarah, you are an oncologist, a rad-onc, but later on got into palliative care. So can you tell our audience, whether medical, non-medical audience, have an understanding of palliative care? And why is palliative care so important to be given at home for any of their loved ones?
When I passed my MBBS, I came out thinking you could do anything being a doctor. And during my internship, just after my internship was when my mother was diagnosed with a terminal illness. And I was faced with the reality or the limitation of medical science. We think that as doctors, we can do anything, because that's what the textbook tells you. That if this is the thing, you do this, give this medicine, they give that, do all of that. And the reality that the medical science has limitations was something that I realized early on in my medical career, and I switched completely out of clinical medicine and went into teaching. And after that, I took a 10-year break and came back to do my post-graduation. And I thought radiation oncology means, again, high-end machines and all of that. There also, a large number of patients we were sending back every day telling them, no more treatment, nothing more to be done. So, just to answer your question of what is palliative care? Palliative care is a specialized branch of medicine which actually involves a more holistic approach in treating patients with chronic illness and those who are already diagnosed with an illness which is incurable. When the underlying disease is incurable, they also have problems in terms of symptoms. They have vomiting, they have bleeding, they have bed sores, they have swallowing difficulties, they have urinary infections, pneumonia, so many complications are there. So we realize that the underlying disease is incurable, but the symptoms can be addressed with medical help and they can be made comfortable. So the goal of palliative care is not increasing the quantity of life. In the hospital, we would look at every means to somehow prolong the quantity of life, but in palliative care, every decision is made with, can I improve the quality of life? So I have residents at my center when their oxygen levels go down, and we have a conversation with the family and we tell them that they have an underlying lung problem, their oxygen levels are bound to go down. Just because your oxygen level goes down does not mean you need oxygen. So this is a natural process of death and dying. We need to give them comfort at this time, and there are medications which can relieve that suffering. But by giving oxygen, I am not improving the quality of life. So if by giving oxygen I can improve the quality of life, I would do it. So every decision in palliative care has to answer this question, can I improve your quality of life? If so, let's do it. If not, let's not. So palliative care is today coming out in more, people are taking interest into this. It is not a very lucrative branch of medicine yet. Most hospitals don't run it because, it's the most,
least profitable.
Cash burning department of any hospital. So, but this is the reality of healthcare, and I think as palliative physicians, we see death and dying on a almost daily basis, and it makes you more aware of the limitations as a doctor, as a human being, that there are limitations that we have. And how can we bypass these limitations and give somebody a dignity in their death? That is the primary goal that we have as a, so I usually tell even my doctors, the juniors, I said in the hospital, as a good doctor, you need to somehow prolong life. But in palliative care, as a good doctor, you need to ensure that they are dying with dignity. That is our goal is in palliative care.
Extremely well put. Rather, it reminds me of one of my professor's sayings, Charu, don't think that life for 10 years is a better life than life for one day. If that one day of life is pain-free, you are comfortable, and you are being with your loved ones, then it's better than living alone with pain for 10 years. So I think very rightly put by you, Dr. Sarah. Tom, I want to ask you one thing. How has COVID has personally changed a lot of things in everybody's life, but how has COVID changed the perspective of home-based care and Indian population?
It has definitely become more acceptable. I mean, I think COVID was the time when doctors started discouraging people from coming to the hospital, and many have realized that, okay, though I didn't go to the hospital that often, still it was okay. We managed. And maybe, in our cases, what we did is we immediately moved into live-in care and all. I mean, people staying full-time there, and all just to avoid the number of iterations of carers going there on a daily basis and the exposures related to that. But from a perspective of even after the pandemic got over, immediately after, I wouldn't say got over, during the pandemic itself, all our carers, the moment they got their booster doses done, we started even providing care at home for COVID patients too. And it has been very well accepted on one front. Now, the point would be, I would like to just give an example of a case where whether it is COVID or not. There was one patient in our case who was actually diagnosed with terminal illness, and she was put up in the best of hospital facility in Continence, in the deluxe, the highest rated rooms that she was put up in. And her sons were oncology specialists in US. So they understood that, okay, the patient is going to have only a few more months and need the best nursing care. Now, that patient had no interest in life when we first met her. They had to be moved out of that hospital because of an NABH audit coming up, and the hospital didn't want their rating to be low, so they requested the patient to move out. The experience of that patient outside the hospital really made the patient was, the moment she came home, she was actually much better. She was seeing a ceiling. She went to the balcony. She said, okay, after 4.5 months, I am first time seeing Surya Bhagavan. Okay, now we decided to take her down to the playground where kids were playing. She used to interact. So her mood changed, elevated so much that next 3 months we saw her smiling, laughing. We took her to Thirukkakurambalam temple. We took her to Lulu Mall for window shopping. All of that we did, and she was very, happy. Very, sort of forgot about her problems as such. She had her husband next door. All of that is possible in a home environment. So I think COVID or not, COVID has brought in some, in a way, some acceptability, but COVID also did one thing wrong, brought in one challenge, I would say. What happened is, if not for COVID, home healthcare would have been on the forefront discussions, in our discussions, but for COVID. Because organizations and countries across the globe were already talking about this grey tsunami that we are right now talking about. That in between 2.5 years was a distraction for home healthcare is how I think.
I'd just like to add to that in the sense that COVID actually opened the possibility for home healthcare for those who would not otherwise think of it. There is a large percentage of people at that time who opted for home-based healthcare because that was when I started my home-based care, it was in 2016. At that time, I was one of the very few doctors who would go home and visit patients. So every home I visited, they would get visitors who are elderly people, and from that one home visit, I would get a reference of average 3 to 4 reference. I heard that you're coming home to visit, can you come and visit? But after COVID came, almost all major hospitals in our city have started home-based care.
Home healthcare vertical,
home
yes.
healthcare. So the reach and the access, see, one of the challenges of home-based healthcare is one doctor can at best do, I think 4, 5, I mean your doctor doing 8 is commendable.
Yeah.
But 4 or 5, because your travel time, then the time that you spend in the house, then your travel back. So, I mean, after 4 or 5 in a day, I would myself get tired. So, 4 to 5 is ideal. So, that reduces the number of people that you can actually see. Then the concept of telehealth. I feel there is a good space for telehealth, but the challenge with the elderly is they want that personal touch. You know, they want somebody to come and just hold their hand probably, or, you know, they saw a doctor live rather than through the television screen. So in terms of COVID, how has it helped in home-based care? It has definitely accelerated the reach of home-based care, where even hospitals realize that without this, we really can't go forward. So almost all the hospitals, which is good. So then now the reach for home-based care has definitely increased.
You know, I personally see that COVID has kind of changed the landscape towards artificial intelligence, big data, machine learning, and an incorporation of digital technology in healthcare. You know, I personally, learn a lot about big data and have a very strong interest in digitalization and artificial intelligence in healthcare in total. And I personally feel that, as Dr. Sarah said, starting from a very basic electronic visit and telehealth to managing chatbots and virtual reality in process of rehabilitation. I remember there was this research I was reading that the virtual reality market was almost $8.4 billion and is expected to increase to $275 billion by the year 2030. Now just look at the aspect. Earlier it was just like a gaming zone wherein your nephew or your niece is playing a Wii over a table tennis or a lawn tennis, and now we are using virtual reality to take care of falls, to help in healing, to help in rehabilitation and whatnot. So from IOMTs to lifeguard digital health, thinking about how such a fantastic way of preventing falls and also providing immediate resuscitation or immediate help which is required. So digitalize, and I personally feel that although our elderlies, they love the conventional touch, but they are the fastest learners. My helps at home, they all are elderlies and they love the way Arogya Setu worked. They love the way how the entire digitalization in using Paytms and other UPI apps work, because if you teach them once, they'll be very happy to teach so many of them at their same age. So yeah, they're very passionate.
Regarding telehealth, see, we must understand that there is an age group that is the utilizer and there is an age group that is booking these services. So what I feel is definitely the elderly 70 above, they are not digital friendly and probably may never be. But there is an age group between the 30 to 60 who are their children, who are their grandchildren, who are actually utilizing these services. So the good part is, everybody will grow older. So there will be a time when, the digital friendly age group will be older and they will be using these services. And by then, this would have taken a hold. But currently the scenario is where they need training to utilize digital services.
So Tom, any final thoughts on the challenges and realities as we conclude the session?
I think, I hope and pray that in India there will be a framework that will come for home healthcare, framework around home healthcare, which will make even life easier for the professional home healthcare organizations to operate. Otherwise, there will be, it is a mixed group of people, and some organized, some unorganized, some working with high levels of quality in their mind, some working with no interest of those kinds. Now, all of them talking about home care itself, and probably that is not a level playing field in the first place. and people try to compromise on quality, and there is a cost to the quality. It is the life itself. Now, so to that extent, if there is a framework that comes up, that is my prayer. And in fact, I've been in any forum that I get, I've been preaching this part alone. That there should be. I'm told that there is a regulation that is in the parliament, but it has not come up yet for discussions. That's something that is there. Registration of all caregivers, so that there is blacklisting and everything possible, so that it is monitored, and only people who are suitable for that job gets into this field. This is important because we will be otherwise risking our elderly. And last but not the least, thank you for giving me this opportunity, and all cheers to Bliss for having made this kind of a, given us this kind of a forum, and the wonderful work you're doing. Hats off to you.
Any final words from you, Dr. Sarah?
Yeah, I think, Kerala is aging. I think all of us know that. We see that in our WhatsApp posts, we see that on the media. And I would say we need to create a framework. Those of us who have decided to stay back, Kochiyada കാറ്റൊന്ന് വീശിയില്ലെങ്കിൽ കിടന്ന് ഉറങ്ങാൻ ബുദ്ധിമുട്ടുള്ളവരാണ് നമ്മൾ. Those of us who have decided to stay back are those who wanted this Kochi air, to breathe this Kochi air. We decided to stay back. And we have eminent personalities like Dr. George Paul, who have left a lucrative career in the UK and decided that Kochi Katu was better than all of that. So my message to all of us here, I think all of us here, whether it is Bless Homes, Can Care, Signature, so many forums, so many elderly living facilities, so many of us who are working in this space, is let's make Kerala senior living worthy destination. Let seniors here have the best care, let them have the best options, let them have the choices, whether they want to be at home or whether they want to be in a retirement community. At home, if we can provide, home is, I would say, for me personally, as well as I'm sure for all of us here, home is our #1 destination. And if we can get the best care at home, there is nothing to beat that. And the second best option for those who want, who are looking for residential care centers, let's provide the best. And that's, I think Bliss has led the way in that. Congratulations to the entire Bliss team for leading in this, in this area as well. So congratulations, and grateful for the opportunity to be part of this.
Thank you so much, Dr. Sarah. Thank you so much, Tom. And thank you so much, audience. If you have any questions for any three of us, the dais is open. Otherwise, we are available over a cup of coffee later if everybody allows. I would like to thank again Bless Retirement Living for giving us the opportunity. I'm loving Kochi already and loving the hospitality and warmth of all the organizing and the team from Bless Retirement. So thank you so much, and really humbled to be here. Thank you.
Thank you to all three of you for your lovely session. Do we have any questions? Any questions directed to any three of them? All right.
Hello, good afternoon. I'm Dr. Sushma Jadhav. I'm from Maharashtra, Pune. The one in the geriatric care, whether we talk about the institutional care or the home-based care, the one thing comes is maybe in the Kerala, many people goes to the abroad, so maybe the financial they are rich, but it is not the condition in the other states as equal. So the one thing main is a financial aspect. So as you said, one doctor, if he really want to give a good care, he can do a maximum 4 to 5 visits. Then it comes about how much he will earn in the day, and at the end of how much he will charge to the patients, and whether patient will able to afford that. So how you balance these aspects of the finance burden to the patient and to do a good justification for the earning of the one qualified doctor?
Sarah, would you like to say?
What I have realized is, I don't understand which aspect of home-based healthcare is lucrative, because my balance sheets didn't show that.
You spend too much. You shop a lot.
Yeah, and my chartered accountant asked me, why are you doing this? So eventually we moved the home-based healthcare into a foundation where we decided that, see, the average, what I realized was the actual cost for a driver, a doctor, a car, a nurse, an average cost per visit per day comes to about 3,000 to 4,000 rupees for us if we had to, bill in the actuals. So we billed at 1,500 to 2,000, and we started getting, we subsidized that cost and took on that cost onto the organization. So when it comes to elderly, one thing we have to remember is also their resources are limited. They have stopped earning at a certain age. They have a limited amount of resources. A lot of that is exhausted with 2 hospital visits. 2 hospital visits means almost half FD is over. So what is left is usually a small amount, and they are very subsidized in how they are spending it. The second thing is the large population has gone abroad in Kerala, so the 20 to 50 age group is almost absent here. So but they are working. Now, do these working children support the parents? Some of them do. The reality is many of them cannot afford to. They are building careers abroad, and they have got a huge cost there, and they are not able to manage that cost. So to answer your question, is home health care, can we actually pass on? In my personal experience, I have not been able to pass on the full cost to the patient. We have borne almost 50% of the cost. We are currently bearing. I have a foundation as well, and we run, sponsors who run that aspect, even to affordable homes.
So I kind of disagree with Dr. Sarah because, it's nice to be emotional. It's nice to be humane, but you can't really you can't just think that world is full of butterflies and pink color. I personally believe that outside there are a lot of thorns and a lot of snakes as well, so be realistic. She's absolutely right. If somebody has done any degree, somebody has spent some money on education, there is a right to get it back. And it's actually a service industry, it's a consumer industry. So my being not only a doctor, but also an entrepreneur, in my organization, we divide the category of doctors who are paying home visits. And depending upon the category of the doctor, the charges from the patients are different. If somebody wants to see a neurosurgeon at home, then I'll make sure that the charges of a neurosurgeon is way higher than a charge of a physician for that matter. And similarly, on the payout, my policy is absolutely clear. You check my website, it's absolutely clear. We keep 20% as profit. My company keeps 20% profit, that's it. 80%, if I'm taking 10 rupees from the patient, 8 rupees going in operations, capex, opex, everything. 2 rupees I am keeping. And that's very clear because that's important for me to sustain. That's important for a transparent living. If the inflation rate is increasing, then how is my doctor getting the money? Then how is my nursing getting the money? I can't be giving you anything for free. There are no free lunches in the world. So for transparency and maintaining the quality, if you have good sponsors, if you have noble people around you and you're lucky enough to get paid by them, congratulations, kudos. But in case you really need to live realistically, I believe that for quality service, take adequate amount and pay adequate amount. Thank you.
Thank you so much for all your answers and for this lovely session. I would like to call on stage Dr. Karthik Narayan, who's the Managing Director of Atulya Senior Care, to hand over the mementos to our panelists. Give them a good round of applause. Thank you all for your time and thank you all for your thoughts. Now we're swiftly moving on to the next panel discussion, which is Guidelines of Dementia Care and Management. And for this session, I would like to call on stage Dr. Manoj, who is a geriatrician at Sunrise Hospital, Kochi. Can I please have on stage Dr. Manoj? In ഓരോരോ ആൾക്കാരെയും വിളിക്കുമ്പോഴും they are experts in their own rights, so please give them a good round of applause. Next, I would like to call on stage Dr. Chalam Das, who is a psychiatrist at Sunrise Hospital, Kochi. And along, we have online joining us Dr. Renu Abraham Verghese, who is a clinical gerontologist and associate professor, and also the chairperson of Travancore Foundation. And to moderate this session, I would like to call on stage with a lot of respect Dr. George Paul, who is the professor, head of Department Geriatric Medicine, Amrita Institute of Medical Sciences, Kerala. All right, so on that note, I'm leaving the stage to you.
Good afternoon, everybody. At the outset, let me congratulate Bliss Retirement Living, Babu Joseph and his team for this fantastic event, which I believe is first of its kind in India. I'm closely associated with Bliss Retirement Home. Our topic today is dementia, and dementia mainly is an umbrella term, basically, to describe a range of symptoms or progressive problems which affects the brain. Typically, when a doctor say the word dementia, we mean to describe memory problems, behavioral problems, problems with speech and language, understanding, confusion. So it's not just, the common thinking is that whenever we hear the word dementia, we naturally think, oh, that's Alzheimer's dementia. No, there are nearly 2,000 different types of dementia. But there are 5 major types of dementia, and we will hear a little bit in detail about dementia in this 1 hour. So I believe Dr. Chalamdas has to rush back to his OP. So I will invite Dr. Chalam. Okay, Manoj is ready? All right, so we will listen to Dr. Manoj, who is a hands-on medical practitioner in this field. So I invite him to talk about dementia in general. Thank you.
Good evening. I hope after the heavy lunch you're all okay now. I'm sure you would be awake for this session. like Dr. Sarah said, she was inspired to get into home-based care because of her mother who had malignancy of the stomach. In the same way, I also had an inspiration to get into geriatrics because of my dad who had advanced Parkinson's, dementia, and he became bedridden within a couple of years after that. So caring for him inspired me to understand the needs of people who are bedridden, people who are at home. And many times the caregivers do not really know how to take care of them. So my first slide is this. I think caring for our seniors is perhaps the greatest responsibility we have. Those who walked before us have given so much and made possible the life we enjoy. But often we forget that. When we have reached a particular stage in our life, we forget our parents, we forget our dear ones who have really worked hard to make us what we are. Now when you talk of geriatrics, this is the picture that comes to your mind, isn't it? Yes or no? Yes, somebody lying in the home or somebody lying in the hospital with tubes all over the place. But interestingly, those from Kerala will understand that this is also geriatrics. This is also geriatrics. This is also geriatrics. This is also geriatrics, yeah? Those from the other states may not really know, but this is Mammootty and Mohanlal, and this is former Chief Minister and the present Chief Minister. They are all above 70. But looking at Mammootty today, no one would say he is a geriatric person. Maybe in a few years' time, he would also need our care and support. Anyway, that was just bias. So actually the word, the word geriatrics comes from Latin word which means the study of the medicine, study of geriatric medicine. While gerontology is the study of the science of aging. Now there are 5 geriatric giants. When you deal with people who are above 60, 65, 70, there are 5 giants. And they are called the 5 I's, you know. You have instability, you have incontinence where they lose the capacity to hold on to urine. There is immobility, there is impaired memory, and iatrogenic. That is the illnesses that happen because of the multiple drugs that they get. So my topic for this afternoon is dementia types and symptoms. I'll quickly go through a few slides so that, and Dr. Chalam is following me, is actually will be speaking on the psychotic symptoms. I would primarily be dealing with the non-psychotic symptoms. Now as you all know, there is a brain, there are neurons in the brain, and because some of the neurons are damaged due to various proteins, other things get deposited, there is a loss of awareness of place and time, memory, cognition, intelligence, language, and ability to think abstractly. Now dementia is also called the disease of forgetfulness because that is the loss of memory is primarily the main symptom that happens in addition to the other symptoms that come on. Now looking at this picture, when you hand over a key to a normal person, he would ask, is this the bedroom key or the guest room key? He would ask, where did I keep the key? He would have forgotten keeping the key somewhere. But a person with dementia would say, what is this? What am I supposed to do with it? You understand? Now we had a gynecologist who was there and we gave her a stethoscope which she was using for 30, 40 years. And when we asked her what it was, she said it is a rope. So many times when you give familiar things to them, they do not know what it is and they do not know what to do with that. Now, for example, a person with dementia would ask these questions. How to turn the lights on? I remember my wife's grandfather and grandmother, both of them had dementia. And they were sitting in a room and suddenly the power went off. And the older gentleman, both had dementia. The older gentleman took the candle and went to the bulb to light the bulb. And this Amma, who is the Amachi, the older, his wife said, no man, that is not the place, light it on the switch. You understand? That is the way people, sometimes lose their whole orientation. And so this are certain questions. Is this my daughter? A son who comes back after 5 years and in the meantime his father had dementia. The father does not recognize him. It's a very painful thing. Where is my bed? Did I take the pill? Forgotten that whether he's taken the pill in the morning, forgotten whether he's taken breakfast in the morning. He would come and 10 o'clock he would come and hit on the dining table and say, you have not given me breakfast. And if the daughter-in-law is caring for him, he would tell anyone coming into the house, my daughter-in-law has not given me breakfast. And you know what happens? People will believe the old gentleman and they would actually be angry with the daughter-in-law. So this is what happens and creates a lot of difficulties at the home. Now, as Dr. George Paul rightly said, dementia is an umbrella term. Dementia as such is not a disease. It is a symptom, or it is one of the manifestations of various types of illnesses. As you know, the commonest is Alzheimer's. Then you have the vascular, where you have multiple infarcts in the brain, and that affects the brain function. You have the Lewy body, which again comes on little earlier. The Alzheimer's may come on by 65 plus. The Lewy body might come in the 50s. And hallucinations is one very common symptom of Lewy body. Now, frontotemporal. This is again another type of dementia where they have a lot of antisocial behavior. You know, they have rigidity, unsteadiness. They have slowness, twitches. Various other symptoms are there. So, based on these symptoms, we classify each of these illnesses. And sometimes there is a mixed dementia where, you know, you have a multi-infarct person having Alzheimer's, so there can be a mixed picture also often. Now, as I said, it's an umbrella term to define a set of symptoms, which includes memory, perception, reasoning, attention. The attention span is very less, thinking, judgment, language, abstract thinking. Abstract thinking is, suppose you see a dog, or you have a dog at the home, and a guest comes in. You do not think that this dog will go and bite the person and the person will really have to go and take anti-rabies vaccine. Those kind of abstract thinking they lose. They also have a loss of judgment of, you know, distance. So when they cross the road, normally what we do is we stand and we see the speed of the car and we think at this speed the car is coming, I can cross over by that time. But they lose that perception, and so many times it becomes difficult for them to walk on the road. And these are some of the non-psychotic symptoms, which I already mentioned, you know, problems with abstract thinking, frequent memory losses, repetitive questions. One very common feature is when you go to a person with dementia, he'll ask you, what's your name? Then after about 5 minutes, he'll again ask you, what's your name? Then about 5 minutes later, he'll ask you again, what's your name? So they have these repetitive questions, difficulty in performing familiar tasks, disorientation in time and behavior, changes in mood and behavior. You know, sometimes they're angry, sometimes they're very happy, so this fluctuates. Now, when do you suspect dementia? When will you suspect dementia? Loss of memory, they lose the date, year, day, they lose memory. And mostly the recent memory, not you might find that they might be talking very much about their job 40 years back, about their marriage, about their honeymoon. And you sometimes wonder, you know, he's able to remember everything. But if you ask him, what do you take in the morning? He's unable to say that. Repetition of thoughts, ideas, or questions, loss of awareness of place and time, forgets recent events and want to only discuss older events. Gets lost in familiar places. He used to go to the post office every day or go to the shop every day. But suddenly you find he takes a different route and goes off wrongly and he's lost. Forgets about self-care, eating, bathing. They refuse to have a bath. They forget about having a bath. They forget about shaving, the common things. And they're unable to do their normal, and this, I said, loss of language, unusual behaviors, illusions, misunderstandings, and fear. So these are some of the common symptoms that they present with. And so anytime you have these symptoms in a person who is 65, 70, 75, you should suspect dementia and you know, do what is necessary. But one thing that we need to understand also is that all memory loss is not dementia. So most people think anybody who has memory loss is dementia. No. There are some conditions where you have a reversible memory loss. For example, hypothyroidism. If the thyroid hormone is low, they have a low memory. If they have depressed, many times you find people are depressed, they lose their memory. You know, or they find unable because their mind is all clouded with a lot of thoughts and all that. So they have a memory loss. Vitamin deficiency, B12, especially among vegetarians, and folic acid are two common conditions where you can have a memory loss. And it's very important to assess for these things when, and then there's something called normal pressure hydrocephalus, which can only be detected by doing a scan. They become unstable, unsteady, they have incontinence of urine, And whenever a person has those symptoms, you should always suspect a normal pressure hydrocephalus, and this is something that can be treated and the person can get better. So rule out all treatable causes before labeling someone as dementia. You know, as most people say, dementia is only a diagnosis of exclusion. You rule out everything else, make sure that he does not have any major problems, rule out everything else, and then you label a person as dementia. Because the problem with dementia is it's like a death sentence. The moment you say dementia, you know, the whole life changes for this person, you know. So this is very important that we don't just label dementia. Briefly, the do's and don'ts when you deal with a person with dementia. Do's would be always talk in short sentences. You know, don't speak a long sentence. They are unable to, the attention is unable, they are not able to hold attention for such a long sentence. For example, if somebody you want to offer tea, don't ask, do you want tea or coffee or juice or something else. Just ask, do you want tea? No. Do you want coffee? Short sentences, and they're able to relate. Facial expression is very important. They always feel that people are mocking at them, people are making fun of them. Smile at them, but not in a mocking way. Often we find children and older people making fun of their older people who have dementia. For example, the first thing that happens when your cousin or somebody comes to a person who is in dementia at your home, what is the first question they'll ask? Anyone? Enne manasilayo? Do you remember me? And this poor gentleman is struggling to remember, and he keep on asking, do you remember me? Do you remember me? Can you remember me? And you know, this fellow gets desperate, and then the wife comes in and helps him and says, this is so and so. So asking such questions make them very, uncomfortable. So don't ask such questions, calmly wait for a response. Don't talk. Don't keep on giving them clues. Let him take his time and slowly and then respond. If they are hard of hearing, lower your tone of voice, and make your voice a bit louder. The problem with, when you speak with a high tone and a high loud sound, they think that somebody is angry with them, somebody is scolding them, so they get very agitated. Do offer food, drinks, or activities according to that person's liking. And finally, do reminiscence with the resident. Take albums, old albums, let them see their marriage photos, or let them see their honeymoon photos, or let them see their first child was born. Those old memories bring in lot of, good feelings to them, and they are usually people are aggressive. They just settle down when you do this. There are many other forms of therapy, music therapy, a lot of other things, but there's no time for today. And few things that you don't need to do. Don't ask too many questions. Like I said in the beginning, would you like coffee or juice? Full stop. Don't ask, give them 5 options. They get lost somewhere along the way. Don't stand over the individual in dominance. When you have a person on the bed, don't look down on this person. Probably if you can kneel down and you have an eye-to-eye contact, that makes them much more comfortable. Now, we had a person who was 77 with severe Alzheimer's dementia. His grandson came from the US to see him. This grandson was 6 feet tall. And this gentleman got threatened by this 6-foot guy. And he said, this guy has come to attack me. Please send him out. So sadly, this young boy who came all the way from the US to see his grandfather could not see his grandfather. And he returned after a week. Because they feel very threatened when somebody bigger comes, they think somebody's going to attack them, somebody's going to really bully them and those kind of things. Don't invade their space. Don't treat them like a child. Give them their space, and don't be afraid of touch. Touch them gently, they feel comforted, they feel cared for. And never disagree, argue, or correct. Very important. One quick story. There was a gentleman who was lying on his bed with dementia. There was a caretaker on the next bed. Suddenly, middle of the night, he got up and said, I am on a coconut tree, I am going to fall down. Now, what would you say when you are the caregiver? Normally, what would you say? You would say, Appa, you are on the bed, see the bed sheet, see the pillow, see this, see that. But this guy was very smart. He said, just wait, Appacha, I'll bring you down, just wait. And he said, okay, put your right leg, put your left leg, and slowly brought him down the coconut tree. He was actually lying on his bed, but he suddenly had this feeling that he was on the coconut tree. And in about 3 minutes, he brought him down the coconut tree, and then both of them slept peacefully that night. But suppose this guy had argued and said that it is not you're on the bed, you're on the bed, they would have fought the whole night and both would have lost their sleep. So I just close with this last slide. It says, it's about a carer who wrote this. I will fight with you. I will remember for you, because they can't remember. I will advocate because of you, and I will one day honor the memory of you always, until the sun will rise over a day without Alzheimer's and dementia. Thank you so much.
Thank you, Manoj. Such an effective communicator. It was so clear and so simple. I think we will have a little discussion and maybe few questions from the audience at the end of the session. I think we are running a little bit late. And Dr. Chalamdas next will be explaining to us the behavioral problems, how to manage them. Thank you.
A warm good evening to the dignitaries of on and off the dais. First of all, I thank God, then Dr. George, the organizers, Dr. Manoj for supporting me for doing this. And at this hour, particularly doing a boring topic like psychopharmacology or the managing psychosis in a person with dementia is not that easy, and often it goes to a kind of a boring sessions, but I will try my best to lift your spirits. So why I take this psychiatry as a profession? Actually, basically, when I had my MBBS, I was not at all as a liking for psychiatry. But later, when I had to see their sufferings, the way they suffer, the way they, and some of my the misbehavings by my colleagues or my friends to persons with afflicted with psychiatric illness, I'm really took a decision to carry a profession of psychiatry. And everywhere, if we treat, whether it is dementia or is a ADHD, we have to have a lot of empathy. Then only we can have a effective communication of our skills, particularly in a person afflicted with dementia. We have to have that kind of an empathy. We have to have that kind of care that comes from our heart. So I think that is what made you come here. You all definitely have a kind of a kind heart and has an empathic heart. So that's why you are here. I really appreciate each and every one of you for attending this session. And with that, I'm going to my slide. You know, the dementia, as Dr. George has said, it has got a lot of cognitive as well as behavioral issues. And the behavioral issues, the current psychopharmacologists say, as they tell it as a BPSD, that is behavioral and psychological symptoms of dementia. Other BPSDs are there, like bipolar spectrum disorders or borderline personality disorders, sometimes called BPD, BPSD. So don't confuse that with BPSD. It's a behavioral and psychological symptoms of dementia. And you can have a lot of cognitive and behavioral issues in a person with dementia, like apathy. Apathy is a person usually very energetic, like Dr. Manoj or Dr. George. That kind of a person, sometimes when dementia creeps into their life, they becomes very, they lose their drive and the energy with which they are used to do things, they lose that, and They lose interest in a lot of things they used to do previously, like playing football or listening to music or enjoying a film. That's apathy. Then anxiety they will develop. Anxiety is, the persistent worries and fears. I can say that nobody in this world is free of anxiety. Anxiety, the fears and worries is actually driving a person. Okay, you take insurance cover because you have anxiety of death. Okay, so everybody is actually move forward with an anxiety in them. So nobody can say I don't have anxiety. So likewise, the person with dementia will also get anxiety, predominantly worries and fears. Then he can develop depression, persistent low mood and lack of energy and enjoyment. That is called depression. It is not just a short time low mood or sadness is not called depression. It's a persistent, maybe up to 2 weeks of low mood and lack of energy is called depression. Then that person sometimes can have disinhibition. Disinhibition is what they call a person is doing things actually he is not intending to do. Like previously he was not kind of an abusive person and now he is abusing and now he is aggressive. So that is called disinhibition. And sleep problems they can have, and psychosis, agitation, aggression they can have. And this I will explain a little bit more. And the prevalence of behavioral and psychological symptoms of dementia, you can see 12 symptoms are there and the 9 symptoms are mostly seen. You can have around 30 to 40. Yeah. So those symptoms are very common: apathy, depression, aggression, sleep, anxiety, irritability, appetite disorder, aberrant motor behavior, delusions. All these symptoms are common. We can see, if you take a person with dementia, you can see each and every one in most of them. And the behavioral and psychological symptoms can take 2 forms. Like sometimes a person can have a physical aggressive kind of that kind of a behavior he can develop. He can be very aggressive. He can be and sometimes non-aggressive persons will also be there. Physically aggressive, like he can kick you. If you are a caregiver and you are going to pacify him, sometimes he's irritated and he can kick you. And he can hit you, he can grab you, okay, and he can push you, he can throw things at you, and he can bite you. So they become like children, we say. Okay, they lose the inhibitory part. The things they usually what we don't do is actually controlled by a brain area that is called prefrontal cortex, and they can lose that prefrontal cortex and they can have aggression towards you, can bite you, scratch you, and spit towards you, and they can hurt themselves and others, and they can destroy property, they can throw things, and they can make sometimes sexual advances to others. I remember a history like usually sons and daughters came to me, and their main complaint was their father was making sexual advances to their mom. Actually that lady was in a bedridden state with a stroke. She was afflicted with stroke and she was bedridden, and this person used to take care of that lady very well, now is having a physical approach for sexual interaction. So these kind of things are very annoying to the family. So they will come with a very with much pain in their heart. And so we have to pacify, we have to explain things to them, and sometimes they may get offended because of these kind of symptoms. And non-aggressive symptoms, like they sometimes they go out of their room, and sometimes they may lose because they cannot remember who they are or from which place they belong to. So they will move out, and they can pace, they can dress inappropriately, and they can eat and drink inappropriate things, handling things inappropriately. They will hide things. they may not be able to remember and recollect and get those things, and they can hide things. They can hoard things. Hoarding means collecting usually not the useful items, and they will keep it the old materials like old broken glass pieces or spoons or all those things. That is called hoarding. And they can perform repetitive mannerisms like dancing or those kind of things. And they will develop a general restlessness. That is called. Then sometimes they can have verbal aggressive and verbal non-aggressive kind of symptoms, like they're screaming, they howl, they're making verbal sexual advances to particularly the caregivers. The caregivers have to be very, expect these kind of things from them. Okay, they can have verbal sexual advances, and you have to be careful. And cursing or verbal aggression they can have. Then non-aggression kinds, they can, as Dr. Manoj said, they can repeat a simple thing on and on. So that you have to be aware. They can make strange noises and complaining, particularly if they are having a history of a personality disorder like cluster B. They will be complaining, the son is not taking care of me, the caretaker is not taking care of me. And negativism is a kind of thing, even normal persons can do that, but that is not negativism. Like if our parents are asking to do us some specific things, we may not oblige to that. Okay, so that is not negativism. But in dementia, you can have a lot of negativism. They won't accept what we are telling them, and they won't do that. That is called negativism. Then constant unwarranted request for attention. These also can be seen in the persons with the previous history of personality disorders. They request somebody should be there. Sometimes this may be due to the inherent fear they may develop, or anxiety they may develop. After that they request unwarranted attention. But sometimes some persons with a personality disorder also will have this kind of attention-seeking behaviors. And you can see psychosis is very common in most, particularly the dementia with Lewy bodies and Parkinson's disease dementia. It is very common. Psychosis is very common. Hallucinations and delusions can be seen in more with Lewy bodies and Parkinson's disease dementia. And what are the features of psychosis? We are talking about psychosis, and what is psychosis? Psychosis is nothing. It's a persistent condition, and the person is having delusions, hallucinations, and agitation. So delusion, what is delusion? Delusion is it's a form, it's a very firm, fixed idea. The person is having a very false, fixed, firm idea, and we cannot correct it even if present counter evidences. So that is called delusion. And the person afflicted dementia may be telling you, the neighbor is coming to my home at night and he is taking my things. Or the neighbor is coming to my home and he is poisoning my food. And even if we try to correct this kind of a thought, we cannot. So that is called a delusion. Then hallucination, it's a perceptual disturbance. Then the person is seeing a person we can't see, but he can see. Okay? That is called a perceptual disturbance without a stimulation. So that person with dementia can really see a person sitting there. And whole lot of persons are seated opposite to the window. He can see them. And he can hear them talking. That is called auditory hallucination. So hallucinations are there, visual and auditory are there, very common in dementia. And as I said, delusions and hallucinations are very common. Particularly, the delusions we usually see is the paranoid one. What is paranoid one? Paranoid one is they are thinking that other people are trying to harm them. That is called paranoid. Okay? Then visual hallucinations in the form of people looking at them at night and all those things. So delusions and hallucinations are there, very common in most forms of the dementia. And what is the significance of psychosis in dementia? So we are speaking about psychosis, and what is the significance? how psychosis affects a person with dementia. Psychosis in a person with dementia is actually indicative of a more severe form of dementia. So, if you're seeing a person with psychosis, then you can understand that that person is having a kind of dementia which is severe. So, we have to treat it in a very aggressive way, and more caregiver burden and more rapid progression, more need of institutionalization, and more chance of death in a person with psychosis. And how we manage this psychosis, that is the theme of my presentation. We usually, what we do is we can have evidence-based, it's a multi-pronged approach, evidence-based, multi-pronged approach consisting of psychiatrists, sometimes psychologists, psychiatric social workers, then caregivers. So all these people must be included in caring a person with dementia when there is a psychosis there. Even if otherwise you need this kind of persons, but particularly if psychosis is there, you need a collective approach. Then only we can manage them well. And before managing their psychosis, we have to have certain things ruled out, like some reversible precipitants like pain and nicotine withdrawal. Because they are like children, they can express it to you. A person with dementia is having pain, but he can express it to you. So you have to look into areas where this person is having pain from which part. So you have to touch and feel and bend and look. So that's an important thing to look for pain. And if the person is a smoker, and don't stop it suddenly, okay? Because you know, nicotine withdrawal and that is one of the most difficult addictions to take care of, okay? That is very difficult to quit, the nicotine withdrawal. And then medication side effects and infections, particularly urinary infection. You have to look into urinary infection, lung infection. These two infections are very common with dementia. So the person may be showing agitation or psychotic kind of symptoms due to this kind of disease, these kind of illnesses. So we have to look into that also. Then non-pharmacological, what is the current consensus is non-pharmacological methods are the mainstay of the treatment in a person with dementia. And the psychopharmacological, the medication used therapies are not at all, as of now, it is not come into the fore. Because the brain is already having plenty of degeneration, and the medicines won't have enough receptors to act. So that is why predominantly the non-pharmacological approaches are useful in a person with psychosis. And you have to identify two things, psychosis and agitation. This is very, very important because the treatments are different. You have to identify psychosis and agitation. So how we can differentiate between psychosis and agitation? Psychosis is predominantly with a delusion and hallucination, and sometimes it can be associated with agitation. And how we can differentiate agitation? Agitation is entirely different thing. It's an emotional distress. A person with agitation will have emotional distress, and he will be restless, and he will be irritable. So these things you should remember as caregivers. Agitation, differentiate between agitation and psychosis, then go and treat them. Otherwise, agitation can be due to, as I said, pain or hunger or boredom or thirst. These things can lead on to agitation. And sometimes the environmental stressors, the caregivers may be too harsh. Okay, as Dr. Bobby Sara was telling, sometimes the caregivers are very harsh, and then they may not be amenable to our requests. So they do whatever they do. And sometimes they make them do unpleasant routines. If a person with dementia is not having a liking of climbing up stairs, and the caregiver is trying to make them climb stairs, so he can get agitated. So we have to find and rule out these kind of things. Then the essential thing is we have to support and train the caregivers. That is the most important thing, because psychiatrists and psychologists and all other palliative care teams are seeing people with dementia for quite some time, maybe for 10 minutes or 15 minutes. But the rest of the time is you guys, like you are taking care of them. So you need to look into these kind of things and educate them and teach them problem solving skills. And if the person is finding difficulty holding a glass, then you can help them find a solution for that. And a person is agitated and having a delusion, we can distract him. Okay, we can distract him, and we can provide exercise and activities to release his pent up energy. Then we can make him engage with a lot of people, give some relaxation techniques. Reminiscence therapy. Reminiscence therapy is like we can provide them with photos and videos and their previous years, like their childhood and their school years. You can provide them with a lot of photos and videos, and this can make them relaxed. And music therapy is found to be effective. All these therapies, only the music therapy is having some kind of a robust evidence to calm a person with agitation or psychosis. And aromatherapy is use some plant products, like I seen some products of synthite. They can use some plant oils, and they can use massaging and all those things, and they can calm down an agitated person. And use aromatherapy, different kinds of good smells, and pet therapies. Sometimes even purring of a cat can calm a person with dementia having psychosis and agitation. So we have to see them as normal persons and as us. Then only we can have put forward a helping hand to them. So we have to have a lot of empathy. Okay, and I'm coming to one of my last slides. That is a pharmacological treatment. As of now, there is no pharmacological treatment for the psychosis management or agitation management. But a lot of drugs are on the pipeline. The reason I said, because there is not much receptors are there in the brain to take care of the drugs. So even if we give drugs, it will take a lot of time to act. But off-label antipsychotic use is what we do usually. If a person is having severe aggression and agitation, we use off-label antipsychotic, particularly risperidone and quetiapine and olanzapine and those kind of things. And this is the Biomagnetic is another a drug that is evolving, that is found to be very useful in a person with psychosis and a Parkinson's disease. And you know, Parkinson's disease will be developing later stage. Sometimes in most of the persons with Parkinson's disease will develop dementia, psychosis later. So this Biomagnetic is found to be very useful in persons with psychosis and a Parkinson's disease, and that thing is actually extending into this psychosis also, psychosis in dementia also. So that is one of the best drug. I think it has to come. I think it will come maybe within 1 to 2 years for managing psychosis in dementia. Until that time, we have to be satisfied with off-label use of antipsychotics. And for agitation part, the one drug in the pipeline is the brexpiprazole. You have heard of aripiprazole, and this is the brother of aripiprazole, is the brexpiprazole. And another is dextromethorphan and bupropion combination to counter agitation. So these are these three are actually good drugs, and we are awaiting their coming into the market. I think they will come maybe within 1 to 2 years. And this is all I have, folks, because we have to see this psychosis and agitation and all those things. I'm again telling you with an eye of much empathy, and we have to stay with them, and we have to support the caregivers also, because the caregiver is the mainstay of treatment of persons with dementia. So we have to support them very well. We have to teach them. We have to arrange classes for them. Then only we can have a good solution for this dreaded disease, dementia. And two things you can do to avoid coming of dementia. Usually people will ask, doctor, what should we do to keep away this devil, this dementia? So the current two things are, one is keep away anxiety. If anxiety and depression are forerunners of dementia, if a person is with anxiety and depression and not getting treatment, there is high chance of getting dementia later. So treat. If anxiety is there, treat. Depression is there, treat. And make your brain very active. You read, exercise is another thing to keep away you from dementia. And with that, and thank you all for giving me this wonderful opportunity. Once again, I thank you.
Thank you. Thank you, Dr. Chalamdas, for such a simple and clear explanation of exactly the most challenging part of looking after dementia. I believe the vast majority of the audience sitting here are in that field, and I'm sure you can identify what Dr. Chalamdas has been describing and the background, why they are behaving like that. Now that we realize what exactly is dementia, what is the depth of dementia in our society, in the family, and as a nation, it is important that we should have some guidelines and policies about this disease process. In order to do that, I shall invite Dr. Renu Varghese, who is joining us from New York. She's a clinical gerontologist. Shall we connect? Looks we have some technical problems.
So good afternoon, everyone. I hope you can hear me.
Sorry?
Can you hear me?
No? Oh, yeah, sure, yeah.
Oh, okay. All right. Thank you. So I just wanted to thank everyone for waiting this long. I know this is the end of the day, but hopefully, thank you for the panelists who talked before me so that you set up the stage. I want to thank Bliss Homes for extending this invitation to me. It's really a privilege to be a part of this conclave. I thank Dr. George Paul for being the moderator for this session. And also I thank all the audience who are patiently waiting, and hopefully you will have a few more minutes. And I tell you, this topic is not very interesting, especially when we go to policy. But hopefully I will be very specific and I'll be very short so that we can have some discussions after that. So if somebody can forward the slides, that would be good. So I'm going to be specifically speaking about the global dementia plan set by WHO, and also the prevalence of dementia, and it was going to be a comparative session of action that was set by WHO, then India, strategy actions by India, and also specifically Kerala state. And also we will look at some of the Kerala state initiatives, which is Kerala State Initiative Dementia, that was jointly put in by Social Justice Department and Government of Kerala and ARDSI. And also we will look at some of the schemes. So hopefully this session will be very informative, and I invite you to just listen for a few more minutes. Thank you. So the first session that that you see is the actions that were set by WHO, and this is the target for WHO from 2017 to 2025. So the actions that cover mainly 7 areas. Please go to the next slide if you can. Okay, thank you. So there are 7 areas that WHO gives the action plan for. The first action area is to to declare dementia as a public health priority. So you have heard about the complexity and the intensity of this disease, the symptoms and what the person goes through. So given the range of the prevalence that is coming up, WHO is approaching it as a multi-sectorial way so that we can produce or we can have some policies and legislation for each nation. So the rationale being the development of policies and legislation through a multi-sectorial approach aligns with the universal health coverage of individuals and also for the persons with the disability and diseases. The second area that you see is the action area number 2, that is the dementia awareness and friendliness. So the target is 100% of the countries will have at least one public awareness campaign. 50% of the countries will have at least one dementia-friendly initiative to foster dementia-inclusive society. You know, there is a misconception that dementia is inevitable when you get old, and you have heard from the previous speakers that that is not the case. There is a stigmatization, there is discrimination, and there is a fear of this disease. So the action plan aims to foster understanding about dementia and also to have an awareness of right of these people with dementia and other disabilities. So the society needs to be inclusive. Society needs to understand the needs of the person and also the persons who care for this. And that is the aim. And the Dementia Aware campaign and the friendly program should be tailored to the culturally appropriate programs so that people can really understand and actively participate in it. So the third action area is dementia risk reduction. We heard a lot about how to prevent this process. What are the lifestyles that we should be following. So the target for prevention and control non-communicable disease by 2013 to 2020 and any future revisions are achieved for risk reduction as reported. So there is evidence that shows that there is a strong association between dementia and non-communicable diseases. So that is lifestyle and people with chronic diseases of hypertension, diabetes, obesity, imbalanced diet, midlife, late life depression, all this can cause to dementia. So the rationale is to aim to reduce the incidence of dementia by adjusting the life and having a good lifestyle to follow. So it has to be culturally appropriate. And the fourth area the WHO regulates is that dementia diagnosis, treatment, and care and support. As you know, as the person becomes advanced in dementia, the care needs are more, the person becomes more dependent on the caregivers, and if the comorbidities that we talked about is not treated, the person, the status is going to decline, and early diagnosis and intervention is very important here. So one of the previous presenters also talked about preserving the autonomy and the dignity and the self-esteem of dementia sufferers. It's very important that we formulate a person-centered care, and also whether it is community-based and if the person is an institution. So we have to be very empathetic and we need to understand the needs of the person. The area that goes under 5 is support for dementia caregivers. And we all heard that, especially from Dr. Chalabdas today, that how important is that we need to take care of the caregivers, because we can all talk about dementia, the pathophysiology of dementia, symptoms of dementia, how we should be caring, but really and truly, the people who care for dementia will know the burden and the intensity day in and day out, what they go through without sleep, without food. And persons do not realize that. Only if you are in their shoes, of course, we can realize how much their burden is. So it is very important to realize that and to take care of their healthcare or physical, mental needs so that there won't be any decline for the caregivers. And the essential thing is that, though, is that they are the one who knows this person. They know because they care for them. So it is very significant that we include all of them in the policy making, in the legislation, because they will be the one to tell you because they have true life experience. So the target is that 75% of the countries provide support and training programs for carers and families of people with dementia by 2025. So action area 6 is the information systems for dementia. So information system or data is very important to make any decision, because if you don't have evidence-based legislation, that doesn't mean anything. So we need to have strengthened our information. We need to be able to collect the information so that we can use it for future purposes. So the target is 50% of the countries routinely collect a core set of dementia indicators through the National Health and Social Information Systems every 2 years by 2015. So the rationale is that the systematic monitoring and evaluation of the system can provide the best available data so that we can form procedures, coordination of care, and also some of the policies. The last dementia action area is dementia research and innovation. This is last but not the least. You know, research is the priority. Dementia research is the priority right now because the translation of knowledge from bench to bedside is very important as practitioners, whether they are dealing with any type of dementia, whether it's in the community, whether it's in acute care, or in this institution. Knowledge is what they need. So evidence comes from this research. I know it is that you need fund to have all this done, but the target is that the output of global research on dementia doubles between 2017 and 2025. So then the thing is that we have to have interprofessional collaboration in research because the disciplines need to know, and also between the states, especially in India. So we have to have research innovation, technological innovation, and that probably prevent dementia incidents. And also we never know, one day we will have a cure for dementia. So I just wanted to, I'm cutting it short because these action areas are rather very lengthy. So I know that it is not going to make much difference if we talk for it today, but I just wanted to give you the basics so that you'll be able to know the foundation. So if you look at the screen now, I just wanted to make a comparison where we are. We have heard so much about it, so I just wanted to touch upon a little bit of prevalence in the world and in India and in Kerala. So prevalence of dementia in the world is 50 million as of 2020, and you know it's going to go up. It's going to go up to 135 million by 2050. And in India, 60 plus is 140 million. I know the numbers may change here and there depending upon the source that you're looking at, but this is kind of an average figure, and this is very recent. So the prevalence of dementia in India, it was 3.6 million in 2011, and look at the data. It's going to go above 14 million by 2051. So that is a huge jump, and you know we are going to have a lot of dementia sufferers in the future. So we need to have something done to prevent that. Now, thinking about Kerala specifically, we know that we are so blessed to have many things as a state as Kerala, so as the number of older people and the dependency rate. We are going up in that way as well. So we have 60 plus of about 4.2 million. That means one person out of every 8 persons in Kerala is 60 plus. And prevalence of dementia is about 0.2 million 2021. This is according to Dr. Hriday Raj from Trivandrum, who is an economist, so it is very recent. So all this data are reliable because it's from scholarly research. Next slide, please. So what you are going to be seeing now is that based on that action plan that was done by WHO, India has taken some strategic actions that is to be targeted by 2025. And this is the report by ARDSI. And these are the left-hand side column, the left column that you will see 7 areas of action by WHO. The middle column, you will see the strategic actions by India targeting for 2025. And the extreme right column is going to be suggested activities. Of course, I'm not going to go into detail because it's going to take a long time. However, I'm just going to touch upon some of the interesting facts that we all should know as citizens of India and especially as Keralites because of the prevalence that I have just mentioned. So number one, that dementia as a public health priority, the increasing the awareness. So India has targeted that 30% of all states in India will have developed their own state program and strategies by 2025. So 30% of the states in India. So that means, whatever approach that they would take, multi-sectorial approach involving many sectors in social and community, state-specific strategic programs so that it can reach to all levels of people in India. So second action is to increase the awareness and friendliness that I have talked about, the discrimination, stigmatization, isolation that is faced by dementia sufferers and also dementia caregivers. So the strategic plan for India is 80% of the states with ARDSI chapters with public awareness campaigns will go on, and 50% of the states with dementia-friendly initiatives, and they will have sensitization materials also will reach the community. So we talked about the lifestyle. So all this sensitization material will be at least focused on the prevention of dementia, to change the lifestyle, healthy eating habits, the community-wise, how to decrease the stigma, and how to improve or promote awareness activities, and how the sources can be available, so resource utilization. The third factor is risk reduction. We have heard enough about it. Alcohol, substance abuse, smoking, sodium intake, all these are risk factors. And then people need to know how to avoid those risk factors so that they can prevent incidents. Diagnosis and treatment. India targets 30% of states to have minimum 40% accurate diagnosis. So there is a problem there because all those professionals that are working for this population need to be careful that we are making a correct diagnosis and an early diagnosis for early intervention. So India also target to have 24/7 care for dementia. 30% of general practitioners and paramedical gets the training by 2025. So we will be able to have intervention protocols, allocated hospital beds in district hospitals, that is 150 bed for them, and also palliative care. Caregiver support, a very important area that I talked about. ARDSI is doing a phenomenal job. They are trying to reach all the states, and at least 40% by 2025. So, and activities is that, for caregivers, actually, they're giving health insurance, transportation, pension, medical care, and curriculum design. Curriculum design in the sense that, as a person who knows India very well for the last 23 years, I've been so much involved in aged care. And as one of the researchers and as a clinician, I can say this, that I've been promoting that there should be syllabus, there should be some curriculum, there should be an integration of the aged care coming from school curriculum, never mind the college curriculum, so that the children will know what is aged care about. Because many of the things that we see in the society today need to deal with how our children are brought up in a society where they are going to see a lot of older people. Research and intervention. This is very important. As a researcher, I could tell you that ICMR, Indian Council of Medical Research, and Department of Science and Technology and Department of Biotechnology All these departments come up with the research and innovation for dementia, and they are doing clinical trials, randomized control trials, systematic review, meta-analysis. All these are type of research that they would be doing on assistive technology, dementia-friendly infrastructures. And last but not least, that I talked about information system, because as all researchers and clinicians, we know that we cannot do anything without data. Data is the proof. Data is the basis. So information system need to be strengthened. Our data collection need to be strengthened, and also is data analysis, so you can analyze the data. So the next slide will show you some of the programs that already, it's not specifically for dementia, but it covers older people, and also people with disabilities. You know, and I'm sure that many of you have heard of these schemes and programs, so I'm not going to go in detail, but I just wanted to mention Citizen Act of 2007, National Policy NPOP for 1999, and some of the central sector schemes, Interministerial Committee, old age pension schemes, National Policy on Senior Citizens 2011, National Program for Palliative Care. And the right side is a little blurb on what it does. And as the name suggests, we have some mental health programs, which is NMHAP, and Abhyudaya Yojana, I think that is for medical facilities, and also Ayushman Bharat for digital infrastructure. The next slide, I just want to take a few minutes, and I want to focus on what Kerala is doing. So it is very commendable to see that Kerala, out of all states in India, took the initiative to have a dementia program implemented in 2014. So this was a joint venture by the Department of Social Justice, the Government of Kerala, Kerala Social Security Mission, and ARDSI. So Government of Kerala alone, if you look to the right side of the screen, all these are done by Kerala government. You know about Biomitram. Biomitram provides medical care. I think it is free medicines and also psychological services for eligible candidates. Ashwasa Kiranam is a monthly monetary assistance for eligible older persons, just to assist them. Vayomatiram, as the name suggests, it has to do with diabetes mellitus, and you know that Kerala is one of the capital, I guess, states where there is high incidence of diabetes, and it is very high in older people as well, because we have heard from previous presenters in other sessions too, older people are living longer with chronic diseases. So Vayomatiram is the free distribution of glucometers for those who have diabetes. And Amridam is the medical management or the treatment for those living with chronic diseases. Mandahasam is one of the schemes to give dentures, free dentures to older adults. Sayam Prabha Home Project, that is a daycare project for the elders. And Central Sector Scheme, that is the basic shelter and food and amenities like that. Ayurarogyam, that is implemented in Kollam for geriatric care. Palliative care and policy. It is commendable to say that Kerala is the first state to start palliative care for end-of-life stage, end-of-life care. And 841 palliative care institutions out of 908 in India is in Kerala. So that is really commendable. And Smruti Padam is actually focused just for demented residents by Kerala government. And palliative care, there is one in Trivandrum and also one in Kozhikode that trains the professionals. And there are some NGOs and voluntary organizations in Kerala that works for the older people. One is Kudumbasri, although they do other things, but they also take care of the older people who need assistance at home, and also Harsham Geriatric Care, that is also my NGO. I couldn't list all of it, and I'm sure that there are many more that is not listed. You cannot see in professionally, that displayed or maybe studied about. And I know that there are many volunteers who come up and who spend their time in hospitals and old age homes. I just wanted to talk one more slide. I'll be stopping. This is my the last, but the one slide more. So from 2014, Kerala has implemented daycare centers in Thrissur and Kochi. They have published memory clinic guidelines by ARDSI. There is Dementia National Helpline at Kochi, actually by Department of Justice, Social Justice Department and ARDSI. And there are operating procedures for daycare centers and dementia care centers, and also skill training for personnel, as you know, is ARDSI. So the recent development, all of you at Kochi, I'm sure that you know this. Kerala Chief Minister declared Cochin as the dementia-friendly city as of 2021 October. And more recently, Dr. R. Bindu, Honorable Minister of Social Justice Department, declared in April 2023 as the Udbodh. The project has been implemented by Cochin University of Science and Technology. And I think the services broadly, they cover psychological counseling through direct contact or by app. And they also give legal advice, clinical facilities, day and evening programs. So the second, this is the first phase, and the second and the third phase is expected to expand to the entire district. So this is, in a nutshell, the policies and the programs that we have. We do not have specific laws that deals with dementia residents or dementia care. However, we have legislations and actions. But my last slide is about my personal view of things. Like I mentioned, I'm very closely associated with, as a chairperson of Family Group Foundation, as a researcher from 2000. I was able to visit that time. There was no old age homes in Kerala. I was able to spend my years in Chennai, and I was able to do my first study comparing the developed and developing nation and for the institutionalized elders. So we have come so far in the last 2 decades, and I can say that there are more institutions for elders and people are more aware. We were in the rudimentary stage, now we have grown up. However, and I think this is my personal view from my experience, I think dementia screening and assessment is very, very important. We talked about and we heard about why it is important for early detection and early treatment. So dementia screening should be a part of routine and primary care. Anybody above 65 years of age, I think this should be made a part of the routine care, whether it is in the hospital or in old age homes, for retirement homes we call. But I think we need to have an interdisciplinary team who is able to assess whether or not the cognitive level of the person. So there are many assessment tools. MOCA is one, mini mental state examination is one. So I am not sure how many of our homes are really doing an exclusive comprehensive assessment to do this and to care for them. So we know that dementia has many stages, dementia has many symptoms, and we also saw that dementia needs to be cared for depending on the stages. So I think the parameters should include that should be mandatory. Every home the person comes into for the long-term care, it should be made mandatory that the cognition, for example, orientation, judgment, decision-making, language, praxis, performance, not only when a person's cognitive area is affected, there are many other systems going to be affected. For example, the person's behavior. We heard about anxiety. We heard about depression. So there should be at least I think the caregivers and the team should be able to distinguish between depression, dementia, and delirium, because people do come with all of the symptoms, because I see this every time for the past so many years. And I think we need to be a little bit more cognizant about the behavioral problems that the person presents with, and also deterioration of ADLs and the physical assessments. So if there is no assessment tool, and if there is no baseline information, we will never know whether the person is going to be progressing or the person came with dementia. If the person did not come with dementia, did the person develop at home? So comprehensive assessment, interdisciplinary team who are well equipped to understand this is the need of the hour. We have talked enough. I think there are strategies in place, but now it's the time of action. So ARDSI is doing a great job, but I think more training needs to be implemented for health professionals, for physicians, for nurses, the licensed practitioners. There are no geriatric specialty certification for even nurses. And I know that there are some of the geriatric specialty courses somewhere, but that's not enough. It's not only enough to start these programs, but it is very needed whether we are evaluating on those. Mandatory evaluation, mandatory trainings. Otherwise, we will be still there talking about what the target would be. If you want to reach the target, this is what we should be doing, and that is called capacity building. I thank everyone who are listening patiently to me, and thank you everyone for this great opportunity. It's a privilege of mine. Thank you, Dr. George Falk, and all the panel members in the audience.
Thank you so much, Dr. Renu, for this extremely informative presentation, explaining the local, state, national, and international services, strategies, and one principle behind effective care of dementia patients. That is just one word: understanding. Understanding what is dementia. If you don't know what is dementia, you will never be able to care for a dementia patient effectively. It will, most of the time, it ends up in a wrestling competition. There won't be any difference between the patient and the carer. So, those who are on the supervisory side will make sure that anybody and everybody who looks after dementia patients understands exactly what they are doing and who they are dealing with. I would like to take this opportunity to thank Bliss Retirement Home once again for making me a part of this event. And I would like to thank Manoj, Dr. Chalam, and Dr. Renu. Thank you so much. And last but not the least, for you listening to me and listening to our panelists. Thank you so much.
Thank you so much, Dr. George. I would like to request Mr. Venu sir to please come on stage really quickly to hand over the memento to both of them. Thank you so much. Now we're jumping right into the next session, which is the Introduction UN Decade of Healthy Aging. And Venu sir, since you're already here, it's my absolute honor to introduce Mr. Venu Rajamoni, IFS Officer on Special Duty from the Government of Kerala. So, And along with him, I would like to welcome on stage Dr. Sal Chaco, who is the founder and president of YVI Ilaga, member of NGO COA and IFA. Please put your hands together for her as well. I would also like to welcome on stage Dr. Chandana Unithan, who is CGH member, Chief Scientific Officer, Lifeguard Digital Health, Professor Digital Health, and Torrens University, Australia. And along with them, we have online joining us Dr. Cynthia Stewart, who is a chairperson of NGO COA UN, and Dr. Jane Barrett, Secretary General IFA, and Ms. Jo Boylan, Chief Executive Officer at Clayton Church Homes, South Australia. All three of them will be joining us online.
Good afternoon, ladies and gentlemen. Warm and special welcome to my fellow panelists who are here with me, Dr. Sal Chaco, founder and president of the YVI ILAGA, and Dr. Chandana Unithan, who's based in Australia. We have 3 participants joining us online, and one of them, Dr. Jane Barrett, Secretary General of the International Federation for Aging, based in Canada, is in a hurry because the session got delayed. She has another appointment in another 15 minutes. So instead of making the chairman's remarks at the first, I shall invite her to speak, and then I will speak after her. Dr. Jane Barrett, can we have her on the screen? This session, as most of you would know, is on the UN Decade on Healthy Aging. Dr. Barrett, you're muted. Can you check your...
No, I'm
okay.
not muted on my end.
Yeah.
Is it
We
on
can...
your end?
Now we can... Go ahead.
Okay. Thank you very much. And it's a great pleasure to be with you this afternoon. Congratulations to the organisers, for a very robust agenda and an important agenda to understand the issues that we're all dealing with when it comes to a life course approach to ageing. Could I have my slides, please? Can the slides be put up?
Yeah, they're coming on.
Okay, thank you very much. So in the next few minutes, I'm just going to be touching on some of the elements of the UN Decade of Healthy Aging. Next, please. The International Federation is 50 years of age this year. So, we are moving into that latter half of what we understand as, the life course approach to aging. We have a vision of a world of healthy older people whose rights are both protected and respected. And so this conference is important to start unpacking some of the issues related to what it really means to be healthy and growing older. Thank you. As I've said, we are a global pointed connection for experts and expertise, and we believe that it's bringing unlike together that is going to create a common agenda moving forward, because health intersects with so many aspects of our lives. There are 3 fundamental domains when we're talking about healthy aging. It's our functional ability, our intrinsic capacity, and the environment in which we live in. We often talk about how do we create an environment that enables older people to do what they have reason to value. But we could also say that how do we create an environment for us all to live and be able to do what we have reason to value. So we need to also recognise that ageism, we need to look through the lens of ageing and ageism. Next, please. The IFA and all of us here today recognise the importance of intergovernmental agendas, and these are some of the agendas that we actually build our work around. For example, not only do we have the UN Decade of Healthy Ageing, we have the WHO Immunisation Agenda 2030, we have the UN Madrid International Plan of Action on Ageing, and hopefully going into the future, we will have a Convention on the Rights of Older People. These are fundamental frameworks that we actually need to hook into, but build our work around and pull through when we're discussing, the rights and the quality of life of older people. Next, please. When we're talking about these intergovernmental agendas, we also have fundamental reference points and reference documents. And one of them, that's really fundamental to our work is the WHO 2015 World Report on Ageing and Health. And this is important because it casts a different narrative around growing older, and the focus is on health prevention and promotion. You might have heard a lot about the work of age-friendly cities and communities around the world. Well, that's one of those action areas. But what the IFA does try to do is make the connection between intergovernmental agendas and these referenced documents, because we need to actually encapsulate those at a national level. Next, please. All of our work is viewed through the lens of the action areas and the enablers of the UN Decade of Healthy Ageing. Next, please. And it's important to make note of what they really are. The action areas: integrated care, combating ageism, long-term care, and also age-friendly environments. But they are the action areas. Now, how do we work in those action areas? And so, the way that we work is we look at our enablers. And next, please. And the enablers are listening to voices and being engaged in meaningful conversations. Older people at the table is not a luxury person. It is a must. Secondly, building the leadership and the capacity of civil society, and that civil society in partnership with, private sector, government, academia, and of course, central to that, the voices of older people. Thirdly, connecting stakeholders across disciplines and sectors, not only nationally, but around the world. And fourth, strengthening the data collection and innovation. And without data, it's very difficult to make the business case for change. Next, please. So we are working towards, in the Decade of Healthy Ageing, a world where all people can live long and healthy lives. Of course, we need to keep acknowledging that, while ageing starts at birth, the social determinants of health are intrinsic to our decision-making abilities and what we need as individuals and within communities. Next, please. Next, please. Thank you. The definition of healthy ageing is an important one to remember. It is a process. It's a process of developing and maintaining functional ability that enables well-being in older age. Next, please. And this really shows us, the trajectory of not only functional ability, but intrinsic capacity. Intrinsic capacity being all of the physical, mental, social characteristics of each and every one of us. And these can change over time. Next, please. Particularly in the latter half of our life, we need to consider different trajectories. And what we all want to be is in the first trajectory, high stable capacity throughout our life. And we have some very good evidence as to how we can help make that happen individually, but in population health. Secondly, declining capacity, and that's that cohort of older people that may be receiving services in their home or may have a family supporting them to live, in their homes. And then many of us will know people in this third cohort and those with, quite rapid declining and loss of capacity and function. In each of these trajectories, we have an opportunity as a society to improve education, improve access, and improve equity to ensure that the services that older people require, are within a rights-based approach and that they are well informed about their decisions. Next, please. Now, we talk about the intersectionality of our policies, and three main pillars that the IFA works and builds our work on is prevention, access, equity. Next, please. And finally, some of the components of an enabling environment and the work that we're doing. So vision health, oral health, vaccination, labour market, but they all actually intersect with one another. What we're trying to build is a world of healthy older people whose rights are truly protected and respected. Next, please. And I thank you very much for being with us today and for me being with you. And thank you for being generous and providing me the opportunity to leap to the beginning of this important session. I wish you well going forward, and I can only think that there were delays because there was very robust discussions. So thank you very much for your time.
Thank you so much, Dr. Barrett. Our apologies for the delay in the beginning of this session and for having rushed you, but we warmly welcome you to visit India and Kerala in the near future. We think you're doing outstanding work and we'd love to hear more from you. Thank you so much.
Thank you very much.
And have a great day.
All right, all the best. Bye-bye.
Please give her a big hand. Good afternoon, friends. As I had mentioned earlier, I postponed my opening remarks so that Dr. Barrett could finish her intervention and then leave for her meeting, which was in a few minutes from now. I would like to begin my chairman's remarks by complimenting my good friend of long years, Mr. Babu Joseph, as chairman of the Bliss Retirement Homes, for organizing this first ever International Conclave on Healthy Aging here in Kochi, and for having not only brought all of you who are physically present here together, but a range of interesting experts from various parts of the world through online sessions. Friends, this session is on International Decade of the Aging, which has been adopted by the United Nations through a resolution on December 14, 2020, and this decade ranges from 2021 to 2030. So the first question in many of your minds might be, what does all this international have to do with what we do here on a day-to-day basis? The individuals, the people, the patients that we deal with, the elderly that we deal with, the social context in which we have to provide them services, the challenges of health, the challenges of resources, etc. Let me say that both in the discussion on dementia as well as the presentation made by Dr. Barrett, it became very clear that it is important for each one of us when we live in this globally connected world to know what happens across the world, to understand that the challenge of aging is not confined to us alone here in this city, in this state, or in our country, but it is a universal challenge. And by knowing what happens across the world, what various stakeholders are doing to address the challenge and the need for developing a plan of action for healthy aging, we will strengthen ourselves to address the tasks that we have. So the problems are universal, and that is one reason why the United Nations, the General Assembly itself, which is the highest body of the UN, in which representatives of 193 countries of the world come together, debate and discuss various issues of the world, has adopted a resolution to have a UN decade on healthy aging. And this follows on from similar declarations made by the World Health Organization, which has been declared by the UN as the lead agency on the topic of healthy aging. Once again, you saw in Dr. Renu's presentation earlier, the crucial role being played by World Health Organization in developing a plan of action for dementia and how it percolates down from the international to the national and the state level. Ladies and gentlemen, the UN is one of the best sources of information, of expertise. The UN, and within the UN, the WHO in particular, brings together the best knowledge possible from across the world in terms of health from all countries of the world. And it is a great resource to call upon when we look at our challenges and need to find solutions. We also have the UN Institute on Aging based in Malta, which is collaborating with this conclave along with various organizations. The UN similarly is also a source of legitimacy. This conclave, for example, is a perfect example of what the UN General Assembly has asked not just governments but all stakeholders to do on the issue of healthy aging, which is to raise awareness, which is to facilitate discussions amongst experts and to engage with caregivers and look at what are the possible solutions on the field that needs to be provided. Ladies and gentlemen, we can also say that the UN is an agency which sets standards, like we saw in the case of dementia. The UN sets benchmarks, and then voluntarily, every country who is part of the UN agrees that they will implement policies which reach those benchmarks. So here the opportunity for organizations like Bliss, for NGOs, for experts, for doctors, the medical fraternity, for everyone involved in the issue of healthy aging is that you can hold the governments to account. Where you see deviations in what the government does, when you see inadequacies in what the government does, you can go to them and you can tell them, look, you have committed to this in the United Nations. You have committed to resolutions which have been universally adopted by the General Assembly, by the WHO, and these policies should be implemented. Or if something is wrong is happening, you can tell the governments these policies should be corrected. So often what happens is somebody from the Ministry of Health goes and attends a meeting in Geneva or New York, agrees to a resolution, the details of the resolution never percolate down, and how is it going to be implemented in terms of policies, not just at the central level in a country as large as India, but also at the state level. But exercises like this provide information to people at the grassroots, which they can use to hold governments, whether at the central level, whether at the state level, or even at the local level, accountable, and to demand from them more action in pursuit of these goals which have been universally agreed. I mentioned that the UN is a great source of information. Let us just look at some figures. What is the global situation with regard to aging? One, by the end of the decade of healthy aging, the number of people aged 60 and above will be 34% higher, increasing from 1 billion in 2019 to 1.4 billion. By 2050, the global population of older people would have doubled to 2.1 billion. Today, there are more older people than children under 5 years across the world. In 2020, for the first time in history, people above 60 outnumbered children under 5. By 2050, people aged 60 and above will outnumber adolescents and young people in the 15 to 24 years or age bracket. And very important information which even I did not know till I came here. We know Japan is aging, we know Germany is aging, but the challenge is actually in developing countries. Most older people live in developing countries In 2019, 37% of the older people lived in Eastern and Southeastern Asia. Only 26% in Europe and North America, 18% in Central and South Asia, 8% in Latin America and the Caribbean, 5% in Sub-Saharan Africa, and 4% in North and West Africa, and 0.7% in Oceania. The number of people aged 60 years and older will increase most rapidly in developing countries, from 652 million in 2017 to 1.7 billion in 2050. And the proportion of the older people in the population will increase in most countries from 1 in 8 persons to 1 in 6 by 2030 and 1 in 5 by 2050. So the pace of population aging is not just accelerating, but developing countries have to adapt more quickly to aging populations than many developed countries. And these developing countries, as we all know, have much lower national income and infrastructure and capacity for health and social welfare. In this global context, let me also give you some figures regarding India and Kerala, taken from the Kerala Economic Review of 2022. According to the 2011 census, there are nearly 104 million elderly persons in India, with 52.8 million females and 51.1 million males. The share of population of people above 60 is projected to increase from 8% in 2015 to 19% in 2050. India's elderly population will touch 194 million in 2031. The India Aging Report of 2017 has projected the total aged population in the country to 34% by the end of the century. As compared to this, the percentage of population in the age group of 60 plus to the total population in Kerala is 12.6% as compared to the national average of 8%. The old age dependency ratio is 19.6% for Kerala and 14.2% for India. The rate of the general growth of population was 12.4% during 2011-2021, when the growth rate for the elderly was 36%. The percentage share of elderly population in India is projected to reach 13.1% in 2031 from 10.1% in 2021. And Kerala ranks top in the country in the proportion of elderly persons, 16.5%, and is projected to reach 20.9% in 2031. So you can see where the challenges, you can see how important these numbers are to understand what is the way forward and also what is the international context. Aging is a fact and a reality which we all know and we must accept. But can we convert that process of aging into a process of healthy aging? And as has already been mentioned, healthy aging does not just mean absence of disease. It means providing the elderly with dignity, with respect for their rights, with equality with everyone else in society. It means providing them with the best of health and welfare measures possible, ensuring their financial security, ensuring their food security, and ensuring their mental health through human interaction and a variety of activities which will strengthen them both to look after themselves but also make them valuable contributors to our society as a whole. There is much that elderly can do in terms of the economy of a society, in terms of the labor markets of a society, in terms of the knowledge economy that we seek to build. And both their welfare and their ability to contribute to our society is vastly amplified by science and technology, by latest developments in telecommunications. So for us, whether we are here in Cochin,
as a citizen of the city, whether we are here as a Keralite, whether we are here as an Indian, whether we are here as a global citizen. The challenge is universal. The best way forward to address this challenge is to join hands, all stakeholders come together, forge bonds of international cooperation with those who know the best, and go ahead with determination and persistence to ensure that no citizen in our country, no person in the world will be left behind, and we will ensure healthy aging for one and all. Thank you very much. Yeah, thank you. Ladies and gentlemen, I would now like to invite Dr. Cynthia Stewart, who chairs the NGO Committee on Aging, which, as per the NGO Committee, which interacts closely with the UN, and who is the main representative of the International Federation on Aging to various UN bodies, to address us. Dr. Stewart, the floor is yours.
Thank you so much. You did a beautiful job of setting the stage, as well as making the very important point of taking the global to the local. And we're all interconnected. And that was just a beautiful presentation. Thank you. My focus today is to share with you how the NGO Committee on Aging at the United Nations interacts with member states and our NGO network throughout the year, and to focus more specifically on what the decade of healthy aging really means for older persons and why it is a human rights issue. I will share why we need to improve the protection of human rights of older persons and why this decade must be the transformation that is needed to ensure a life course approach to healthy aging. Next slide, please. So, how does the NGO Committee on Aging work? What we do? Well, we've been established since 1977, and we seek to raise awareness of opportunities and challenges of global aging by being a voice in person, in writing, on position papers, making interventions, working in alliances with other organizations to promote the inclusion of older persons. We advocate to integrate aging concerns into all aspects of UN work, such as the Sustainable Development Goals, Agenda 2030. We worked very hard to ensure across those goals that older persons were included. Obviously, issues of poverty, food insecurity, health, of course, health, and also to educate UN that older women's health, under Goal 5 and Goal 3, older women are seriously left behind because of years of inequalities and inequities. I'm very excited about Goal 4, that it's not only education and thinking of the early part of life, but lifelong learning. So important. Obviously, Goal 8, where we working for the opportunity for older persons who must or desire to continue working. Goal 9 and 10 on innovation and technology and reducing inequality, very important, as older persons have had a lifelong, inherited a lifelong of not having many of the innovations and technologies currently available. And of course, Goal 11 on sustainable cities and environments, very important. And the very last goal 17 has a section on data. That is where it is very critically important that countries, localities continue to collect data and not have it all just aggregated across all older persons at whatever age your country sets as when that's defined, but to disaggregate it by 5-year increments, because older persons are as diverse as the most diverse of all the populations when you think about our lifelong experiences as we age. We also seek to demonstrate the value of inclusion of older persons. Lastly, we call out ageism. I'm very grateful to the World Health Organization's recent report on ageism that documents how rampant ageism is and the wonderful tools they provide to help all of us educate and overcome ageism across the life cycle. Next slide, please. This is just a list of some of the commissions, meetings that we try to have really focus on throughout the year in advocating for aging concerns. The Commission on Social Development that meets in February is this past year was very significant in that it was also the report of the quadrennial reviews of MIPA, the Madrid International Plan of Action on Aging. And I will report that all 5 UN regions participated in summarizing their regional reviews, which pointed out the need to seek further protection on the human rights of older persons. The Commission on the Status of Women, we continue to try and make inroads and say, women's life does not end at reproductive age. It continues, and older women need attention as well. So that's probably one of the hardest ones we have, the nut to crack. The Statistics Commission, obvious, as I mentioned under Goal 17, we need the data. If you can't document it, it isn't there. But it needs to be in the original documents of the UN that call for data on older persons. The Open-Ended Working Group on Aging just convened, and I'm going to talk more about that later. World Elder Abuse Awareness Day, every June 15th. I look forward to the day when there doesn't have to be an awareness day. However, the pandemic showed us, actually, elder abuse, violence, neglect actually increased during the pandemic. So we have a long way to go. The High-Level Political Forum, the one that meets every July, is the watchdog for what's the status, where are we with our Agenda 2030, all those 17 Sustainable Development Goals. Of course, we observe and celebrate the International Day of Older Persons on October 1st of each year. And also, this being the 75th anniversary of the Universal Declaration on Human Rights, it's a very important year where it will culminate with Human Rights Day in December. Of course, the General Assembly meets in New York every September, and the reports of all of the various bodies will come to them. Next slide, please. Now I'm briefly going to delve into a little bit of the human rights of older persons. As I mentioned, in the Universal Declaration on Human Rights was passed in 1948, and it covered a lot of areas. However, there was no mention of age. There is an other category, so I guess we are considered sort of others. Perhaps it's understandable in some ways, and when you think about mid-1900s, what was the average life expectancy? Not that great by today's standards. But there was increasing awareness for the aging population. And so in the first World Assembly on Aging took place in 1982 in Vienna. In 1999, the International Year of Older Persons was marked by the UN, and the Second World Assembly on Aging took place in 2022, and its outcome was the Madrid International Plan of Action on Aging. The General Assembly of the United Nations established the Open-Ended Working Group on Aging in December of 2010 to look at the possible gaps in the human rights protection of older persons. So each year since 2011, we've been meeting. Earlier this month, in early April, we had the 13th Open-Ended Working Group on Aging, with finally some progress. Based on the previous year's action, a core group of about 20 member states came up with a resolution that was adopted by consensus that moves us forward. It calls for 2 co-facilitators, one from a developing and one from a developed country, to be appointed by May 1st, and for them to consider the gaps in the protection of human rights in older persons and how best to address them. And here's the important part for all of us. It calls for that process to be open, transparent, and informal intergovernmental organization meetings with intergovernmental organizations as well, and the NGO community, as well as getting input from our expert on the independent expert for the protection of human rights of older persons. Something we should all be aware of is that the Office of the High Commissioner on Human Rights and the Human Rights Council is based in Geneva. It reports to the United Nations, but it is based there. And while they do have regional offices, and there's certainly one in New York, very important group, and they're the ones, as this slide is showing you, they monitor all of the human rights treaties that have been adopted. Because since 1948, there have been a number of other treaties that have had to enhance the Universal Declaration on Human Rights. Most recently was the CRPD, the Convention on the Rights of Persons with Disabilities. And another one, CEDAW, the Convention on the Elimination of the Rights, Convention on the Elimination of Discrimination Against Women. They're very important to bring populations that were not well articulated in the universal. And that's my whole point. Because older persons were never mentioned in that original document, it is time, given the longevity that we all should be grateful for in all of the world, developed and developing, it is time. It is really time. So, next slide, please. So why do we need a convention to protect the human rights of older persons? Well, as I showed in the previous slide, we really do need to protect the human rights. And if the pandemic taught us anything, it was outrageous violations of the rights of older persons. Older persons were triaged when they got to a hospital, simply based on age. Older persons, at some point when we had the vaccine, were withheld vaccines till younger populations could be vaccinated. People in some places with long-term care were some of the last places to get the protective equipment, and the isolation that older persons experienced living in long-term care and in communities during the pandemic also taught us something very important: digital inequities. Older persons were isolated and had no way to connect. And if anything, I think the whole world discovered we can do so much more, just like today. I can't be with you there in Kochi, but I can be with you and share our ultimate concerns together. But the last thing I want to say is what is so important about why we need a convention is we all must work to overcome ageism. Again, I referenced that WHO report on ageism, and there are many tools and wonderful ways to help us think about and educate. And it has to start with the very young. It's documented in research that by age 3, little toddlers recognize and begin to assume their attitude about aging. We have to make sure that that learning, that trajectory shows positive, helping, caring concern of all the generations to live together, to indeed create a society for all ages. At the very end of this presentation, I have a page of useful resources that will help you. So, next slide, please. What you can do. You can educate and raise awareness of what a convention, that's a legally binding document, can do to overcome the lifelong inequities faced by current populations of older persons. You can lobby your own government to include older persons at the table and ensure older persons' voices are heard. Just as the disability movement leaders said, nothing about us without us, well, as Mr. Venu said at the beginning, it's part of the preamble of the Agenda 2030, leaving no one behind. So familiarize yourself with the human rights mechanism and follow the work of the independent expert on aging. She's fabulous. She's just a fabulous person, wants to have input, will make country visits. But lastly, I want to say, we all have to own our own aging and be a role model of healthy aging, because I believe we do have the opportunity to embrace the decade of healthy aging and all of its many tools available to us to make a very big difference. And I'm particularly looking forward to next year's open-ended working group on aging in April, as we move to ensure that we really are transforming and protecting the human rights of older persons. So I thank you. Please share my last slide of useful resources for your audience, and it's really been a pleasure to be with you. Thank you.
Dr. Stewart, thank you so much for that extremely interesting presentation. All the best for your efforts to promote amongst the countries of the world a new convention on healthy aging. I myself have worked in Geneva with the Indian mission to the UN on dealing with human rights. I know how difficult and a long journey it is to get countries to agree on a new convention. But all the best for your efforts, and I'm sure you'll be reaching out to the Indian representatives on the Human Rights Council. India plays a very important role as a voice of developing countries in these forums, and I'm sure you would have their support on what you're trying to achieve. All the very best, and once again, welcome to Kerala and to India whenever is the earliest convenience. Thank you.
Thank you.
Friends, we will now have speaking to us Dr. Sally Chaco George, who has done her research in gerontology. Her specialization is on the effects of cultural differences in aging. How are the elderly, or how do societies, Japan, Africa, India, what are the differences in terms of dealing with the aging, or how do the aging discover the whole process depending upon their cultural differences? She strongly advocates understanding humans as they are and concepts such as aging in place, and I'm sure she will tell us more about it. Dr. Sal Chaco.
Thank you, sir. Good evening to everyone. It's a great pleasure to be here at this very moment. being here and now with the unconditional love. That is the motto of ILAGA. What is ILAGA, that you may ask? ILAGA is an initiative to support UN Sustainable Development Goals number 3 and 4. 3 is for well-being and good health, and 4 is for quality education. ILAGA have developed a broad curriculum on geriatric care management, counseling psychology, and self-management. This can be used by geriatric care centers, universities, and differently abled persons or the trainers, and rehabilitation centers. The ultimate aim for this curriculum is to reach to the high potential of a human. That is, through our curriculum, we bring out through counseling, so geriatric care management, or mindful exercises, yoga, dance therapy, music therapy, drama therapy. We also touch grief and loss therapies and making aware of people. All this includes, when it comes to saying about being here and now, what does that mean? As you all know, the world we are in now, it is always multitasking and running around. None of us has the time to sit and think or to do things in a focused way. So let me ask you a question. Who are you? If I ask you, where are you now? Or if I ask you, what is the date today? Or the time? Some of you may be able to tell me immediately, but some may take some time, or they may have to look at their watch or their digital gadgets to think about it, because we are not paying attention nowadays as we are multitasking. Let me play a video just to show how important it is to focus, especially when it comes to therapies and being everyday life, being at home or with the elderly persons. So let's play the video. Can you? Is that possible?
PD has some technical difficulties, ma'am. Can you move to last time? Just move on.
Okay. All right. So the video has some technical difficulties, so we have to move on to the next session. That's what I have been told. Yes, the video was all about the multitasking population, especially when it comes to counseling, or especially when the current situation where the youngsters and the older people, how they deal with the current scenarios. It is very difficult to see that they are focused. It is very difficult for all of us to see that the time has changed from what we believed in. So when we look at UN Decade of Healthy Aging, it emphasizes on people finding their own basic needs and finding their own job. After the retirement, they are encouraging people to find their own job or the second job which they can find out with. So when they have mobility, and if they are able to make friends and keep the friendship going, and also giving out to the society. So these are the things UN Decade of Healthy Aging is emphasizing on. That is the goal they are saying, to combat ageism and also making people to be digital friendly and aging in place. All these issues, all these matters have been addressed. So let me ask you what the meaning of aging, or what is gerontology, or how can you describe the healthy aging? Well, we know the moment we were born into our mother's womb, the aging process starts. We also know gerontology means psychology of aging. And then comes to the explanation of definition of what is healthy aging. For some, healthy aging means living up to 100 years without any physical illness. For some, healthy aging means living in dignity, peaceful life. And for some, it is genetics, and it is cultural factors, or lifestyles, or maybe a luck living healthily aging. According to you, and you just heard Dr. Bharat said, the WHO's definition for healthy aging is, it's a process by developing and maintaining the functional ability in older people which can lead them to age well or healthy aging later in their old age. So that's exactly what ILAGA is saying. The functional ability, being independent, and healthy aging through the exams, through the programs we give them, they all learn to live independently. That is what it is called. In ILAGA, it is all about reaching the high potential through counselings or mindful exercises, yoga, therapy. All this leads to a person's being here and now exercises. So this leads us to the third question I have about aging out of place. We always heard about aging in place, digitalization, making it all friendly. But very often we forget about aging out of place. Cultural differences in aging process is a very important part in human's life. About 60 years of personal experiences and more than 30 years of professional experiences as a psychologist or teacher or a researcher, I have come to the conclusion that inculcated culture in people as an individual has differences. But that culture in them, the belief system in them, if we try to change that, they will get totally confused at the age of 70 or 80 or 90. So that's what we have to look into it now. As the aging globally, with the technology we have come, all of us have come to global aging part of it. We are aware of everything. So what we can do is understand the culture from where they speak. For example, we know when the pandemic happened, people were left at home and many of them couldn't use the technology. As a result, elderly at home, they felt lonely. Didn't they feel out of place? The children, grandchildren, all of them were with the digital gadgets. And here, they're left alone. Some of them prayed at home. Otherwise, they didn't know what to do because Nobody was talking. This is the situation in our families now. Everybody has their own gadgets. Everybody has their own spaces. And the elderly are left alone. And if you ask them to learn, okay, you do WhatsApp. Learn WhatsApp, grandma or grandpa. This we often hear. How much they can do that? As I said, the belief they had for about 60 to 80 years, we are asking them to change that. Is that healthy aging? Or we are making them to age out of place? So I conclude by saying that healthy aging has 3 pillars. One is physical well-being. Second one is mental well-being. Third one is emotional. So if you are physically well, then your immune system, it works well with your aging and you can do it. And if you are mentally fit, the cognitive functioning is fine. And then you can do decision making and not depend on many people for decision making. And the third one automatically leads to emotional being. So final say is being here and now. That should be our aim when we talk about elderly. And when we think about elderly, we have to include them in our decision makings, knowing this fact. So as you have seen on the board, this has come out 2 days back. This is a UNFPA State of World Population Report saying that India has outnumbered China in aging population, in the population itself, not only aging. And India has 7% of 65 plus elder adults, whereas China has 14, and the world, it shows 10. So what does it say? Think about the life expectancy. And now it's a time for us to train our children, grandchildren, to adopt the culture, whatever we have built in, or whatever they are coming across with digitalization. Make them understand, include them. This is all I have to say. Be here and now. Peace.
Thank you, Dr. Sally George, for that very interesting presentation and for highlighting the importance of inclusion of the elderly in all aspects of life and in all activities. It's my pleasure now to invite Ms. Jo Boylan, Chief Executive Officer at Clayton Church Homes, South Australia. Ms. Boylan, thank you so much for very patiently sitting through the session, awaiting your turn to speak. I know it is 10 p.m. in South Australia right now. Thank you for staying awake for so long, and it'll be a pleasure to hear you.
Thank you very much. Can you hear me? Can you hear me? Okay.
Yes, please go ahead.
Oh, fantastic. Well, thank you very much for inviting me to speak today. And to all of the participants that are attending, this is such a very, very important conference. We all live in different parts of the world, but we're all talking about the same problem, whether it's digital technology, pandemic, aging, human rights approach, ageism, and so on. We're all experiencing the same challenges. So I must say to you, I'm very impressed with your commitment to a global learning partnership. This is so, so important. I've travelled the world and looked at lots of different models of care that are provided to our oldest old and our retirement living elderly. And it's just so important to take the best parts of those learnings back to your countries. I'm presenting to you today about implementing a healthy ageing practice. So we've heard from Jane and Cynthia about magnificent policy around healthy ageing, human rights, ageism, how we're eradicating ageism. So all of these topics are so important. So what I'm sharing with you today is how we have implemented a healthy ageing model into residential aged care, into home care, and into retirement living. Now, I've got so many slides, but I won't show you all of the slides because we won't have time. However, I can always share any of my work with anyone. I don't hold anything that I cannot share. So, if you've got my slides up there, yes, thank you, that's wonderful. I will talk to you today. So why are we even talking about healthy ageing? Addressing the fitness gap and the move, and confronting in some ways that we're even talking about healthy ageing in aged care. This is where, when we do progress and promote healthy ageing in aged care, this is when we can really give our elderly the dignity that they need. So the focus is on keeping good function, but also not only physically, but also socially and mentally engaged. So I'll talk to you about designing for prevention and good governance, and but helping invest and develop a growth mindset in our care workers who look after our elderly. Particularly, this is happening in Australia, but even families across the world, whoever's looking after their mums and dads, how we can develop that growth mindset so that we can keep a positive trajectory for our elderly people. And how we can adopt healthy ageing through a multidisciplinary approach, looking at ways to recognise frailty early and put in steps to recover quickly. So you can reverse frailty. We just need to put those steps in very quickly and be very committed. And using recovery pathways to do that. So I'll just start off going through those slides, if that's okay. So if you'd like to go to the next slide. So for the past 20 years, I've practiced and led authentically from a healthy settings approach. I've worked in several aged care organisations, big organisations, designing services and structures and practices to progress healthy ageing. A healthy settings has its roots in the World Health for All strategy laid out in the 1986 Ottawa Charter for Health Promotion. These are very old strategies, but they're still relevant today. These are whole of systems approaches to health promotion and prevention that involve holistic and multidisciplinary methods which integrate across all risk factors for older people. So aged care in this conversation is about Australian residential, home care and retirement living services. Our older Australians are on average around 87 years old across all of our services. This is normal that they're coming to our services quite late, with risk factors that include multiple comorbidities. Now, they used to be around 8, now it's 8 to 15, compounded by frailty, poor function, reduced social engagement, and a lack of access to services that will assist them to regain their functional capacity. So in Australia, we've had a huge amount of reform that has come through following a royal commission into aged care. Unfortunately, though, by and large, our aged care services continue to deliver basic and traditional care. So traditional methods of service delivery include personal assistance, showering, bathing, and so on. This traditional service means that an older person has increased dependency on the service with practices and interventions being done to them rather than a re-enabling way, or with a plan for services to assist the person to regain their functional capacity and to fully recover from a setback. So we are in this cycle where we're building more dependency in our elderly people because of this paternalistic traditional approach. So our aged care settings are not set up with restorative care or with rehabilitation as the initial default response to an older person's presenting needs. Now, probably Cynthia would say this is happening all over the world. So this is our challenge. This is the big, hairy challenge that globally we have to face. And it's one that's not talked about a lot. We give it a little bit of discussion, but we don't fully commit to it. So I'm asking everyone tonight or today to really think about this issue, where it's we know about healthy aging, but we don't always actually do anything about it other than talk about it, particularly for our old or our aging elderly people. So we must do something consistently through healthy aging models, and we must commit, because this is a human rights approach. This is really the right to dignity at the very end of their lives. So in Australia, there is still, if you'd like to go on, oh no, you're on the right slide. There is still a lot of resistance in the aged care sector, and in particular governments, which is not different to many parts of the world, to lead and to move away from or to stop funding traditional medicalised and dependency-inducing service delivery models. So we're still in Australia, after a Royal Commission, still stuck in this model. So my presentation to you is about how we can move away from that. And so I'm going to do that very quickly. So you've now got that fantastic slide up that everyone can see. And we could really talk about this for 30 minutes, just this slide. So what happens in Australia is a lot of our aged population, and particularly now even in retirement living, are coming in admitted into our services on the purple-pink trajectory line, which is they're already starting to move below the disability threshold. So they're moving towards disability. Now, we start providing services in Australia, and often they're services that take away from their independence rather than giving them independence, and so they become more disabled. So in most of our services, I put gyms into all of my residential homes. I've now put in about 30 gyms across all of the services that I've led. So put gyms in to really work hard on people's function, which is also very social as well. It's a very social thing to go to the gym, so that I can push them back up to that green line and good nutrition. So they are the two evidence-based strategies to address preventable decline and frailty. So this is a Kalache and Kickbush slide where they've really provided that really good visual understanding of below the disability threshold and pushing up, looking at that fitness gap to push the person back up to above the disability threshold. Now, once you go above, you still may need assistance to in everyday life, but certainly you can still have dignity to do most of your the things that are important to you. So if I can go to that next slide. So this means that we have to have a significant drive, keep going through it, yes, towards preventing frailty, and then addressing and reversing frailty very quickly. To do that, you really do need that multidisciplinary team, and you need to educate staff to understand how to detect it very quickly and to address it very, very quickly. And if you can go to that next slide. Before we can do too much though, and this is what I found particularly in Australia, we need to really, to get the paradigm shift really working well and everyone understanding that we all have one goal, is to keep the people that we care for and provide services for functionally able-bodied. So everyone has this goal. We all know that. But often I have to really address ageism. It's quite rife in our care workers and in healthcare. And when you've got that pervasive behaviour, you have to really sit down and break it down. And once we do that, we can start to look at the outcomes and show people what the benefit of what they can do. So this, when we understand this bias, aged care settings and hospitals can set up restorative care and rehabilitation as the initial default response to an ageing person's needs, rather than a special thing. It should be normalised. Today we're going to learn 3 words: make healthy normal. So we've made it special, but we're going to make it normal. But to do that, we have to stop ageism. So if you can go to that next slide. When we're providing aged care services like residential, home care, retirement living, we do need to have really good governance. All of this needs, very good leadership, partnerships, and so on. So this is quite fundamental to everything. But sometimes nurses will just hang their hat on good governance. So we have to really make sure that the whole goal of keep top of mind. Next slide. And I've just spoke to you also about investing and developing a growth mindset in our workforce. So if you'd like to go to that next slide. That's lovely. So particularly in residential aged care, the nursing hierarchy and the nursing system is very fixed mindset. It loves routines, tasks, everyone sitting down, everyone neat and tidy and so on. But it's actually this growth mindset that we need, where we need to change that strategy and embrace that the goal is about the person. We must meet that person's goals to enable them to do the things that they value. It's very hard to do the things that you value sitting in a wheelchair or in a device where you're relying on someone else to help you get there. So if you move to the next slide. So how I've used a lot of this technique is I've got 4 stages into implementing a healthy ageing model, and I'm just explaining some of it in these slides, but certainly addressing ageism and our attitude to what the barriers are to promoting and progressing healthy ageing is key. But also having that healthy ageing multidisciplinary task force. So having a group of people that are constantly looking at those people who are not progressing forward, who are starting to decline, who have had an adverse event, who have had a setback, so that you can push them back up above that disability threshold. This is quite fundamental, and that is the responsibility, I believe, of the people that are supporting these services. So this multidisciplinary approach has to act really quickly because frailty can set in and become established very quickly. So we have to act quickly and we have to review people very quickly. So if I can get you to move on the slide. And decline of frailty early. There's a whole number of things that we must do, but they need to be all done. We can't just do one little part. We can't take a soft approach and just do little bits. We have to do the whole part to commit to preventing that preventable decline. I'll get you to move on. One of the things that I've done in this model is actually develop a 12-week program, and it helps the person recover. Some people have really good muscle memory and have been really strongly functional, and they can recover after 5 weeks. So we have a pathway. Everyone contributes to this pathway to keep the person walking. Most of the exercise is strength-based, and I'll get you to go to the next slide. Keep going, and on to the next one. Terrific. And we get the staff to really find those issues very, very quickly. So the recovery program has got a rehabilitative focus. And it does require 3 to 4 more intensive sessions per week, but also every day up to 4 to 6 interventions for walking in particular, or some level of exercise. But care workers can do all of this. Can be supervised by more other. It's one of the ways that I've done it, and people are very weird that a 95-year-old is wanting to go to the gym and has never been to the gym. And people from all different cultures. Australia is full of a beautiful melting pot of many, many, many cultures, and certainly people do understand the benefit of making sure that they stay strong. So these recovery pathways, they go through a 12-week program and then they go on to a maintenance program. And we make sure that the exercises are progressive so that they just don't do walking and they don't just do 1 kilo weights, that everything is progressive to the point where they're actually then holding a 10 kilo weight. So very important that that happens. There's and on to the next slide, I've put the recovery pathway in there, and the next slide is about the Sunbeam project, which is a fantastic exercise program for retirement living people, really based on someone who is more independent and standing, and this is perfect for that age group. I'll go on to the next slide. It's very important to constantly meet up with the Healthy Aging Task Force to work out what's working, what's not working, because you can't keep doing the same thing if it's not working. You have to constantly revise and tailor to what's important to that person. I generally find out what's important to them, and that becomes the goal. If you can move on to the next slide. So just making sure that every activity that they engage, that the person engages in, is as active as possible. Sometimes the 15 minutes might be the longest someone is active for the day, and which is a tragedy. So if we can break that barrier down where the long sitting and sedentary behaviour is changed, even, your whole model of care does need to change. And the next slide. I think there was one picture just before that. Oh, there we are. So this is a new activity that we're doing in aged care called Drum Fit. And you can do it again, it's a global activity to any cultural music, anything. And it is just really taking off. So anyone can do it. And there's so much enjoyment that can be had. So if I can just go to that the healthy aging measures. So anytime you put any activities in place, make sure, or changing your model of care, make sure you start to measure those things that are important, such as reducing falls, reducing the immobility, and ensuring that people are engaged in meaningful activities. So I'll finish off there, and happy to take any questions.
Thank you very much, Ms. Boylan. It was most interesting for us to hear about your innovative and growth-focused alternate service delivery. It is also interesting to know that even in Australia, there is no one answer, and many different approaches are being tried to address the challenge of healthy aging. Thank you so much for joining us at this late time in the evening in South Australia.
You're welcome.
Ladies and gentlemen, we now have with us Dr. Chandana Unnithan, who is the Chief Scientific Officer of Lifeguard Digital Health, which has a stall here, and Professor of Digital Health at Torrens University, Australia. She is also a member of many UN committees, including the UN Committee on Peaceful Uses of Outer Space. She will talk to us today about technology and aging. Please, Dr. Unnithan.
Thank you. Good evening, everyone. Thank you for all present here. Particularly to begin with, thanks to Bliss Homes and my partners, Lifeguard Digital Health, and everyone who has been so patiently waiting until now. My role today is to present some of the perspectives in evolving uses of technology in senior care from the space science and from UN Agenda 2021 to 2030. This is particularly from the perspective of the United Nations Committee on Peaceful Uses of Outer Space, Technologies, Science and Technical Subcommittee. So just a brief on the Committee on Peaceful Uses of Outer Space. It was set up by the UN General Assembly to exclusively deal with international cooperation in the peaceful uses of space science and space-derived technologies. Example, remote sensing, geographic positioning systems, for use in sustainable public global health. So the Space and Global Health Group is an expert group that focuses on improved use of space-derived technologies and information or data for promoting global health. Some of the examples under this agenda is assisting in disaster relief by using satellite imagery to plot disease transmission and planning relief missions in war zones, translation of technologies that assist astronauts to improve health on Earth. Some of these translate directly to senior care. Another example, drones being used for delivery of medication where humans cannot reach in the pandemic long-term facilities. So how does space science translate to senior care? As the pandemic death toll increased, loss of loved ones increased, social distancing restrictions occurred, placing limitations to healthcare access, resulting in growing mental health concerns, particularly for seniors. The space sector has had considerable experience in managing astronaut self-isolation and confinement into small spaces for long periods, and contributes substantially to global dialogue on managing stresses and self-isolation. This experience translates to senior care and long-term planning, particularly in long-term care facilities. So telemedicine, as we all know, has become a very interesting area in senior care. It has served an essential role in the mitigation of COVID-19 in providing medical care and exploring options for remote monitoring of patients with active COVID or long COVID. With the space sector that has been in the forefront in the development of telemedicine to provide care to and ongoing monitoring of astronauts, satellite space communication enhances telemedicine and expands the healthcare possibilities that are being offered in senior care. This is an example of a biomonitor that offers continuous monitoring of heart rate, breathing, blood pressure, temperature, ECGs, physical activity, and blood oxygen levels, which was developed some time back by the Canadian Space Agency. So moving on from there, where we are now in the digital health landscape in the same agenda, connected healthcare is all about collaborative environments to accelerate adoption of innovative digital services and technologies, which is also the UN mandate. A key component of this strategy is harnessing digital information to make informed decisions by providers and consumers, infrastructure that can be safely accessed, easily used, and responsibly shared enables the best outcomes in digital health. So space-derived technologies and health data provision in secure manner underpin these digital health services and sustainable senior care. So going from a flip side, the UN Decade of Healthy Aging Plan of Action 2021 to 2030, I'm putting forth three sections that are relevant in this area of senior care in combating ageism. 3.2 talks about ensuring communities that foster abilities of older people, focusing on removal of physical and social barriers, implementing policies, systems, services, products, and technologies in particular to promote health and maintain physical and mental capacity throughout their life course, and to enable people, even when they lose capacity, to continue to do things they value the most. 3.4 talks about long-term care for older people who need it wherever and whenever they need it. Significant declines in physical and mental capacity can limit an older person's ability to care for themselves and to participate in society. Access to rehabilitation, assistive technologies, and supportive, inclusive environments can improve the situation, and there is a need for non-intrusive care using technology. People do reach a point in their lives when they can no longer care for themselves without support and assistance. So access to good quality long-term care is essential for such people to maintain their functional ability, enjoy basic human rights, and live longer lives with dignity. 4.3 talks about connecting diverse stakeholders around the world to share and learn from the experience of others. There is no single discipline, perspective, or method to achieve the goals of healthy aging. Collaboration among interdisciplinary research networks, including seniors and researchers, are necessary. Science, technology, social, and business innovations must be integrated to find the best ideas that respond to policy and practice challenges. So in bringing it all together, some of the perspectives for calling to action: age, as the UN thinks about this, is age is just a number. Every year is a celebration of life and what it offers. Technology, consider it a virtual friend, no longer a high maintenance friend, which means the costs in technology are reducing considerably. It is there, wherever you are, seamless, supportive, and simplified. So embrace the technologies for healthy aging. Thank you. I would like to leave you with this. Thank you.
Thank you so much, Dr. Nithan, especially for the last message to embrace technologies. And it's wonderful to know that even an esoteric field like space science can have a direct relevance and connection to healthy aging. Ladies and gentlemen, we are about an hour and 15 minutes behind schedule. I do not know if there's any time for question and answers. Should we? Okay, if there are any questions, we can answer one or two. I see some of our online panelists are still there.
Do we have any questions for the panel? Looks like everybody is waiting for a 101 to ask their questions.
Permit me to thank all the panelists for the excellent interventions made by them. I do not proceed to a lengthy summing up. It is very obvious that we in India have much to learn from the world, but equally important, we also can give to the world. The Indian professionals across the world have done an outstanding job wherever they are. We have the best of doctors, best of healthcare professionals, scientists. Our R&D capabilities are amongst the best in the world. And healthy aging is a task to which India can dedicate ourselves. For India, we are still a young country. We have some time to look at the world, see what happens in the world, and learn from them on how to address the challenge of healthy aging. But as far as Kerala is concerned, we are the most rapidly aging society in the country. We need to address this challenge with a sense of urgency. I know tomorrow both the Law and Industries Minister as well as the Leader of Opposition of the state are going to be here. It's a wonderful opportunity for the organizers to place this issue before them. And let us hope that this conclave is only the first of many such events which enable us to put healthy aging on the top of the state and let's hope this is the first of many such events which will help put healthy aging on the top of the agenda for both our state as well as our country. I once again conclude congratulating Bliss for having taken this wonderful initiative and thanking them for having brought all of us together. Have a great evening, ladies and gentlemen.
Thank you so much, sir, for your kind words. And I would like to once again thank Dr. Sal, Dr. Cynthia, Dr. Jane, Dr. Chandana, Ms. Jo, and of course, Venu sir for so beautifully handling the entire panel. I would like to call on stage Sri Kumar sir from Asli to please hand over the mementos to all the panelists. He went for a meeting. All right. I would like to call on stage Gigi ma'am from Travancore Foundation to please hand over the mementos. Gigi sir, sorry. Sure.
Thank you to all the panelists for your time, and thank you for sharing your wisdom with us. Now, we have, of course, we have culturals and a few other things planned for you, but so I'm giving all of you a quick break to move yourself a little bit. Stalls juice ready. Please do go exchange a few thoughts with each other of everything that you've heard, and I'll see you back in a bit.
The watch will auto-detect the fall, and the admin desk will receive the alert. so they can respond immediately. Intellicare has geofence alerts. If a resident leaves the facility premises, the staff will be alerted with the location of the resident and can communicate with the resident. Intellicare can monitor residents' vital signs. When a wearable device is worn by the resident, it monitors their vital signs and will report to the staff, so they can check on resident vitals anytime from the admin tablet. Staff and residents can message each other. Staff can message residents with important information. And residents can give feedback to staff. Finally, staff and residents can communicate with voice and video calls. Staff can call residents on their tablet in their room or on their wearable. In the event of an emergency, residents can call staff directly from the wearable at any time. Life-saving alerts for senior facilities. Intellicare powered by Lifeguard Digital Health Inc.
Autumn years in a person's life are equally to be cherished. Quite often, the hand that rocked the cradle is left clueless about how to live the rest of their lives. The reason may vary: the kin settling abroad, nuclear family preferences, or wanting personal space for them. These reasons contributed in the setting up of Atulya, a premium independent assisted living for the elderly. Based on the concept of harmonious community living, Atulya provides customized assisted living to its members. The homes are ergonomically designed, keeping in mind the needs of the elderly. Right from the carpet to the ceiling, the interior design has been crafted after conducting a thorough research on assisted living trends that are popular worldwide. The floors at Atulya are non-slippery. The state-of-the-art adjustable beds provide optimum comfort. Railings are provided wherever required, as we understand that even minor injuries may cause serious health complications. Emergency call buttons provided near the bedside ensures that precious time is not wasted in case of any medical emergency. Some of the unique features include round-the-clock medical care, providing healthy food options curated by dietitians. In addition, we at Atulya also provide rental ownership, where a person gets to choose his or her duration of stay. Atulya provides internet and video conferencing facilities to connect with their loved ones. Atulya is centrally located and one has easy access to the best hospitals and healthcare services which are at close proximity. We at Atulya ensure a cheerful and dignified living for the elderly by redefining the living standards and enhancing the quality of life.
രോഗത്തിനുള്ള പ്രതിവിധി തേടുന്നതിനേക്കാൾ നല്ലത് രോഗത്തെ പ്രതിരോധിക്കലാണ്. ചെറിയ അസുഖങ്ങൾക്ക് പോലും ഇന്ന് നാം ആശ്രയിക്കുന്ന മരുന്നുകളുടെ പാർശ്വഫലം എത്ര വലുതാണെന്ന് പലരും ഓർക്കാറില്ല. ഇവിടെയാണ് ബയോമാഗ്നറ്റിക് തെറാപ്പി ശ്രദ്ധേയമാകുന്നത്. ബയോമാഗ്നറ്റിക് പ്രോഡക്റ്റുകൾ ഉപയോഗിച്ചുകൊണ്ട് വരാനിരിക്കുന്ന ജീവിതശൈലി രോഗങ്ങളെ പ്രതിരോധിക്കുവാനും നിലവിലുള്ള രോഗങ്ങൾക്ക് പരിഹാരം കണ്ടെത്താനും സാധിക്കുന്നു. ഇൻഫ്ലുവൻസിയ ബയോമാഗ്നറ്റിക് മാട്രസ് പാഡ്, പില്ലോ പാഡ്, റിസ്റ്റ് ബാൻഡ്, വാട്ടർ ബോട്ടിൽ പാഡ്, റിലാക്സിംഗ് പാഡ്, ഇത്തരം ബയോമാഗ്നറ്റിക് പ്രോഡക്റ്റുകൾ എങ്ങനെ നമ്മുടെ ശരീരത്തിൽ പ്രവർത്തിക്കുന്നു എന്ന് നോക്കാം. മനുഷ്യ ശരീരത്തിലെ 99% രോഗങ്ങൾക്കും പ്രധാന കാരണം ശരിയായ രീതിയിലുള്ള ബ്ലഡ് സർക്കുലേഷൻ അഥവാ രക്തചംക്രമണം നടക്കാത്തതാണ്. ശരീരത്തിലെ സെല്ലുകൾക്ക് ആവശ്യമായ ന്യൂട്രിയൻസും ഓക്സിജനും എത്തിച്ചു നൽകുന്ന ജീവനുള്ള ടിഷ്യൂ ആണ് രക്തം. രക്തത്തിലെ ഹീമോഗ്ലോബിനിലെ പ്രധാന ഘടകമാണ് അയൺ. നാനോ ടെക്നോളജി ഉപയോഗിച്ച് മെഡിക്കൽ ഗ്രേഡ് മാഗ്നറ്റുകൾ സയന്റിഫിക്കലി സെറ്റ് ചെയ്തിരിക്കുന്ന ഇൻഫ്ലുവൻസിയ ബയോമാഗ്നറ്റിക് മാട്രസ് പാഡ് ഉപയോഗിക്കുമ്പോൾ ഇതിലുള്ള മാഗ്നറ്റുകൾ ശരീരത്തിലെ ബ്ലഡിലെ അയണുമായി ആകർഷിക്കുകയും സജാതീയ വിജാതീയ ധ്രുവങ്ങളിൽ ഒരു പുഷ് ആൻഡ് പുൾ പ്രവർത്തനം നടക്കുകയും ഇന്നാക്റ്റീവായ ബ്ലഡ് സെല്ലുകളെ ഡീക്ലസ്റ്റർ ചെയ്ത് ചലനശേഷി ഉണ്ടാക്കി ആക്റ്റീവാക്കി മാറ്റുന്നു. ഈ സെല്ലുകൾ ഹാർട്ട് ബ്ലഡ് പമ്പ് ചെയ്യുന്നതോടെ ഓരോ മൈക്രോ കാപ്പിലറുകളിലൂടെയും സഞ്ചരിച്ച്.
I hope everybody got hold of a juice or something to drink, because we are going to go ahead with the evening. പുറത്ത് നിൽക്കുന്ന എല്ലാവരോടും വോളണ്ടിയേഴ്സ് ഒന്ന് റിക്വസ്റ്റ് ചെയ്യുക പതുക്കെ അകത്തോട്ട് കയറാനായിട്ട്. So before we move on to the culturals, we have quickly 3 papers that the students are going to present to us. Students in their perspectives are always important when it comes to growth, because I don't think I have to say this, they are the future. So we have 3 papers that are going to be presented here today, which was selected as part of a competition which was held by Blessed Homes. So ആദ്യം ഞാൻ പേപ്പർ പ്രസൻറ്റ് ചെയ്യാനായിട്ട് I would like to welcome on stage the students of Rajagiri College. To represent the group, I have Alfie, who is going to come on stage to talk about psychosocial well-being of senior citizens in Pagalvida, a study from Calicut district in Kerala. These are students and they need your support, so whoever is inside the hall, please give them a good round of applause.
Namaste to one and all. Yep. Can you please settle fast? Yeah, I would like to start my paper presentation. And the topic is Psychosocial Well-being of Senior Citizens in Pagalvidu, a study from Calicut district in Kerala. And this topic comes under the theme of this conclave, that is community living and quality enhancement in elderly. As we all know that in their younger ages or in their youthful ages, elderly population will be the people who have contributed significantly towards the development of the community. So, Pagalvidu is a very famous theme introduced by Kerala government in 2003, and this really contribute to the quality enhancement of the elderly population's lives. And there are 3 authors for our papers. First author is Adrajit, second is me, Alfie, and the third one, our guide, Father Joseph MK, HOD of Social Work Department of Rajagiri College of Social Sciences, and we represent Rajagiri College of Social Sciences. Coming to this introduction, we all know that Pagalvidu can be translated as Pagal and Vidu, day, home, which is used for taking care of elderly population with great safety and protection. Over here, they are given ample security and socialization. This Pagalvidu is nowadays spreading all over Kerala. And The primary objective is to enhance the quality of life for the elderly in the community by providing them with a space where they can connect with others, engage in meaningful activities, and get the necessary assistance. And we all know that there are many kinds of services provided from Pagalveedu, such as medicinal assistances, nutritional assistances, and so on. And psychosocial well-being. The psychosocial aspects include all those factors of emotional, social, and cognitive dimensions, which is very important for well-being of a person. And all these three factors comes under psychosocial development, and the same thing is measured by us. So then moving on to the methodology part of our research, we would like to say that this research was conducted among the citizens of Olavanna Panchayat of Kozhikode, where we can see that 71 participants aging between 60 to 80 were our target group. And from that, we have selected the population who are regularly going to Pagalveedu and who are very active in the same. And the research design is quantitative descriptive. And we have used Riff's psychological well-being scale, which contains 18 items, and it defines or it measures this psychosocial well-being or psychological well-being of this population from 6 main dimensions. They are autonomy, environmental mastery, personal growth, positive relations, purpose in life, and self-acceptance. Coming to the results of our study, I would like to start with the socio-demographic profile of the elderly at Pagalveedu. The age of these respondents ranges from 71 and 75. The majority of the respondents are from this age group. Then the gender, coming to the aspect of gender, we can see that the male representation was slightly higher than that of the female. Then religious affiliation. In Kerala, we are very particular about this religious affiliation. So majority of the respondents have told that they are from Hindu background, followed by Muslim and then Christians. Then about the education, most of them have completed 5th standard of educational qualification. Then employment status, as we know that all those elderly population are unemployed. Then family size, mostly our respondents are from nuclear families, ranges from 1 to 5 members constituting their family. Then the children, number of children for the respondents ranges, that majority of this respondents have 2 children followed by 3. Then the usage of scale. As I've told earlier, we have 6 dimensions from which we have made all these measurements. First dimension is respondents' level of autonomy. And this is the pictorial representation of what we have found. We saw that it is level of autonomy. Autonomy is in case of taking decisions for themselves, in that only one have told, out of 71 participants, only one have told that I have very low level of autonomy. And rest 64, that is, they told that they are having autonomy of medium range. Only 10 have told that we are having high level of autonomy. Coming to the second aspect, respondents' level of environmental mastery, how well they can cope up with this environmental changes and so on. We can see that only 12 people told that they are not at all having environmental mastery, or their environmental mastery is too low. But majority have told that it is medium. That is 59 have told it is medium, and none have told that they are having high level of environmental mastery. Coming to the next dimension, that is respondents' level of personal growth, we can see that 2 persons have told that they are having high level of personal growth, but majority have told they are having medium, followed by low level. That is 24 have told, out of 71 respondents, 24 have told they are having very low level of personal growth. Then respondents' positive relationship. We know that positive relationship with this environment is very important so that we lead a healthy life. So positive relationship with the environment, we can see that majority have a medium level of positive relationship, followed by high level. That is 5 have told they have high level and 3 have told they are facing very low level of positive relationship. The next dimension, respondents' level of purpose in life. Most of the respondents have told that they have very low level of purpose in life. That is 37 out of 71. Then 33 have told medium. And only 1 have told that he or she really feel like they are having a purpose in life. Then last dimension, respondents' level of self-acceptance. If we are not in a position to accept ourselves, it will be very difficult for us to live, right? There is not even a single person who have told that I have a high level of acceptance on myself. It was 56 people who have told they are having a medium level of acceptance and 15 told that they are having low level of acceptance. And coming to the overall score of this psychological well-being using this RIFS well-being scale, we can see that we have to add up all those 6 dimensions. And the final result is respondents' level of psychological well-being. As we have seen that for most of those factors, it was low or medium. So that really replicates in the final result too. 14 have told that they're having very low level of psychological well-being and 56 told that they're having medium levels. So as we are social workers, we should talk about this social work implications. Coming to this, we put forward the suggestion that development practice models should be designed so that we can have customized plan for each and every location depending on the needs of development in Pagalveedu. Then more and more social policies should come forward. And the next one is outreach and engagement. Outreach and engagement can be done by each and every person present here, not only the social workers. So as part of our study, we have been to these old age homes and we have engaged them. So they were feeling good out of all those activities. Then collaboration with healthcare professionals. Not only the healthcare professionals, we can have collaborations with different professionals of different fields so that we can make life better for this elderly population. Next, research and evaluation. Such kinds of conclaves, research and evaluations should take place so that this area will get expansion and more innovative methods can come forward. Next one is trauma-informed care. We suggest that trauma-informed care should be given to elderly population. We should understand that all those delegate feelings and emotions that we express towards them really affects them badly or in a good way in their neurological process. Then we should always understand that there is a need for funding in the development of elderly population, so advocacy for that. And the final one is empowerment and self-determination. We don't really want to do all those things possible for them. We are nobody to do all those things for them. They are having certain capacities to fulfill their own needs, so we should encourage them to do the same. Then the conclusion of our study is that there is need for introducing some policies and programs for them so that they'll be having a better life. So that's all. Thank you. These are our references. Thank you for listening.
Thank you, Alfie, for the lovely paper that you presented. So I would like to call upon the next paper that's going to be presented. For that, I invite Janet onto the stage. And the topic that she's going to be talking about is exploring the linkages between behavioral pathology, cognitive status, and false risk in the elderly. So can I have Janet on stage? And also, just before she starts with her paper presentation, I would like to request all those who are there in the stalls to please also join the audience, because we just have 2 more paper presentations and we're going to move on to the culturals. So can I please request you to also join into the audience? Thank you.
Good evening, everyone. As introduced, I'm Janet Biji. I'm an MSW student specializing in medical and psychiatry from Rajagiri College of Social Sciences. So glad to be part of International Conclave on Healthy Aging. And I'll be presenting my paper, which is titled Exploring the Linkages Between Behavioral Pathology, Cognitive Status and False Risk in the Elderly, Implications for Prevention and Intervention. So this is the paper which is based on my dissertation, postgraduate dissertation. It was done under the supervision of my guide, Dr. Father Saju, MD, Associate Professor at Rajagiri College of Social Sciences. We'll be dealing with these contents from the paper. So let's start by speaking a little bit about the background of this study. As we are discussing throughout this conclave, aging has a lot of factors associated with it. Let it be physical, emotional, psychological, familial, environmental factors. There are so many factors associated with aging. So in this particular study, let's start from false risk. So we can say that when we consider elderly population, false risk can be considered as one of the greatest public health concerns, because the number of elderly being affected by falls, let it be injuries or even loss of life, is very huge. So there is a need there are so many interventions happening, and there are more studies required in this area. So along with false risk, there are two other major components we'll be discussing in this study, which are behavioral pathology and cognitive status. So just to introduce behavioral pathology, most of you might be familiar. This is a term which we usually associate with Alzheimer's, dementia, and all the other categories of dementia. So here, in this study, we actually have this assumption that it's not only in a person who has been diagnosed with dementia, even in the general population, general elderly population, there can be behavioral pathologies or behavioral deficits that develop as part of their normal aging. So in this particular study, we have this assumption, and this is a very important area to be given attention to, because when a person elderly presents some behavioral problems, it is a concern when it comes to caregiving. They can actually confuse that with the personality of the person, and caregiving can get affected. But it is to be educated that this can be a part of their process of aging, and it is to be acknowledged by that way. And cognitive status, of course, as age progresses, cognition is being affected, and that can lead to further issues. So in this study, these are the three components that I've focused on, and these are the components that we have assessed in the population. So the objectives of the study are basically the first one, to study the behavior, socio-demographic profile of the respondents, and then the other three are seeing the association between all the three components that we discussed in the previous slide. So just running quick through the methodology, the design was cross-sectional, it was quantitative, and the population included the community dwelling elderly who are above the age of 60, and the sampling was multi-level proportionate sampling with a sampling size of 60. The research tool included 3 scales. The mini mental state examination was used to measure the cognition. Then behavioral pathology and Alzheimer's disease frequency weighted scale, which was used to measure the behavioral pathology of the samples, and false risk assessment tool was used to measure false risk. Data collection was done through door-to-door surveys. I used the SPSS software, descriptive statistics, ANOVA, and Pearson correlation tests to analyze the data, and pre-test was also done. Coming to the results, these are just the consolidation of the demographic details. Some of them, most of them were females. They had below 10th grade of education. Most of them had been self-employed in their past. So we'll run through that. And coming to the consolidation of the age, the mean age was almost 77, annual income over 9,000, 97,000 on a mean. This is the family income, just to show you what was the demographic condition. Then the mini mental state examination score was on average 21. When it comes to behavioral pathology, 11, and false risk 2 out of 5. Okay, and now this was the behavioral pathologies these are the behavioral pathologies that we studied using the BehaveAD scale. So we discussed in the previous sessions, the biological and psychological symptoms of dementia. Similar to that, this is another classification. The scale actually included 25 questions which were classified under these categories. So when we look at the mean scores, this is the frequency intensity product that is being consolidated here. So we can see that the most frequent, most intense pathology was aggressiveness, and then it was followed by anxieties and phobias, and then diurnal disturbances, and then the psychotic symptoms, paranoid delusional ideation and hallucinations. So now one of the results, another major result was seeing the association between cognitive status and behavioral pathology. So here we can see that among all these behavioral pathologies, 3 of them showed significant correlation. Those 3 were paranoid delusional ideation, hallucinations, and activity disturbances. So psychotic symptoms are seen to be associated with cognitive status and activity disturbances also. Now the next set of results was the relationship between false risk and behavioral pathology. So here we can see that there are again 3 pathologies are found to be correlated to false risk. So those are aggressiveness, diurnal disturbances, and affective disturbances. So this means that those samples who showed increased symptoms of aggressiveness had a greater risk of false. False risk was measured using another tool. So we found the correlation between false risk and these behavioral symptoms. So diurnal disturbances, they had disturbances in sleep, day-night confusions and so on. So, and when it comes to affective disturbances, these are depressive symptoms, senses of feeling worthless, hopeless, and so on. So this is the meaning we derive from these findings. All the samples who showed these behavioral pathologies had a higher risk of false too. So we found a correlation there. Now, in order to discuss, the last 2 set of results are focused in this particular paper. So the first set of results was the relationship between cognition, MMSE results, and behavioral pathology. So we made this suggestion that we can reduce the severity and frequency of pathological behaviors by strengthening cognition. So the methods to strengthen cognition are already being studied, and there are tools like some of them listed here: cognitive stimulation, puzzles, games and reading exercises, memory training and physical exercises. Now coming to reducing the false risk by regulating behavioral pathology. We saw that 3 of the behavioral pathologies were correlated to false risks. So we are suggesting that by regulating the behavioral pathology through some non-pharmacological methods, let us try to reduce the false risk. These are so we thought of some of the suggestions: psychotherapy and behavioral interventions for those people who have behavioral issues, like the ones we mentioned were aggressiveness, diurnal disturbances, and affective disturbances. And then social support is very important, and here comes the importance of family and the caregivers, whoever is associated with the elderly. They must be able to support the elderly in a very effective manner by understanding what is their actual condition and giving them what they need. I mean, supporting them in the right sense. And then elderly groups are found to be very effective by different studies. just like the previous presenter spoke about the psychological well-being of elderly in Pagalveedu. So elderly groups, the elderly find the atmosphere to correlate to people and move back to the interactive life they had before. For those who had an interactive life before, this would be a very effective way to have an active aging component there. And then medication, as even the doctors from Sunrise Hospital had talked about, there are medications available to control behavioral symptoms. And also, in addition, let me relate to what they have said. There are reminiscence therapies can be given and other non-pharmacological interventions that can help in reducing the BPSD, as they said. In this case, the pathological behaviors. So by these results, we mean to move towards healthy aging and support them in whatever way we can. So this is the end of my presentation. I would like to thank Bliss Retirement Home and the entire team of International Conclave on Healthy Aging for giving the opportunity, and also including the student community, especially since we are almost about to complete a formal education and move into our careers. This is a very good opportunity to opening the horizons of career before, practical discussions, deliberations, and so happy and glad to be part of this. Thank you.
Thank you, Janet, for the lovely presentation. And for the last paper presentation, I would like to call on stage Jitti KJ. The students are from Model Engineering College, and they are presenting on the topic Assistive Device for Alzheimer's Patients. The previous two papers were MSW students, and these are engineering students. So the stage is all yours.
Good evening to all. First of all, I thank the respective authority for giving us such a wonderful opportunity. We are final year electronics and biomedical engineering students from Government Model Engineering College, Thrikakara, and myself, Jitti KJ, and my team members are also here, and they are Aparna R, Nia Nelson, and Srishma. And our project is on the topic Assistive Device for Alzheimer's Patients. And our project is being coordinated by Dr. Jesse John, HOD of our department, Department of Biomedical Engineering, and Ms. Shruti, and guided by Soumya C. Ramanan. So we all know that what this Alzheimer's is. It's a progressive neurological disorder and which causes issues in memory and malfunctioning of brain. For a patient having such kind of condition, either the brain cells or the connection between these brain cells will be degenerated and dies, resulting in memory functioning problems and many other mental malfunctioning. And age is one of the biggest factor because patients are more from the age of 60 and above. About 8.8 million people in India suffer from this challenging situation. And most of the problems faced by these kind of people include problem in remembering, then sometimes they will wander here and there and they will get lost their way, and difficulty in doing their day-to-day activities, and difficulty in recognizing their beloved ones. So depending on the severity of these problems, mainly there are three. So depending on the severity of these problems, mainly there are 3 stages of Alzheimer's, that is mild, moderate, and severe. And our product mainly aims on those people or those patients who is at the mild and moderate stage of Alzheimer's. And it will improve the quality of life of Alzheimer's patients as well as their caregivers. So in order to attain these goals, our product mainly aims to have the following outcomes. That means In order to provide a day-to-day activity reminder, we have incorporated such a system into our project. And the second feature included is a face recognition system. And by using this face recognition system, patient can recognize their beloved ones. And the next feature that we have incorporated is an indoor location tracking system, by using which the caregiver can locate the patient's location within the home, and whenever they have gone out of the home unknowingly, notification will be sent to the caregiver's app so that they can take immediate response. And these are the main 3 features that we are focusing. And all these features have been incorporated there inside a jacket. So our final product will be in the form of a jacket. And that will be enclosed by using a lock system, which can be controlled only by the caregiver. Because there is a chance for such patients to remove their jackets unknowingly. And in addition to that, we have also incorporated another feature, that is an automatic medicine dispenser. By using which, whenever the notification for medicine have arrived, then this medicine dispenser will automatically open, so that the patient at mild stage can go and take their medicine even without the help of a second person. And coming to more details of our project, here we have used ESP8266 as the processor, just because it is having an inbuilt Wi-Fi module in it, so that it can be connected to the caretaker's app. And a power supply is being provided using lithium-ion battery. Then the first feature, that is an RFID, by using which the location tracking can be done. So here an RFID reader and a tag will be there, so that the reader will be placed inside the jacket of the patient, and the tag will be placed in those areas like the gates, doors, and whenever the patient crosses these areas, the reader will read the tag. At that time, a notification will be sent to the caregiver's mobile app, so that he can track the location of the patient. And the next feature is a day-to-day activity reminder. For that, we have used a DF mini player, in which the commands like it's time for food, it's time for taking medicine, it's time to go to washroom, such kind of reminders for reminding the patient to do their daily activities will be stored inside an SD card, and this SD card will be stored inside this DF mini player. And the caretaker can schedule the time for playing these audios. And whenever the stipulated time arrives, what happens is that the corresponding audios will be fetched from this DF mini player, and speaker out will be come, so that they can have a track on it. At the same, through the same way, a music therapy can also be implemented using the same system. And as I have mentioned earlier, a lock system is also incorporated by using a driver, and all these features can be controlled by the caretaker, and that is one of the main peculiarity. And coming to the block diagram of an automatic medicine dispenser, it's also being done by using ESP8266, and power supplies also being provided. And here also what is happening is that a dispenser, a medicine dispenser will be there. Its lid can be closed and opened with the help of a servo motor. And this servo motor's lid can be opened and closed by using, this servo motor rotates. Its rotation can be controlled by the mobile app. That means whenever the notification for medicine have arrived from the day-to-day activity reminder, the servo motor will start rotating, and it will open the lid of this dispenser. And after a stipulated time, it will closes automatically. And the next feature which we have implemented is face recognition system, in which the first part have only been completed, and remaining will be completed soon, since our project will get completed only by the end of June. So we have done the camera module activation. In order to do this camera module activation, the ESP32 cam will be connected to the system by using a TTL converter, and when the data is flashed, an IP address will be attained, and by browsing these IP address, we will get a tab. A tab will be opened, and in that tab, the complete settings of the camera can be done. And its future, that means up to this we have done, and in future we have to done the recognizing part. For that, machine learning algorithm is there in which the faces, the pictures of the loved ones, the close relatives and the friends will be stored in this machine learning model. And whenever a person comes in front of the patient, and that will be taken, his picture will be taken by the camera. At the same time, the facial features will also be extracted and will be compare that facial features with those which have already stored in the system. And if it matches, then speaker out will become pronouncing the name and the relationship of that person with the patient. And this is what our project is. So we all know that by implementing such kind of assistive devices, we are not only helping to improve the quality of patients and their caregivers, but also we are improving the safety, the well-being, and providing hope and independence to both caregivers as well as the patients. And together we can make a positive impact to the society. And now we will be having a live demo of what we have done till now in our project. So in the demo, first we are showing the music therapy. So the caretaker can play the music as per the requirement of the patient. And its volume, everything can be controlled by using the mobile app. And the next feature that we have incorporated is the RFID location tracking, indoor location tracking, in which whenever the tags comes in close proximity with the receiver, a notification will be come to the caretaker's mobile app.
It's time for food.
And now the day-to-day activity, it will provide such kind of information, such kind of audios will be played so that the patient can keep a track on their daily routines. And whenever the audio for medicine arrives, you can see there is a medicine dispenser is there, it will opens automatically.
It's time to take medicine.
You can see that
to take medicine.
the dispenser have opened automatically. Okay, that's all about our project. Thank you, and thanks for the patient listening. Thank you all.
Thank you, guys. So with that, we come to the end of the 3 paper presentations. I think all the students, all 3 batches deserve a good round of applause. എല്ലാ 3 ബാച്ചുകൾക്ക് നല്ലൊരു കയ്യടി കൊടുക്കാം. So now with that, we are going to enter the cultural event part of the evening. എല്ലാവരും മടുത്തോ? വീണ്ടും ചോദ്യത്തിന് ഉത്തരമില്ല. എല്ലാവരും മടുത്തോ? ഇല്ല എന്നല്ലേ കാണിച്ചേ? ഓക്കെ, അപ്പോൾ കുഴപ്പമില്ല. So we have a few cultural events planned. ഞാൻ ഒത്തിരി സമയമൊന്നും കളയുന്നില്ല. Very excited to announce the first event, the first program that we have. ആദ്യത്തെ ഒരു ഡാൻസ് ഇവൻറ്റ് പരിപാടിയാണ്. തിരുവാതിരയാണ് നമ്മൾ കാണാൻ പോകുന്നത്. And for that, I would like to call on stage Mrs. Kamala, who is a resident of Bliss Homes, Mrs. Nirmala, who is also a resident of Bliss Homes, Oppam Mrs. Sunita, Advocate Megha Chandran, Mrs. Diya, Mrs. Marlin, Mrs. Radhika, Dr. Ashwati, Miss Preeti, and Miss Neeraja. ഇവർക്കെല്ലാവർക്കും നിങ്ങളുടെ കയ്യടിയാണ് അവരുടെ എനർജി, നിങ്ങളുടെ സപ്പോർട്ടാണ് അവർക്ക് ഡാൻസ് കളിക്കാനുള്ളൊരു ഊർജ്ജം കൊടുക്കുന്നത്. അപ്പോൾ ക്ഷീണമൊക്കെ ഒന്ന് മാറ്റി വെച്ച് നല്ല സപ്പോർട്ട് കൊടുത്താൽ വി കൻ ഗെറ്റ് ത്രൂ ദ നൈറ്റ് ഹാപ്പിലി. സോ ഒന്നും കൂടി please give a good round of applause for the dance team that we're going to have on stage now. I believe I have a minute before everyone sets up. Avaru stage la ready avuna samayathu. You are not from Kerala, right? But are you familiar with Tiruvadira? You've seen it before? ഇവിടെ ആർക്കാണ് ജസ്റ്റ് ഒരു 2 വാക്കിൽ തിരുവാതിര എന്താണെന്ന് ഒന്ന് പറഞ്ഞു കൊടുക്കാൻ പറ്റുക? You have seen it as a tourist, so this is very personal. This is a little bit more close to your heart, I hope. ആർക്കെങ്കിലും 2 വാക്കിലൊന്ന് എനിക്ക് അറിയായിരുന്നു ഇവിടെ നിന്നായിരിക്കും വരുന്നതെന്ന്.
Tiruvadira is a Hindu festival. It demarcates the birthday of Lord Shiva.
അത് തിരുവോണമല്ലേ? തിരുവാതിരയാണോ? ഓക്കെ, അപ്പോൾ എനിക്കറിയില്ല കേട്ടോ. So I am also an NRI, so this comes from there.
Actually Adira, but then when you add respect to it, it becomes Tiru Adira. Adira and Tiru Adira. Okay, so they celebrate. Parvati did a long worship to get Shiva as the husband. So these girls are now the accomplices of Parvati, so that they get married.
Beautifully said. I did not know any of that. All that was new information for me too. So on that note, നിങ്ങളെല്ലാവരും റെഡി അല്ലേ? മ്യൂസിക് ഇടാൻ പറഞ്ഞോട്ടെ. അപ്പോൾ once again, please give a loud round of applause.
ഗിരീശ്വരന്റെ ചിന്തയിൽ മുഴുകി വലഞ്ഞു. നിദ്രനീങ്ങിയല്ലും പകരും മഹേശരൂപം ശൈലപുത്രിക്കുള്ളിൽ തെളിഞ്ഞു. പാർവണേന്ദുമുഖി പാർവതി ഗിരീശ്വരന്റെ ചിന്തയിൽ മുഴുകി വലഞ്ഞു.
Can we hear it once again for the whole team? What a lovely performance. And we're moving right along with a little bit of music. It's my absolute pleasure to have on stage Mr. Justin. Justin sir has been teaching violin and music for a long time. കുറേ ആൾക്കാരെ കുറേ സ്ഥലങ്ങളിലായിട്ട് സ്കൂളുകളിലും കലാഭവൻ പോലെയുള്ള സ്കൂളുകളിലും ഒക്കെ പഠിപ്പിച്ചിട്ടുള്ള ജസ്റ്റിൻ സാറാണ് ഇന്ന് നമുക്ക് വേണ്ടി പെർഫോം ചെയ്യുന്നത്. ഒപ്പം വി ഹാവ് അജയ് ഹു ഹാസ് ബീൻ എ സ്റ്റുഡൻറ്റ് ഫോർ ദ ലാസ്റ്റ് 5 years if I'm not wrong. Is that right, Ajay? Yes, okay. So both of them will be performing together for us. നല്ലൊരു കയ്യടി കൊടുക്കാം രണ്ടുപേർക്കും. Thank you, Justin sir, and thank you, Ajay. And now we have a fusion song performance by
for very talented women. And no, sorry, I have to correct myself, by 3 very talented women and a very talented gentleman. We have Advocate Aparna, Miss Rishma, Mr. Nikhil, and Mrs. Beena performing a fusion song for all of you. Meanwhile, I would also like to just let you know that the fellowship counters are open for those who are interested. We'll just give them a quick minute to set up. Are we good to go? അപ്പോൾ ഞാൻ ഒന്നും കൂടി സ്നേഹത്തോടെ വേദിയിലേക്ക് സ്വാഗതം ചെയ്യാണ് അഡ്വക്കേറ്റ് അപർണ, മിസ് രീഷ്മ, മിസ്റ്റർ നിഖിൽ ആൻഡ് മിസസ് ബീന. നല്ലൊരു കൈയടി കൊടുക്കാം അവർക്ക് എല്ലാവർക്കും.
Hello. നീലാഞ്ചനപ്പൂവിൻ താലാട്ടുഞാലിൽ തീവാരം നൽകുമി തങ്കക്കൈനീട്ടം. ചന്ദ്രനോ സൂര്യനോ പുലരിയോ താരമോ ദ്വാപരം തേടുമെൻ പുണ്യമോ കണ്ണനോ. பல பல ஓசை செய்திடும் ராவணன் ஈடில்லா என் மகன். கண்கள் நீ, காற்றும் நீ, தோளும் நீ, தோறும் வெள்ளி, வண்ணம் நீ, வானும் நீ, ஊனும் நீ, உயிரும் நீ. பல நாள் கனவே, ஒரு நாள் நிலவே, ஏக்கங்கள் தீர்த்ததே, எனக்கே பிடிது உன்னை நான் எடுத்தேன். நான் தான் நீ வேறில்லை. முகமெல்லைத்தான், அதில் முத்தைத்தான், ஒரு வெண்பாவை நான் சேர்ந்தேன் கண்டேன். இதில் எச்ச நீர் எனும் தீர்த்தங்கள், அதில் தீர்த்தங்கள் நீ செய்தாய் கண்ணே.
നീ മണിമുകിലാടകളാടിയുലഞ്ഞൊരു മിന്നൽ മിഴികളിലായിരം പരിഭവമോദിയ വേലിപ്പൂവിൻ നാണം
വെറുമൊരു നാടൻ പെണ്ണ് ഈ ഞാൻ, നിന്നിലറിഞ്ഞവൾ മാത്രം.
മണിമുകിലാടകളാടിയുലഞ്ഞൊരു മിന്നൽ മിഴികളിലായിരം പരിഭവമെഴുതിയ മേടത്തിങ്കൾ ചന്തം വേലിപ്പൂവിൻ നാണം. ദൂരത്ത് കണ്ട അറിയാത്ത ഭാവം മരികത്തു വന്നാൽ അതിരാപ്പാൽക്കുടം മുള്ളുള്ള വാക്ക് മുനയുള്ള നോക്ക് കാണാത്തതെല്ലാം കാണുവാൻ കൗതുകം ഉലയുന്ന പൂമേ മദനന്റെ വില്ല് മലരമ്പ് പോലെ ചിറകുള്ള നാണം വിടരുന്ന പനിനീർ പരുവം മനസ്സിനുള്ളിൽ.
ഹേ സലോമ സലോമ സലോമ, ഹേ ഹേ സലോമ സലോമ സലോമ, ഹേ സലോമ സലോമ സലോമ, ഹേ ഹേ സലോമ സലോമ സലോമ.
I'm thinking of you. I'm thinking of you. ഇളമാൻ കണ്ണിലൂടെ I'm thinking of you. ഇളനീർ കനവിലൂടെ I'm thinking of you.
മിഴിയോരം നിലാവലയോ, പനിനീർമണിയോ, കുളിരും മഞ്ഞിൽ വിരിഞ്ഞ പൂവേ, തീരങ്ങൾ കടം വാങ്ങും ഓരോ രജനീയാമം എങ്ങോ പൊഴിയും നേരം എന്തേ ഹൃദയം തേങ്ങി മഞ്ഞിൽ വിരിഞ്ഞ പൂവേ പറയൂ നീ ഇളം പൂവേ മിഴിയോരം നിലാവലയോ മണിനീർമണിയോ കുളിരോ മഞ്ഞിൽ വിരിഞ്ഞ പൂവേ പറയൂ നീ ഇളം പൂവേ മിഴിയോരം നനഞ്ഞൊഴുകും മണിനീർമണിയോ കുളിരോ മഞ്ഞിൽ വിരിഞ്ഞ പൂവേ പറയൂ നീ ഇളം പൂവേ ഉറങ്ങാത്ത മോഹം തീടും ഉഷസ്സിന്റെ കണ്ണീർ തീരും കരയുന്ന പൈതൽ പോലെ കരളിന്റെ തീരാതാകും കനൽ തുമ്പി പാടും പാട്ടിൽ കടം തീരുമോ തീരിറങ്ങും മുകിലേ മഴത്തൂവലൊന്നു തരുമോ നോവലിഞ്ഞ മിഴിയിൽ ഒരു സ്നേഹനിദ്രയെഴുതാൻ ഇരുൾ മൂടിയാലുമെൻ കണ്ണിൽ തെളിയുന്നു താരനിരകൾ താങ്ക് യു താങ്ക് യു
എല്ലാ മൈക്കും അവരുടെ കയ്യിലായിരുന്നുകൊണ്ട് എനിക്ക് മൈക്ക് കൈ കിട്ടാൻ ഒരു ഇച്ചിരി വൈകിപ്പോയി, അതുകൊണ്ടാട്ടോ 2 സെക്കൻഡ് ഡിലേ. ബട്ട് നിങ്ങൾ ഓടി ഓടി പോകണ്ടായിരുന്നു. ഐ വോണ്ടഡ് യു ടു വെയിറ്റ്. പ്ലീസ് ഗിവ് ദം എ ഗുഡ് റൗണ്ട് ഓഫ് അപ്ലോസ്. നല്ല ഭംഗിയായി 4 പേരും പാടി. നിങ്ങളൊന്ന് ഇങ്ങോട്ട് വന്ന് നിൽക്കൂ. ഞാൻ നിങ്ങളോട് കയ്യടി വാങ്ങിച്ചു തരുന്നതിന് മുന്നേ തന്നെ നിങ്ങൾ സ്റ്റേജിൽ നിന്ന് ഓടിക്കളഞ്ഞു. സോ all 4 of them sang very, very beautifully. I think we can all give them a good, loud round of applause. ഉള്ളീന്ന് വരട്ടെ, മനസ്സിന്ന് വരട്ടെ. Okay, thank you so much, guys. So on that note, officially ഉള്ള cultural events എല്ലാം കഴിഞ്ഞു. And I'm saying officially because I know that there are a lot of talented singers here. കുറേ ഇവിടെ പെർഫോം ചെയ്യാൻ ആഗ്രഹമുള്ള ആരെങ്കിലും ഒക്കെ ഉണ്ടാകും എന്ന് എനിക്കറിയാം. സോ ഇഫ് എനി ഓഫ് യു വുഡ് ലൈക്ക് ടു കം ഫോർവേഡ് ആൻഡ് സിംഗ്, ദ സ്റ്റേജ് ഇസ് ഓപ്പൺ. പ്ലീസ് യു ക്യാൻ ഗെറ്റ് ഇൻ ടച്ച് വിത്ത് മീ ഓർ എനിബഡി ഹിയർ അറ്റ് ദ കൺസോൾ. For everybody else, please be on time. And on that note, have a wonderful evening. I'm signing off. Thank you.